Good morning, respected dignitaries, esteemed faculty, and dear colleagues. It gives me immense pleasure to welcome you all to EFIAGES-2026, a fellowship program in endoscopy, bringing together experts and learners across the country. Endoscopy has revolutionized the way we diagnose and manage gastrointestinal diseases, transforming what was once major surgery into minimally invasive, highly precise interventions. It is a field that beautifully combines technical skill with clinical judgment, demanding both dexterity and deep understanding. From diagnostic visualization to advanced therapeutic procedures, endoscopy continues to push boundaries of modern medical and surgical practice.
So as we start today's session, I would like to welcome Professor and HOD Dr. Sibu Prasad Patnaik sir to the dais to formally address the gathering. Thank you.
So good morning everybody, respected dignitaries, guests, faculty members and delegates. It's indeed a great pleasure on my part, and I consider it to be a blessings of Almighty that we are able to hold this prestigious conference at MKC Medical College, Berhampur. Within a very short span of time, after the undergraduate examinations were over, within the last 3 days, we could organize such a thing, and because of the commitment and dedicated effort of some of my colleagues, we are able to organize this thing. And I hope this will go smoothly because of all your respectable presence and active participation and a meticulous program which has been designed by the association. Thank you.
Thank you so much, sir, for your kind and encouraging words. With this, I would like, it is my honor to invite Dr. Aigopal sir to the dais for the welcome address.
So good morning everyone. My pranams to all my teachers, distinguished guests, my colleagues and dear students and delegates for this workshop. So when we think about endoscopy, as I used to think when in my earlier very days from 10 to 15 years back, because of my guru over here, sitting over here, Prabhat Panigiri sir and all, when we thought about doing endoscopy, a surgeon doing endoscopy was limited to certain sorts of diagnostic purposes or just to, if I'm not wrong, to get some money for doing one endoscopy for some price, we used to do endoscopy like that. But then I trained myself at Apollo Gleninges, and thereafter I was secretary to ASI Orissa State chapter, and then I joined IAGS. The first time I had gone through this workshop at Rajahmundry, we did our fellowship course over there. After that, we deep dived into that, and the spectrum opened up. And then we took up endoscopy as a surgeon in a different way. So it's not just about, we often think about for the young people, young delegates who are coming over here, you should think that this is no more a diagnostic gastroscopy or a routine colonoscopy that you're going to do. And you have to think that these scopes are now being transferred from the diagnostic labs to your OT theaters. So there's a lot of shift of the way we are taking up endoscopy in our daily practice. So it's not, as we have seen, minimal access surgery has taken a lot of momentum, like the way what laparoscopies which we haven't seen 10 to 15 years back, even when we are doing a post-graduation. Now it's totally, laparoscopic unit is totally a normal routine for every surgeon. So is endoscopy that is coming up in that way. So this landscape of 2026 demands that we as surgeons should master both this traditional and these non-invasive methods, and you have to adapt this one. So this training program that we have designed is only to make you to put in the first stepping stone and to have the scope in your hand first, so that it's limitless. Like Therapeutics, we have flexible endoscopies. Even though it was first managed by gastroenterologist, probably we as surgeons we took it up because of our training in anatomy and in our ability to do tissue handling, allowed us to push the scope further into doing therapeutics. And because of therapeutics, complex therapeutic procedures, like now almost we are doing the CMR, ESD, EFTR, POEM, third space endoscopy, name anything, even for diagnostic purposes, even for staging, as we are reading in a seminar and all from endoscopic ultrasounds, a lot of things have changed, including narrowband imaging, which we have in our institute also. So all these things have changed the spectrum of the way a surgeon has to approach these diseases. Probably by now our postgraduates know that the way we are doing our GA surgery cases, we are doing our own endoscopy, we are seeing our tumor itself, we are seeing what its histopathology is like, we are seeing whether how much it is resectable or not. A lot of things have come up. Added to that, still there is a lot of scope, and this era we are already getting into artificial intelligence, robotic endoscopies, a lot of things are coming up. So everyone has to be get tuned up, and probably this will be the first stepping stone into it. So welcome you all to this from the side of the organizing committee. We tried our best into making up this academic session a good feast. If there are some lacunae, please pardon us and try to adjust up within us so that we'll make by the end of this day, we'll make up a good academic event. Thank you so much, sir.
Thank you so much, sir, for the welcome address. To mark the auspicious beginning of this academic program, we now proceed with the ceremonial lighting of the lamp. The lighting of the lamp symbolizes the dispelling of darkness and the pursuit of knowledge, wisdom, and enlightenment. I now request all the chairpersons and speakers present here to come to the dais and light the lamp to begin today's session.
Course coordinator, start the course. Sir, ready, sir. 2 minutes. Online class. Sir, contact number.
Now, with great privilege, I invite Dr. Satyapriya De Sarkar sir to the dais and inform the gathering about today's proceedings and the endoscopy course. Over to you, sir.
Respected Dr. S.P. Patnaik, Dr. I. Gopal and Madhuri and all the team. We started in 2016 first the courses. Me, Ishar and Govindaraj maybe 25 times we have conference call and we made the syllabus, and then from very start Dr. Vijay Bargaonkar, Dr. Satish Midda, we are a very small team who started all this program. I think this started in 1990 when I was doing my MS in SSKM. We went as surgical PG to the gastro department and we were just thrown out. They said, first you should know how to stand, then you should walk. So from that day we thought that no, someday our surgeons will do up this thing, and few days back in our global endolaparoscopic world conference of TUGS, me, Arunima and Rathore were there as speaker. So I think it's a long walk from that post-graduation refusal to just see, just look into that, not doing question anything. I thought that yes, everybody can learn, whatever be there. And a student has I think the best thing of a student is his intensity to learn, not only something new he should do. Now really world has changed, and I'm there last 7 years, continuously I'm there National Endoscopy Board Chairman and convener now. Now with me, Arunima and Gunabi has also joined, and our whole team. We really work like a family, not in words but in deeds. We covered each other, then we started a long way from those diagnostic world and now to the real therapeutic world, and now really internationally many of the times we are in our SARC, Bangladesh, Pakistan, Nepal, Sri Lanka, all those places we are their international faculties to their universities. So it's nothing personal, I think it's a whole endoscopy team. As the surgeons, we should be allowed. And then individual talent, individual passion will take you to the heights which you deserve. Nobody knows the boys who are here where they will reach. As I never dreamed of reaching any world conference as a speaker during those days when we are ridiculed, the surgeons are coming to do endoscopy. I think all of us, those who are almost contemporary, they know the struggle we made. But again, those days are over. Now we have a very excellent team. And again, I say that Ishar, I am missing him very much, because we too, around 2,500 Indian surgeons we have trained, and then we asked for our endorsement from the Edinburgh Royal College. And they said that they have sent us a Google form. I think this little history you should know. And then we send it to all the EFIGS people, what they were doing before and after. Everybody filled it. We have sent it to the Edinburgh Royal College of Surgeons. Then they said, this thing you should publish in any index journal. Then as a paper that we published. And then Edinburgh Royal College gave us an endorsement of our course. So it was really, we struggled, we persisted, and we have a hope, okay, let's try. If it failed, nothing to lose actually. And then in their annual conference in Edinburgh, we all were, many of our friends were there, and we have given the lectures there. I was their inaugural speaker to talk on the endoscopic management of Barrett's mucosa. So again, I am saying absolutely nothing personal, any achieving anything. It's a group thing, and it started from the first colonoscopy, first stenting of CBD, first our PEG, first many of the first our poem, all were done by the surgeons internationally. So surgeons have done historically the pioneering work in the endoscopy. So we are giving all respect, because in West Bengal also, I'm the only surgeon who was there twice, president of their gastro association. So that's again a rare thing. My friends have learned a lot from the gastromedicine people. So I have all respect for them. There's no question of any competition with anybody. We have a huge country, 140 crores. So together we'll serve them better. With each course, we learn a lot. There's no end to learning, that we all know, and it's evolving science. So next, you people will come, our days are going to end. So you people will take it to that level where nobody can disown you. I remember performance, I tell you, is the only thing. Those people ridicule, they make you faculty, they give you so many other prestigious things. So you go on, you don't think whatever who says. Think about the patient, think about your skill, and you be humble, be down to earth. We're not doing anything great. We're just trying to do within our immense limitation what we can. So with these words, I feel you should be proud of EFIAGES. And the first speaker who is there, Srijay. Srijay was also one of the pioneer person. In our first EFIGS course also Srijay was there. Sunil Popat was there. Few of them, and like Satish and Vijay, they have all started in their states first time. All these endoscopy, RCP things. So it's a great moment for me to be here, the prestigious MKCG Medical College, Berhampur. And without wasting any more time, I request Madhuri to contact Dr. Srijay. He has somehow, because of some emergency, okay, so he is waiting there to start there. All the best wishes from our whole team, and go to the top. Sky is your limit. Thank you.
अब शेयर कर दो स्क्रीन मध्ये दिले शेयर केलं.
With this, it is my great privilege to introduce our chairpersons for the first session. Dr. Sivaprasad Patnaik sir completed his MBBS and MS from MKCG Medical College, Berhampur. He further advanced his training with a fellowship in GI surgery from the prestigious Sir Gangaram Hospital, New Delhi. Adding to his distinguished academic journey, he was awarded a WHO fellowship in GI oncology from the renowned Kidwai Memorial Institute of Oncology, Bangalore. With extensive training and expertise in gastrointestinal surgery and oncology, he brings with him a wealth of knowledge and experience. We welcome you to the dais, sir.
It is now my privilege to introduce our next chairperson, Dr. P.K. Kar, sir. Sir currently is the president of ASI for 2025, a testament to his leadership and immense contribution to the surgical community. He has previously held the important
शेयर
position
किम करवी
of CDMO Ganjam, reflecting his dedication to public health and
मु
administration.
किम शेयर करिलो
A
तमारो
highly
करियो
experienced senior surgeon, he brings with him
मु किम
extensive
करियो को
experience
मु जानी नहीं
in both general and laparoscopic
ये
surgery
चेंज है
and has been instrumental in advancing surgical care in this region. We are truly honored to have you
नहीं
with
तो
us, sir.
मोर अच्छे लिखाई छी मोर लिखाई छी मोर record show of captions documents whiteboard एमती नुआ चेंज है ना तेरा किम शेयर किम करवी मु जानी पड़नी हैं
With this, it is my great privilege to introduce our first speaker, Dr. Srijoy Patnaik sir. Is currently the director at Shanti Memorial Hospital, Cuttack, and a highly respected consultant in minimal access surgery and surgical gastroenterology. He has been a pioneer in advancing laparoscopic and bariatric surgery in Odisha, significantly contributing to the growth of modern surgical practice in the region. His leadership and organizational excellence are reflected in his role as the organizing secretary of the 16th IAGES and the 79th ASICON in 2019 at Bhubaneswar, as well as serving as the joint organizing secretary for the ASICON 2007. We welcome you to present the talk on endoscopy hardware and room setup. Over to you, sir.
So we warmly welcome you. Sir will be joining us online.
ना शेयर की जो शेयर अच्छी शेयर कर ली ହେଲା ହଉ 1 second ହେଲା thank you I think I am audible. Hello, am I audible?
Hello. Yes, sir, audible.
So why the slide is not going. Good morning, everybody, and first of all, welcome, Sir Dr. Shashit Midla, President. Satyaveda has already spoken so many words regarding me, and Dr. Vijay Borgaonkar, my elder brother, is also there. They are all my elder brothers. Thank you for coming to Berhampur for this EFIAGES meet, and I am really sorry I could not make it because due to some unavoidable emergencies in the hospital. So I'm opening the inning. Thank you, Madhuri and Aigopal and the team at EFIAGES Berhampur for giving me an opportunity and allowing me to open the innings with this very simple topic, this endoscopy hardware and room setup. So before you start an endoscopy program, you need a hardware for starting your endoscopy program. You need endoscopes. For endoscope, only the flexible, and they are mainly flexible. For that, you need light sources, video processors, monitors, insufflators, suction, and irrigation systems. On the right, you can see this is a Fujifilm. This endoscopy system. This is the monitor. They are all video endoscopes now. Earlier, we were just watching through the objective lens, but now they have video endoscope. It has become, they are almost 4K, and the resolution is almost superb, excellent, what we were seeing in our days. These are the types of video endoscopes, mainly what we will be dealing. Now we are dealing with upper GI here, then colonoscopy. Then when you start doing ARCP, you need a duodenoscope. For seeing imaging and for processing an image, you need good quality camera systems, high definition 4K. Now they have come up and they have a superb image processor. They have got good recording systems. And there are also AI assisted modules now available with Olympus, Fujifilm, and Pentax also. Also, along with that, once you do diagnostic, then you come into therapeutic accessories you require, like a biopsy for at least when you see a lesion or a tumor or something, you need to use these accessories wherever possible by doing a normal endoscopy. So this is the video endoscope parts. This is a video or upper GI endoscope what we are talking about. It has got 3 parts, which is the control head. I'm showing here, this is the control head with the heart of the scope, and there is an insertion section which goes into the patient, and the umbilical cord which connects to the processor. The control head is very important. It's almost the heart of the scope. It has got 2 wheels, 2 locks, 2 buttons, and some additional functions. So what are the 2 wheels? One is the big wheel and one is the small wheel. You can see the bigger wheel, you're holding with the thumb, and this is the smaller wheel. Right and left is written, Down and up is the bigger wheel. This is the smaller wheel. And this is the smaller wheel is this one. This is the bigger wheel, this is the smaller wheel. So how does these wheels work? They have got angulation wires, and this angulation wires just works like a pulley. So when you pull this wheels, this almost works like a pulley, and there's a bending section, and it bends the insertion section either upwards, downwards, or left or right. So it has got a right and left pivot pins here, and and rings here, and end of the angulation wire. This is how it works. Sorry, it's not working. Then coming to the function of the buttons. There are two buttons, the superior button and the inferior button. Superior button is red in color, inferior button is blue in color. So what are the function of the wheels and the buttons? The superior button, the red one, is for suction. The inferior button, the blue one, is for insufflation of air and installation of water. Then coming to the wheel, if you pull towards you, the scope looks upwards, and when you turn the wheel away from you, the scope looks downwards. Similarly, the smaller wheel, if you pull the wheel away from you, it turns to the right side, and when you move towards you, it moves to the left side. So left, right with the small wheel, and the big wheel make movements of upwards and downward movements only. There are suction channels which must be capped for all while doing suctions. It is connected to the external pump, the normal suction machine which you use in your surgical practice, day-to-day surgical practice. So when you press this button, red button, then the suction starts. You start doing the suction. The other one is the blue button. I'll explain you next slide. This is the blue button. It's connected to the water bottle which comes with the endoscope. It's connected near the processor, and there is an air pump also connected to it. It is inbuilt air pump is there. So when you just put your finger on that blue button, the air starts coming in. It inflates the stomach, and when you press, then water is comes out. These are the fundamentals of air feeding. Here is the scope tip on the left side, and here is the processor end. So once you press the blue button, what happens here on the left hand side? Once you touch it, the air comes into picture. When you press it, water comes out. Water feeding takes place. So the anatomy of the endoscope is very intricate inside, and it has got all these functions. There's the suction valve, there's the air and water valve, there's the biopsy valve, there's the insertion tube, and there's the nozzle. And all this are connected via the cord, umbilical cord, to the processor. And this is a water bottle, this is a suction connector, this all channels which are coming in, and all are interconnected to the processor. So green is for suction and access channel, the green channel. Blue is the water jet, and white one is the airflow. What is the mechanism of electronic video endoscope? They have got CCD cameras at the tip with an objective lens. They are connected through cables, and this the yellow one is the light. The light passes on, and the image what is captured from this objective lens through this charge coupled device through these cables goes to the video processor, and the image is processed and is transferred to TV monitor where you can see. These are the CCD charge coupled devices at the tip of the scope. This is the objective lens. This is the light gate bundles, the two light gate bundles, and this is for biopsy, and this is for air water channel. When you start doing your endoscopy practice, you should use this one, the TV screen, you should consider it as a clock, or endoscopic clock, what we say. And 12 o'clock is always upwards. We name it at 12, 3, 6, and 9. Whatever you see on the 9 side, accordingly you plan, accordingly you just collaborate with the anatomy inside. Now coming to the scope tip. The scope tip has got light guide cables. As I told you, 2 light guide cables. This is the objective, this biopsy channel, and this is the air water nozzle, and this is the water jet. And you see at the tip of the scope. And it has a commendable compact design. The outer is a polymer cover with a outer spiral metal band, followed by inner spiral metal band. And these are all integrated with stainless steel wire mesh through which this light guide fibers pass, and wires for adjustable stiffness are there, which makes it otherwise it will break inside. And these are the channels as I told you, and there are also this angulation wire that helps in bending the incision section. Now endoscope, the highly recommended are this Olympus. You can buy the Pentax or Fusionon. They are all 4K HD and with all important features. All endoscope, HD endoscope have got pristine pictures because of their pixels. Image are sharper and richer. This is the SD vision, this is the high definition vision. They're much sharper and richer. And this importance of image enhancement is due to white light endoscopy, chromoendoscopy, NBI. This I won't speak. They will be speaking in when they are speaking on pathology of those the lesions. Now, image enhancement techniques also there with narrow band imaging, eye scan of Pentax, FICE of Fusionon, and the magnification endoscopy where you can watch the pit patterns when you are doing endoscopy for the lesions. Coming to the suite has to be made. If you want to start your endoscopy practice, you should have ideal endoscopy suite, because now the present generation you need to attract patients where having a wonderful endoscopy suite where you will be doing mainly upper GI or at least colonoscopy there. You should have a reception area. This is the reception, this is the waiting area. Then you can have 1 or 2 consultation room depending on the size of your suite. And this is the counseling where you start doing a counseling, then you prepare the patient, then the dress changing room, and you can have 2 rooms, one for upper GI and colonoscopy separately. And you can have a cleaning and disinfection which is a must, and the storage area. And you can keep, once you finish, you can just store your accessories here. There should be always a counseling area and billing area. The staff room, audiovisual must in all endoscopy, and again the billing and the patient can come from your, if you have got an indoor setup, they can come from the IP or from the emergency, or if you are only dealing with OPD patient, then the OPD patient will come to you. This is the colonoscopy room layout. This is how you should you should have an adjustable endoscopy table which can go head down or head up with all positions. You should have always oxygen and suction access inside your colonoscopy or upper GI endoscopy room. And it should be a wash area, and the surgeon should stand on the right side while doing colonoscopy with 3 assistants. Here's the monitor, 2 monitors at least, one facing the surgeon and one facing the staff. The staff will of course should be entry, preparation, procedure, then there's recovery. There should be minimal cross contamination. You should have staff with defined roles assigned to them. Infection control is a must. After every endoscopy, you should disinfect, clean the endoscope before putting the next patient. Use PPE when we are dealing with HIV patients or osteoarthritis positive patients. You should have a scope reprocessing protocol, and you should do surface sterilization of the entire colonoscopy room once a week at least. Safety measures should be always be there. You should have emergency crash carts, defib monitor, fire safety devices, electrical safety. Ergonomics monitor should be at the eye level. You should have proper scope handling and staff posture. Checklist before procedure. You should check equipment check, patient consent, sterility, ensure team briefing. Coming to the storage, you should have an adequate storage area where you can put your endoscopes and accessories. These are very important and very costly also. And they have got even now endoscope storing areas are also available in the market. We can buy and put, suppose you have got two scopes, you can buy a storage area which has got a capacity of storing two scopes, three scopes, or 6 to 8 to 10 scopes. Then coming to documentation, printing, reporting is very important for because patient record is you can put it in the computer, all whatever you're doing, endoscopy, colonoscopy, ERCP, and you can publish with these videos in YouTube channels or in the media and make presentation also. And this should be integrated to the hospital software. And you need there are a lot of applications available in the market where you can put in your laptop and keep on storing your still pictures and videos also. And you can integrate with your hospital information system. Now, value of training is credentials are very important, and as you all know, I is a large body of endoscopy and laparoscopy surgeons of India, and this endoscopy fellowship program will definitely help you in learning the basic and diagnostic therapeutic endoscopy. There are other programs, endoscopy programs, which Dr. Satyadev Sarkar will explain to you. And and it's very nice to hear that so many students have members, surgeons have joined today for this course, and I think in future also will grow in large numbers. And we have, as surgeons, we have excelled in every aspect of endoscopy, and we see that our numbers grow in future. There are a lot of training opportunities in IHS, EFIGS, FASI, and single theme courses. And we have got Society of GI Endoscopy of India also, ISG also, and overseas affiliation also. So for to conclude, a well-designed endoscope suite improves safety, efficiency, and outcomes. Thank you very much. Am I audible?
Hello.
Now I can see everybody. Am I audible?
Am I audible?
Yes.
Acha. Is there any question from the audience? Any questions? I think, Srija, you are so clear about your talk that there is no question from the audience.
Thank you.
And a big thank to you.
Thank you. I'm really sorry for missing you all. I should have been there, and the last minute dropping out. So I'll be missing you all. In future, I'll definitely join any of the programs.
Thank you so much.
Thank you. Can I leave now?
Yeah.
Thank you so much, sir. It is now my pleasure to introduce our next speaker, Dr. P.K. Panigrahi, sir. He holds an impressive array of qualifications, including FAIS, FMS, and FIAGS, reflecting his strong academic foundation and continued commitment to excellence. He is an experienced surgeon in gastrointestinal and minimal access surgery with special expertise in hepatobiliary surgery and endoscopy. His proficiency extends across both diagnostic and therapeutic endoscopic procedures, making him a well-rounded expert in this field. We are honored to have him with us today to present the topic endoscopy, when to do and not to do, and about informed consent. Welcome, sir.
Thank you for your kind words. Respected dignitaries, invited national faculty and faculties of MKCG and other invited guests, fellows and delegates. Thank you so much for giving me opportunity for this talk. This is one of the most important academic activity which is included now in surgeons careers also. Thank you so much. Next. Gopal. I was assigned to talk about when to do endoscopy and when to not. Uh, next. Next. Okay. When to do endoscopy? First, Srijal sir has already given the prerequisite requirements. Now I will tell about the introduction in three headings, mainly indication, contraindications, and surveillance. Mainly indications are for diagnostic, surveillance, screening of high risk persons, and most recent, this is therapeutic. The diagnostic indications are dyspepsia, dysphagia, GI bleed, unexplained weight loss, anorexia, sometimes with fever,
Good morning. Satpriyog, I can see Satpriyog. Can you hear me?
Sir, you are not audible.
Am I not?
Now you are audible, sir.
Thank you, thank you, thank you. Good morning. I hope all of you can see me. And it's very first, I wanted to thank the team Berhampur, the Silk City, Gopal and his team. I think I can see from the morning the pictures and the dinner they had. I think I missed a very important event. I think, because of I'm en route to uh, Indore for a marriage, so that's why I couldn't be. Otherwise, I never miss a chance to be with all the people. Especially, we've been doing this the last 10 years, thanks with Sri Joy, Sir Das, when we started in Orissa way back 10 years ago. Now we have trained more than 3,000 people in the art and science of endoscopy. I think the flag is now taken by eminently by our Saturiyu as a chairman. And I can see Vijay and Satish, in spite of their busy schedule, they are here in person to share the knowledge, and Madhuri for coordinating from day one for an excellent program. So let me just share with you. I think I was listening to Sri Joy, and I'm sure both the topics, the anatomy of the endoscopy has been described, and you know when to do. Now my job is to say how to do. So I take the liberty of taking about 25 minutes to share whatever I could share with you. Let me just bear with me. Can you just allow me to share? It says it is not letting me to share the screen for some reason. Yes. Can we see the slides? Just if you are saying okay, then I'll just proceed.
Okay, sir, we are able to see.
Okay, just bear with me. I just want to see.
Are you able to see the slides from your end?
Yes, just a minute. I just want to make the slide. So, can you see the full slide now?
Yes. Very well.
Okay. Thank you. Thank you very much. It's very indeed a great pleasure to be interacting with you all. And my dear friends and all my delegates for EFIGS and also the postgraduates, I just to take it, some of you may be already doing a little bit of endoscopy, but most of you wanted to start the endoscopy. So we'll keep it very basic today and how you start your journey as an endoscopist from the surgeon's perspective. Because first of all, we should understand clearly the three major parts of the endoscopy. Of course, the control head in the middle, which you are going to hold with your left non-dominant hand, the insertion section, which you are going to have it in your right hand, the umbilical cord, which is going to the processor. The very important two numbers you remember for your lifetime. The scope is as little as your little finger, that is 9.2 millimeter diameter. So it is so tiny, delicate. You can do endoscopy, even though it is meant to be an adult endoscopy, you can do in a child as young as 1 year onwards if they're present with a foreign body like a coin. So that's the first thing I wanted to tell you. There is no need for a child endoscopy, even if they're one. Less than one, probably you may have to go for a 6 millimeter scopes are also available. Number two is very important. Another number you remember is the biopsy channel diameter is 2.8 millimeter. So you need to make sure whatever accessories you are having, it's compatible with this particular biopsy channel, because sometimes the colonoscopy accessories may not be passing through this. That's the second important thing. And we'll come to the rest of the things in a minute. The rest is, for example, you are seeing me in the monitor now. You treat the monitor like a clock henceforth. Like if I say that you just see a lesion towards 3 o'clock, that means 3 o'clock is on your right side, 9 o'clock is on your left side, and 12 is up, and 6 is downwards. So if you have that Then when I speak anything to describe any lesion, you'll be understand and to follow my language. That is a very important first point I wanted to tell you. For example, if I say, if I insert a biopsy forceps in a Olympus scope, it comes in a trajectory of 7 o'clock as shown here. Whereas same thing if it is in the pendex endoscopy, it will be coming around 5 o'clock. So the clock position is important for understanding the navigation. Equally important is how you hold the scope. The scope is less than 2 kilos in weight. It is very, very lightweight thanks to the technology. And this is the way you are expected to hold in the first web space in your left hand like this. And you dedicate the thumb for movement of both the big wheel and small wheel. And allocate your two fingers, mainly the index finger and the middle finger, to control the buttons in the front, and the rest of the two fingers for embracing the scope like this. So if you do that, then you will do all the important functions as I'm going to describe. For example, I'm sure Srijoy has clearly explained the control head has four important things: two buttons and two wheels. The two button, the superior button coded red as you can see, inferior button coded blue. The bottom button is blue, the roof button is red. You remember that way. The superior button is very important. The moment we press the superior button like this, you know what should happen. So it sucks the fluid, of course. So superior button is meant for suction, as color coded in the red here. As you can see, the suction from the scope tip, the fluid will be sucked from stomach, for example, all the way into the central suction bottle like this. It'll go. But very important point I wanted to tell the beginners is the suction button, channel, it has the same channel as a biopsy channel beyond this. So the moment you put a biopsy forceps of 2.8 millimeter here, or any instrument for that matter, the suction will not be efficient. Very important thing for you to understand. So the efficiency of the suction is you should not have any accessories in the access channel when you actually wanted to suck. For example, you may be trying to inject something and there is a bleeding. You need to take the injection needle out, then do the suction. This is a small problem in the upper GI endoscopy. The second thing is the cap in the access channel should be airtight. Even if it is a little loose or has a small hole in it, the suction may not be efficient. So if the suction is not working, two things you check: whether the cap is tight enough, whether you have any accessories inside, then you remove it. So these 2 points I wanted to tell you. The inferior button is a engineering marvel. Why I'm saying so? Because it has two very important function it does just by placing your finger or pressing your finger. For example, this inferior button has a two channel, but final channel is single, of course. So what it does, if you just place your hand, it insufflates. If you press the button, it instills water. Inferior button, the mnemonic I for eye, you remember. Insufflation is a very important thing, then only you will be able to inspect the stomach. For example, normally when you switch on the machine, continuously air will be coming and leaking through the inferior button like this. The moment you place your hand like this or a finger like this, what will happen? The air is prevented from coming out, so it continues to pass right to the very tip of the scope by opening the channel like this. So you'll have a bubbling, like insufflation of air will be happening. So only if you put the finger, the air will be coming, otherwise it will not happen. So that is very important, is you maintain this for a continuous insufflation for a successful navigation. What about if you have some smudge in the lens, you want to clean the lens, of course, like a wind mirror, you need to clean with the water. So the same button, instead of like this, where the water is prevented to flow, if you press the button like this, the hole will be in alignment here. So you'll be able to get installation of water, which may be required now and then. So if you understand how the buttons functions, that makes off the job for the beginners. The next important thing is how carefully you need to keep the endoscopy, because the pricey part or the most expensive part of the endoscopy is actually right at the tip of the endoscopy. See, for example, this is the cross section of the more modern video endoscopy, wherein if you switch on the light from the xenon or LED, it will come through this yellow channel like this, and it will illuminate the stomach. The reflected light from the stomach or esophagus, wherever it is, it will fall back on the objective lens at the tip of the scope. Just behind the tip of the scope, as you can see, there is a CCD chip. The charged coupled device converts the image immediately into pixels. That pixels only travel, the cables only take, there is no optical fibers, unlike in a fiber optic endoscopy. So in other words, the video endoscopy is full of cables, so it has to be waterproof. So this, unless we do a leak test, make sure it is waterproof, there is every chance that all the cables can be immersed in the moisture and can be damaged. So this chip is actually at the tip of the scope. That's why we need to be very protect the tip of the scope not getting damaged when the patient is biting. So you need to put a mouth guard in order to take care of not only the patient teeth, but also the chip at the tip technology. So unlike a laparoscopy, probably you know where we put the camera right at the head of the laparoscopy. Here the chip is right at the last 1 or 2 centimeters of the tip of the endoscopy. So that's the final point I wanted to tell you about the anatomy. Coming to the rituals, see, we do endoscopy hundreds of cases every day, but still what is important is never forget to do these 2 steps in each and every case, however experienced you are. One is called endoscopy checklist. The analogy is a pilot in a plane. Half an hour before we board, the pilot is already sitting in the cockpit. What they are doing, they check each and every gadgets in front of them, make sure everything is in order before they start the plane. So that is the safety mechanism. Same ritual, same analogy or mindset you should have. You have to check the endoscopy, the suction is working, air is insufflating, everything is ready. So there is a ritual steps. I'm sure our team, they are sitting, they will be demonstrating when you have a live session is going on. So the endoscopy checklist is not optional. It is very essential before every case. That is called a 6-step cockpit drill. Okay. The second important thing is, just before me, the previous lecture, very important is you should know before you start doing a patient checklist. Why I'm doing a procedure in this? Is this a case of dyspepsia, dysphagia, or a GI bleed? Only if you know the indication, accordingly, you can think in your mind what pathology is likely to be found. So you know the indication, make sure there is no obvious contraindication, try to understand whether the patient is on any drugs. For example, we follow 5-day rule for all double antiplatelets. If the patient is on double antiplatelets, if the indication for endoscopy is a very soft indication like simple dyspepsia, I would rather wait, get the cardiologist opinion, and probably stop the drug, probably the clopidogrel, for at least for 3 to 5 days before you do an adjustment, because you never know if there is a bleeding lesion or if you have to do a biopsy, there is undue bleeding that is medical legally not advisable. Like that, you should know various drug history, whether the patient is on anti-epileptics, anti-diabetics. For example, anti-epileptics, they have to take anti-diabetic oral drug, they should stop in the morning, otherwise they become hypoglycemic even during the procedure because they are fasting for 12 hours. So all those things are very important for whoever is doing the checklist. But most important thing is endoscopy is like a surgery. You need to take a written legal document, like a signed document, after giving them all the details they need, why you do, how you do, what's the outcome and things like that. And though I say 6 hours fasting, personally I feel overnight fasting is ideal. And of course the last one is you ensure there is no loose teeth or a denture, because the last thing you want is patient saying after the end of the procedure, I have missed one teeth, what happened? So you always worry whether it is gone inside the lung or anything. So you have to be ensure all these 6 important checklists also adhere to. Now let us go into the navigational skill. Unlike a laparoscopy, here endoscopy is like a snake. It can go in a combination of 3 important movements. You move the wheels, or you turn the scope insertion section clockwise, anti-clockwise. You adjust your body. So these 3 in various combination helps the tip to navigate wherever you want to. So the tip of the endoscopy should listen to you depending upon what you do with the wheel, with the insertion section, with your body. Let me tell you one at a time. First of all, the wheel. I already told you there are two wheels, the big wheel and small wheel. They follow the green arrow. If you turn the big wheel towards you, okay, with your thumb, what will happen is you'll be going more and more towards 12 o'clock. In other words, this biopsy forceps will move like this. So you'll be watching a lesion more towards 12 o'clock, looking upwards. In the same big wheel, if you move away from you, it'll go down and you look more towards 6 o'clock. So up and down movement controlled by big wheel. And in diagnostic endoscopy, most of the time, what we'll be doing is bring the big wheel towards you because stomach is going up like a J-shaped stomach. Most of our movements will be upward movement. The second thing is a small wheel. Small wheel you do or talking the scope. But when you turn the small wheel, like what the blue arrow shows, away from you, you go more towards 3 o'clock. That is more to the right side. If you want to turn yourself to the left side, like 9 o'clock in the monitor, like if there is a lesion here, then you need to turn the same wheel towards you. So this is the one learning curve that slowly, like moving, I mean, changing the gear in the car, slowly you get used to it. Without your knowledge, you'll be doing it after some time. So big wheel for up and down, small wheel for right and left. If you know, that is very important thing. But this makes a crude movement, whereas more subtle movement. So what we do in the stomach, for example, I told you already, we will be traveling most of the time upwards and to the right, because we need to move from the stomach to the duodenum, which is more to the right side of you. So right side. So you follow these two arrows is a very important analogy. We'll be traveling upwards and to the right. Of course, you have to have a full control of the endoscopy. My teaching for all the youngsters is you need not unlearn a bad skill. So you learn from the beginning a good skill, that is holding the control head in your left hand and the shaft with your right hand. Because when you have that, you become what I call ambidextrous. Both hands are busy. Don't leave the insertion section pulling and pushing to the mercy of your staff nurse, because that is not a good habit, I would say, to start with. Because by holding the scope around 10 to 15 centimeter from the oral cavity like this, like as if you are holding a pen, don't holding it like a tennis racket. It is not. So you have to be very delicate holding like a pen. You turn the scope, I mean the shaft clockwise. You follow the orange arrow clockwise, then you will be turning again to the right, that is moving to the 3 o'clock position. If you go anti-clockwise, that is follow the green arrow, then you will be going more towards the 9 o'clock. So this is actually very, very important when it comes to the colonoscopy, because in colonoscopy, you know, colon is very tortuous. So this torquing right and left by insertion section, clockwise, anti-clockwise, it's like a screwdriver movement. This is a very critical for colonoscopy and less important for endoscopy. The third is important is the teamwork. Endoscopy is not only your own technique, the team matters. See, my team consisting here, a snapshot of my team, 4 people in addition to me. Like the number 1, she is holding the mouth guard. Number 2, she is restraining the patient and also monitoring the patient's pulse oximeter. Number 3, she is waiting to see what I'm seeing in the monitor. She will anticipate and help me with assisting biopsy taking or whatever procedure I'm going to do. Finally, if you have a luxury, a circulating or another nurse, she will take pictures. Whenever I say you just take a printout, or she will do all the things. It could be a postgraduate also at number 4. So a close-up shot of my first assistant, this is the way to be holding a mouth guard like this. So that the victory sign, so you hold the mouth guard, so the not only the patient's teeth are protected, the tip of your endoscopy is also protected. The second you watch her left hand, what she is doing, she is actually trying to push the occiput, the patient's back of the head, towards the endoscopy. That is flexing the neck. Very important thing is neck has to be slightly flexed like this. Very important. You should, because the moment you take the endoscopy to the patient goes like that extension. You should avoid that. Flexion is very important in order to have an easy intubation. And you don't have a big pillow. Okay, pillow is a very important, like something like a sand bag is enough. The next important thing, of course, is in my hospital, I always make sure the patient is monitored not only by you, but also by the monitors like a pulse oximeter, preferably an ECG lead. Give the patient with a nasal oxygen so that patient is not having hypoxia problem. Patient will tolerate that 5 to 10 minutes procedure very comfortably. So these are all basic things. Venflon is not required unless you give sedation, because most of the time we'll be giving what I call a oral or a local anesthesia by 2 squirts of 10% xylocaine spray. Let me tell you what you are going to do after all the lectures in the morning. Hopefully, the Satpriyo and the Satish will teach you with a simulator like this. This is a plastic model, which is exact replica of what is inside the human anatomy, I would say. So if you learn very well what to do in this, what I call a simulation based training, then you can do tomorrow the patient based training very easily. I divide that training into 6 important steps of what I call rule of 3. So the next 10 minutes, I'm going to tell you key important 6 steps. Watch carefully. The step number 1, the moment you take the endoscopy and put it in the mouth, you will get a fascinating and a surprise finding. Unlike an ENT surgeon, when he asks the person to open the mouth, you see tongue below, soft palate above. Here in the endoscopy, because of the location of the lens, the upside down view of the oral cavity will be seen. So this is the first view you should recognize. Tongue at 12 o'clock, soft palate at 6 o'clock. Very important to understand. Don't change it. Just to continue like this. That is the first view you have to have. So the station number 1 is a oropharynx, wherein you are expected to recognize 3 areas. Tongue above, soft palate and uvula below. You proceed another few centimeter, then you have a glimpse of epiglottis. So if you see all the 3, nothing else, you are on the right track. In front of the epiglottis, vallicula, you need not go there. Behind the epiglottis, darkness, that's where we are going next. So step number 1 is clear. Number 2, the station number 2 is, of course, is a laryngopharynx. That, if you see the endoscopy, it has a number in every 5 centimeter. So from incise or teeth at 15 centimeter, bang at 15 centimeter, you will be at laryngopharynx. So at laryngopharynx, you will be having the view. This view is common whether you are an anesthetist or an endoscopist. You will be able to recognize the vocal cord, arytenoid fold, and of course, a glimpse of pyriform fossa, something like this. Whatever more towards the 3 o'clock in your monitor, like a right vocal cord, right arytenoid fold, right pyriform fossa, and this is the left pyriform fossa, and that is a very comfortable location through which you enter in a patient who is in the left lateral position. And other important, interesting observation, I'm sure you all will realize, always the vocal cord is always welcoming, open position. It'll invite you, whereas the cricopharynx, wherein you actually enter into the esophagus, is always in a closed position. So the moment patient coughs, for example, you should be very, very careful. Okay. So the patient has to take an attempt of swallowing, either swallowing a piece saliva or a drop of water. That time only the cricopharynx relaxes momentarily. You can gently push your scope. So normally the cricopharynx is in a closed state. So we are now entering the station 3. That is the easiest station. That is esophagus. You enter the esophagus at 15. You get out of the esophagus at 40. And you see some interesting observation at 25. Otherwise, esophagus is what I call is totally empty. It is bone dry. Very important thing is, if esophagus has any amount of fluid, however small it is abnormal. It could be a case of achalasia because of a neurological problem, or it could be a distal obstruction because of the malignancy. So if there is a fluid or food, there should be some distal problem. Otherwise, suspect achalasia. Take it from me, because I am followed by Dr. Satpriyo. He'll tell the telltale findings of pathology, and in which achalasia is one of the important parameters. So coming to the esophagus back again, you enter at 15, you exit at 40. So these are the rule of 3 important numbers. What about 25? At 25, if you, in elderly people, sometimes if you carefully see this, the 3D anatomy of the thorax, this is esophagus, for example, the arching of the, you can see the aorta, and also just below that, you will have the left bronchus, it will be seen. So this is what important. So some impression at 12 o'clock, somewhere here you will be able to see in an elderly lady. But what you will be definitely seeing at 30 centimeter, all of us will be able to recognize is pulsating left atrium. So why it is important, if you ask me, because that is the only way I can tell if I am seeing pulsation somewhere here, that is 12 o'clock, anterior esophagus. This is 6 o'clock, posterior wall of esophagus. So when I do a myotomy for poem, I'll be doing anterior myotomy here, posterior myotomy here, because it will be just behind the heart anteriorly. So 40 is where we see what I call as Z line, the scomo-columnar junction. I'm sure the pale esophageal mucosa turn into pink gastric mucosa, that is at 40. Then you jump into the stomach. The stomach is actually, once by the time you insufflate, the stomach is like an ocean. It is so big, very easily we get misdirected. The challenge for the beginner is, if you enter the stomach, you don't know which way to turn. That is the problem for the beginner, I am telling you. So we have learned a technique of navigating in the stomach, what I call long route technique. So I'm going to tell you the long route technique. That is nothing but going along the greater curvature. If you see the analogy, this is the fundus, this is the body, antrum, and pylorus, of course. And this is the greater curvature and the lesser curvature with the incisura here. This is the analogy of the other patient cross section. So when you go inside, you have to walk along the greater curvature. So your job, as soon as you enter, endoscopic location of the greater curvature is at 6 o'clock. So your signature of the stomach is rugal folds. So by the time you enter the stomach, because of the converging rugal folds, you know we are in the stomach. Why it is important? Sometimes patient may have a gastrointestinal anastomosis with the total gastrectomy. There won't be any rugal folds. So that's why the signature of the stomach, I call it rugal folds, converging rugal folds. And here, watch an interesting observation. 6 o'clock is your greater curvature. 9 o'clock is a fundus, where you should not go, because fundus, if you go in, you'll get misdirected. You have to walk towards the 3 o'clock, which is the area of darkness, antrum. So you need to go up and to the right towards the 3 o'clock. Okay, never worry about 12 o'clock where the lesser curvature is present. That we will see on the way out. So if you have this analogy, it makes easy for the beginner to follow. So how you go upwards into the stomach, big wheel towards you. How you turn to the right side, a clockwise torquing of the shaft or small wheel away from you. So if you do that, slowly you go, and the pylorus you will reach in no time. Next 30 seconds, you see the pylorus right at the center of the screen like this. A pylorus is very forgiving for most of us, never goes into spasm unless you hyperinsufflate. Don't put a lot of air, you suck the stomach, instill some water, pylorus will nicely open like that. If the pylorus is right at the center of the monitor, that is the right time for you to enter the duodenum. So pylorus at the center, you ready to enter. If the pylorus is down facing or side facing, it may be difficult for as a beginner to go into the duodenum. Try to get this view if possible. And the duodenum 1 and 2. Entering a duodenum 1 is not difficult. You will be fascinated by the very plain featureless duodenum. 9 o'clock is the anterior wall, 3 o'clock is the posterior wall. Here is the commonest site of ulcer. This is the less common site of ulcer, posterior wall, but you have to look for both the walls. And then you go beyond into the post-bulbar region. There you have to do some steps that I'm about to tell you. Then you enter into the D2. As you can see the horizontal folds of mucosal folds, valvulae conniventes, with the only vertical fold at 9 o'clock, that is the ampulla, you will be able to admire. That is the end point of our endoscopy. So what you need to do, you need to go into the post-bulbar region, then you have to take an acute turn like this. So this is a little tricky. So you need to go into these 3 important steps for diving into the D2. So that is what we do. From here, if you want to go in like this, you need to once again turn the big wheel. But I would say probably you need to turn the small wheel first, because small wheel, I would say, is the key for D2. So if you do the small wheel away, then you have to turn to the right. Then big wheel towards you, then turn your body to the right, then pull the scope. Very important component of these are 2. One is a small wheel to the right, that is away from you and pulling the scope and turning your body. Then what will happen is the scope was traveling until now along the greater curvature. Now it will go and hug the lesser curvature when you start pulling it. This is called paradoxical shift of the scope from the greater curvature to the lesser curvature, that I call as a short route. So if you do that, what will you be, how do we know? Because then 60 centimeter at the incisor teeth, if you see, then you will be sitting there at 60 centimeter, the tip of the scope will be seeing the ampulla vata. That is what you need to do. Okay. The final thing is, of course, is a, because you haven't examined the stomach properly. So the final station, sixth station, is the stomach examination and a way out. How we do, you come back into the stomach, big wheel slightly, keep on turning slowly towards you like this, and the stove, it will behave like this, slowly, initially small, then later totally like a J, like a hockey stick, like this it will come. Initially, you'll be able to see a ridge of lesser, along the lesser curvature, what I call the incisura, stretching in the monitor like this from 8 o'clock to 2 o'clock. Below it, antrum, above is the body and fundus. Then if you do further panoramic view of the body and a distant view of the fundus, then you pull the stomach, I mean the scope, you'll be able to see. See, this is what we are trying to do. Initially, you'll see the incisura, then further you pull the stomach, you see the body, then further you pull the scope further, you'll see the fundus. So finally, you'll be able to have very close-up view of the crust of the diaphragm. This is fundus. This is the crust of the diaphragm, the right crust, which is nicely gripping your scope. Because this is very important nowadays, how the scope is nicely gripped by the crust of the diaphragm or lower esophageal sphincter, LES. Because there is a very important classification, Hill classification, that is important, that shows the laxity of the lower esophageal sphincter around the scope. You can categorize into Hill type 1, 2, 3, and 4. That is also important. You will be able to listen to it later in the part of discussion. So this is what we are trying to do, J maneuver. Now finally, we do one important thing. I told you, normally the signature of the stomach is rugal folds. If you insufflate too much, all the rugal folds will disappear. The stomach will be flattened out. But when you suck again, then again the rugal folds will form. How quickly you are able to do a distension and a contraction, that means the patient is having a healthy stomach. Imagine you have a patient who has an infiltrative disease of the stomach, like a linitis plastica or amyloidosis or a post-operative stomach. It will lose its distensibility, like a leather bottle. It will take its time to distend and contract. That will be signified by, because in linitis plastica, sometimes there won't be any mucosal changes. This should alert you there is a possibility I have to do a CT scan. So distensibility test is the last thing I do. Let me just take 2 or 3 minutes to give you a glimpse with a small video here. Okay, this is a video. I'll just run it somewhere here. So this is the way we grip the scope. I'm going to be ambidextrous, as you can see. My left hand, my right hand, both are busy. Okay, and this particular demonstration, I have the anesthetist. If you have anesthetist, well and good, and well influent whenever you are going to give a 2 or 3 milligram of bidazole. Okay, now very important thing, I'm sure my colleagues will teach you the ergonomics of endoscopy, equally important like laparoscopy. The moment you place the scope in the oral cavity, station number 1, tongue above, soft palate below, 6 o'clock, and 12 o'clock is the tongue. So that you will be able to see it now. Then slowly you go in, then you will be able to see the uvula, of course, and a glimpse of epiglottis. You'll be able to see. So if you see all the 3, then station number 1. Don't go in front of the epiglottis, go behind. Station number 2, laryngopharynx, vocal cords, arytenoid fold, pyriform fossa. For example, this is the right pyriform fossa. This is the left pyriform fossa through which we are going to enter now. So this is a high definition endoscopy. So you will be able to see the submucosal vessels, very good clarity in a patient who is not coughing and sneezing. It will be very, just slowly nudge in. Undue force you need to avoid and carefully go. Once you insufflate in upper esophagus, you enter at 15, exit at 40. As you can see in the esophagus, it is totally empty, bone dry. But in this particular case, as you go, you'll watch the patient has a small dilated esophageal varices, but empty. There is no obvious extrinsic compression like bronchus or arch aorta in this case. But I'll show you here, you'll be able to appreciate the pulsating heart. Now, can you appreciate pulsating heart as you can go anteriorly? I'm just talking here and there. You can see a grade 1 to grade 2 varices started appearing now, but still esophagus is totally empty. So that is what you need to realize. That is a grade 2 varices. You can see the pulsating heart at 12 o'clock. Then if you have a narrow band imaging, if you press the button, then you will be able to see the pale esophageal mucosa changing into the pink gastric mucosa. We are now approaching the 40. That is where we are about to exit. See, that is the stomach. We entered the stomach. So I don't want to go towards 9 o'clock because that's where a puddle of fluid and fundus is going to be there. I settle myself at 6 o'clock. That is the greater curvature. You see the stomach, this is not normally a normal mucosa. This is actually a portal hypertension, hyper patient. So congestive portal gastropathy, something like a crocodile skin. The stomach looks like it, isn't it? See, I am walking along the greater curvature. All along, I am walking along, and turning the big wheel towards me like this. Then pylorus at the center. Then it will be very easy to enter. Then you enter the duodenum, futureless. 9 o'clock is your anterior wall. Look for an ulcer. Posterior wall, you don't see it this much as I showed in the picture. If you want small wheel, you have to turn slightly away from you, or you have to turn your body or withdraw the scope and do. Okay. Then small wheel, I turn first. Then big wheel towards me. Turn my body and pull the scope. Very important thing is pulling the scope, shortening the scope. You can see now 9 o'clock, the ampulla beta, and all the horizontal, the valve-like conjunctivitis, a small puddle of fluid or bile is seen at 9 o'clock. All those things you can see. You can stay in the duodenum as long as you want, provided you don't move yourself. You remain keeping your body away from the patient. Okay, you have to look at the monitor. Very, very important thing is your body is a key to be stationary in D2. Then you are falling back in the pre-pyloric region. Now we walk along the lesser curvature, there is short route. That is the incisura you see from 9 o'clock to 2 or 3 o'clock position. Below antrum, above is a body. If you have a slowly, you'll be able to see the panoramic view of the body and also a glimpse of fundus. As I said earlier, this patient is a case of congestive gastropathy. You can see some hemorrhagic patches seen. There is no fundal varices. You have a look at where the scope is coming out of the lower esophageal sphincter or the crust of the diaphragm. There is nice pinch cock mechanism. Probably I would say probably it is a Hill type 2, slight laxity during inspiration. So all these things you observe, you have a full control of the scope. Then you desufflate, there is suck all, so the rugal folds reform like this, then slowly withdraw. Sometimes if you go in a hurry, on the way out, you may have to see what you are missed. For example, slowly the rugal folds form. So I'm just going to see the Z line one more time, especially looking for any esophagitis. And if you have a narrow band imaging, don't do undue suction. If you do keep on sucking, sometimes you can have a suction induced damage, especially when you have a patient like this varices. Don't suck through the varices. If you suck on the varices, it can cause damage and it cause undue bleeding. And you can see I'm coming at, you can see the pulsating heart one more time around there. I'm in the mid esophagus now, slowly. And how you control the withdrawal, you keep your hand very close to the patient's oral cavity. Then millimeter at a time, you pull the scope and have a good look, because you should not have any missed spot or a blind spot on your way out also. And even if you don't see the vocal cords on the way in, you should be able to see the vocal cords on the way out. For example, now I'm cricopharynx. You can see some narrowing happening. So just above the cricopharynx, I want to see the vocal cords one more time, just for my own satisfaction. Big wheel towards me, if I turn, I'll be able to see the vocal cords. Don't put a lot of water here. It will spill over into the larynx. So just you can see a glimpse of vocal cords, little cloudy picture, but you'll be able to understand what I meant and come out. Don't see any teeth. remain at the center, then you will be a very successful. It is a uvula, sometimes mimicking like a polyp. Don't get excited, remove the uvula thinking it is a polyp. So that is overall the examination, as I can say. At any minute, if the patient you think is restless, uncooperative, or saturation shows 60 or less, immediately withdraw the scope. Okay, abandon the procedure if you think patient is not enjoying the endoscopy. Next thing, the patient, the moment you finish, is going to ask you, doctor, when I can eat food. If you're given a local anesthetic, minimum 30 minutes they have to wait. And then if you are given a midazolam, ask them not to drive. Then wait for them for an hour and get the report typed, give it to them, tell them they have to report to you back in case they develop any complication, like any undue bleeding or undue chest pain or a fever. So you give them a telephone number. So these are all the standard of care internationally. So ladies and gentlemen, to close down, let me tell you, every endoscopy, however many cases you've done, always do the rituals. Check your scope in good order. Know the patient yourself, why you do. That is very important, I'm telling you. Safety of the patient is equally important. Never compromise on the critically examining the patient. You, your staff nurse, pulse oximeter, ECG, everything will be looking at the vitals. The moment you have anything to worry about, take the scope out. That is the only way you can resuscitate the patient. Always remember the 6 sets of rule of 3. And we have taken all these discussions, not only in this chapter, in the coming chapter, like an atlas of endoscopy, GA bleeding. I think Vijay is going to give a beautiful lecture. All this has been summarized in our IAGS manual of endoscopy, which moved from our endoscopy book, Science of Endoscopy, into a big book, now 400 pages with the 20 chapters. 10 chapters in endoscopy, 10 chapters for colonoscopy. This is, we recommend as a Bible for both 4G colonoscopy and EFIAGES for everybody. I hope Satpriyo may have few copies for you to see. If anybody interested, you can contact Gopal or Madhuri and will send to you by post on payment in UPI code. So this is just an announcement I wanted to make, and I'll leave it with the 6 stations. If anybody want to have a snapshot, this is my way of making it simple. I'm sure there are more than one way of doing endoscopy. I'm sure this is something like an ATLS. I thought there should be one safe, definite way of long route going in, short route going out. It's a simple thing to teach, transfer the skill set from the trainers like us to trainees sitting there. Thank you. Thank you very much. Let me stop sharing.
Hello. Thank you, Professor Murthy. One thing I would like to say, listening to a stalwart like you has made the endoscopy so simple. And I think as you were going on speaking, everybody in the hall was probably thinking that they are doing endoscopy. So you made it so simple and nice, and all the beginners will actually be very interested to go into that. And thank you so much. You made it so simple and nice. Everybody has already done endoscopy here in the hall itself. Thank you.
Thank you. Because we have observed in the last 20 years, there are 3 hurdles for learning endoscopy. First, they have a small doubt. Do we need to learn the endoscopy? Is it endoscopy important for surgeon? I'm sure later part in our faculties there, they'll tell you how important the endoscopy in the era of laparoscopy. First, they have to get convinced it is a skill set. Unless you have this, you are going to lose out a lot. The second important thing is whether you are legally permitted to endoscopy. That is another small doubt most of our young colleagues. So all people doing DNB, MS postgraduates, they are both legally, ethically permitted to do diagnostic upper endoscopy, colonoscopy. Don't have any doubt in your mind. The third thing is surgeons are very busy operating. They want to spend a lot of time, like 3 months, 6 months to learn the skill. So how to make it very simple, 3-day, 4-day program where we can give them the indication, yes, this is something they can learn. Because basically all of us know anatomy, All of us has a very good hand-eye coordination. It needs somebody like you are in the edge of the cliff. All I need to do is push you out of the cliff so you can start flying or start swimming. So this is what we are trying as a trainer. You give that confidence. So our job is to infuse the confidence. Only way is to make it very simple, break the steps into micro steps. This is what we learned, and I hope this is useful for our youngsters. Thank you.
Ishar, another fantastic, and I think globally you are the most lucid teacher. Everybody
Thank you, sir.
made it so many international workshops have been. Nobody made this thing so simple. What he's saying, giving the confidence, jump from the cliff and then fly. Really, really so proud and so fortunate to work with you. That's
Thank you. Sorry, I couldn't be Madhuri. Thanks for all the coordination and we really enjoyed here. Next time probably I'll come to enjoy the hospitality of the Silk City.
Hands-on workshop will be really missing you. Thank
No,
you
don't
so
worry,
much.
don't worry. I'm sure we have experts there and all Satpriya, Vijay, everybody will make sure ensure. I'll join you later today, probably around close to 5:30, 6 o'clock for another lecture. Till then, best wishes for all of you. Bye-bye now.
Thank you.
Bye-bye now.
Thank you so much, sir. It is now my privilege to introduce our next distinguished speaker, Dr. Satyapriya Sarkar, sir. He has been an examiner and teacher for FIAGS, FAGIE, and FIAGS for over 13 years, playing a pivotal role in training and mentoring surgeons in endoscopy. He is the convener of the Borderless Doctors Group, fostering collaboration among medical professionals across SAARC nations. His leadership extends further as the chairperson of the FIAGS board of IAGS and as an advisor to SAARC IAGS. In addition, he is the head of Department of Gastroenterology at GDDI Hospital, Kolkata, an established training center for endoscopy for surgeons. With such an extensive contribution to surgical education and endoscopy, we are truly honored to have him with us today. May I now invite you, sir, to take the stage and share your valuable insights on the topic Endoscopic Atlas of Upper GI Pathology.
Thanks for all kind words. And not only me, everybody in the SAARC region knows is the most difficult thing to follow Ishar Murthy because he is so mesmerizing. After that talking, it becomes a real challenge. So every time I try to make it tolerable to you. So my first slide. That's the best wishes from Kolkata, India. You know, yesterday the election was going on and luckily after many years there is no casualty. I'm very, very happy. The people should go and every time. Last time 20 people died, 6,000 injured. This time not a single casualty. I'm very, very happy. Whoever you go and give your support, people should be there living at least. No, definitely. The Central Police and the CRPF has done a wonderful job, unprecedented. So that's your place and that's my place. That's the oldest Howrah Bridge, which is for hundreds of years. That's the sign of Kolkata. And I love my city very much. I'm born and brought up there. So we are going for the UGI Atlas. We always feel that you cannot do anything unless your brain knows the everything. Then only you can see. And Ishar has shown you how the way to go, fantastic way, as if what he is saying, absolutely right, as if we are doing the endoscopy. All of you are doing the endoscopy. So we are going for this one. So this endoscopy, at last we should know that we have divided it into main 4 types. Diagnostic endoscopy. For dyspepsia, I am not going through that. The different indications already it has been very nicely elaborated. Then surveillance endoscopy is very important, like Barrett's esophagus, you know, 4-quadrant biopsy you have to do. You are having severe dysplasia, every 3 months you should do, that's the recommendation. If you have mild dysplasia, every year you should do. So that's the surveillance where he says, you know, the CLD is a dynamic disease. So it's not that once you saw it's grade 1, grade 2, it changes. Even after EVL, there can be recurrences. So that's very important. And definitely post-operative cases now, lots of bariatric surgeries are being done laparoscopically, even endoscopically they are doing. We did two the plication of gastroplication through the endoscopy, me and Sarfaraj was there, so that's another ways are coming, but there also we must have the surveillance endoscopy to look into that. And next, the screening endoscopy, the patients who are having family history of polyps or cancers, and definitely, you know, Japan is the first country where they have done fantastic screening endoscopy, and what's the result? Their ultimate going into the adenoma, carcinoma sequence, they have stopped it. And a huge number of endoscopic surgery were done for this malignancy. So that's only you can do when you get it into the that stage when it is only in the mucosa, not even going into the muscularis. So for screening endoscopy is now many of the patients and the relatives are also coming. So that's great. And then the therapeutic endoscopy, it has no limitation. Every day newer and newer processes are coming. And another division I've made it, routine endoscopy we do, intraoperative. I think every 1 or 2 years, my junior colleague, somebody called me, sir, I'm not getting the small lesion during surgery. Especially now they are doing the laparoscopy, so that much tactile sensation is also not there. So that's a difficult thing. So I go and intraoperative, we do the scopy and we get the lesion and then they do the rest. And definitely post-operative also, like there's a fundoplication, so we can assess that whether we have done or anybody has done the right operation. It is too tight or too loose, all these things. So those are the important things. Again, it's recommended that thorough wash to remove the food residues are very important because antral area and those area, I use the endoview always routinely because I've seen that after giving wash, many times you see the actual lesion there. So, and little amount of mucus and foods may not be, as Ishar was saying, the overnight fasting. I also ask our patient because many of people are having the gastroparesis silently. And the gastric evacuation time is not uniform for each one. So few patients after 5 hours is fine, few patients after 5 years, there are a lot of things. So must wash. And problem is when you are in the left lateral position, as we do always, so more wash you give, it goes to the fundus. And when you go for the fundic evaluation, it becomes very difficult. So if you can give the endoview and there is no mucus, you don't have to wash, so it's always good. But if it is there, always do it because that's a very important thing. Now the things have come with zoom endoscopy with magnification. Both are very important. Chromoendoscopy, when we started in 90, then that time we were very much thrilled with my teacher because we have different staining things, and for suspicious lesion, not one stain, different things you suspect, and we used to give that one, then wash it, and then see something, and we as juniors were very thrilled. But those days are gone. Now the narrowband imaging, that's for the Olympus, eye scan for the Pentax, and then FICE, that all are the intelligence scan, they say, almost the same thing. We have 3 basic lights, the red, the yellow, and the blue, and we take out the red, and that is called the digital chromoendoscopy. So digital chromoendoscopy has gone a long way, and then now we don't need for that very lengthy, difficult chromoendoscopy. Now, magnification with standard endoscope are 30 to 35 times, and it can be 150 times in Korean. Some of the things which have come, which can make it up to 450 times magnification, where you get a histological diagnosis if you are trained in that way in your endoscopy room. You can give some stain, make it up to 450 times, and then you see what is the exact histology from there only, without taking any biopsy. So the chromoendoscopy, I'll skip it because nowadays it's not done. So as Ishar was saying, we are going larynx, that's the arytenoid folds, the vocal cord, and we go posterior to that. I'm not going anything against because after Ishar, you know all these things now. So important next is the roomy esophagus. Many of the achalasia patient, you really see, and also the other motility disorder. Now motility has been changed a lot. After the Chicago classification, now surgeons like Bhavni Dhwala and many other, now here Badgaonkar is there who are doing the manometry of this case. And very, very important. Now it's not like that during our nutcracker, esophagus and only achalasia. Now they have the peristalsis with that the LES opening. 3-4 criteria are there. Based on that, Chicago now fourth stage classification of Chicago is going on. And it was really very, very nicely, everything is very specifically, not that non-specific which you used to read and teach. So that roomy esophagus, one of the common is the achalasia. Usually it is not that roomy, and achalasia also usually get some food and the residue here. So you suspect that one. That is another very important thing. I'm coming from the lesion from above. Eosinophilic esophagitis, last 1.5 decades, more and more it's being diagnosed, but we say the persistence or waves and rings are there. You suspect it because you take a biopsy, and then based on eosinophil numbers in per high power field, there are different gradations. Importance is you need to give the steroids in this type of patients, and many of them come with the dysphagia. So that's you should be aware of all these things. See, as a surgeon, always you will be evaluated by other doctors and the gastromedicine, where how many things you are missing, not how many things you are doing. So I think these are very, very important points you should remember what newer thing. Next, the hiatus hernia, the Hills classification, you know that how when you do the J maneuver, then you see that how tightly your scope is being grasped by the LES, whether it is tight with inspiration, then it is little loose, then you can see the esophageal mucosa for a specified area, and then you can see that rest of mucosa is going parallel to your scope. That is the Hills 4, where there is definitely hiatus hernia is there. And then you use the other images also, you will really see, and then those cases definitely surgery is needed for those patients. And that is the paraesophageal hernia, very, very uncommon. I think throughout my journey of around 1,26,000 endoscopies, very few, maybe 5 or 10 I have practiced, but beautifully, once you see, you can really make out that's a paraesophageal hernia. Many times with the sliding also paraesophageal can be combined. Then the esophagitis is a very important thing. They have different classifications of esophagitis. The first one where there is less than 5 millimeter lesions, but there can be more than one, but not beyond the 2 adjacent mucosal folds it's going. Then it is going along the mucosal folds, then 75% of the circumference, that is grade C, and more than 75% of the circumference or any of the complications, then you are going for the grade 4 esophagitis. And one of the grade 4 esophagitis is the Barrett's esophagitis. You can have peptic stricture, you can have peptic ulcers in the esophagus, and you can have the Barrett's esophagus. Important point of Barrett's is, when again we were teaching in the first decade, we used to say it's the island of gastric mucosa in the esophagus. Now totally changed the idea. The prior classification has shown that Barrett's you have to calculate from the cardinal folds, that is where the rugis all end from there circumferentially how much of the mucosas. Now with NBI you can nicely make out which is gastric and the bluish one in the esophageal, and that those all who have done the NBI. So you can very nicely see from there circumferentially how much, that is described as C, and from the end of that circumferential, many of them tongue-like projection goes in anywhere. So that you separately measure and write it like this one, it can be C2, M2. Circumferential how much Barrett's and M how much Barrett's. And that's why you should take the 4-quadrant biopsy from the Barrett's area, and as I was saying, there can be mild dysphagia, there can be high-grade dysplasia, no moderate dysplasia for the Barrett's. And then there can be earliest adenosia. The best thing is in earliest adenosia also you can do the endoscopic submucous resection. Stricture esophagus can be different causes, maybe underlying maybe malignancy can be there, but most of them are peptic esophageal ulcer and then peptic stricture, and they can be what we do. most of the time they can be very gently dilated and patient don't need any surgery and patient can go back to normal life. But again, the same, they had the peptic ulcer, so they should be cautioned that they should change their lifestyle. Malady-Weiss syndrome is another very important thing because you have to suspect that. Classically, we read in our belly lab that the alcoholics and others who are reaching, but all in my life, when I got 2-3 hemoglobin people have come, none of them were alcoholic. They were old patients, many even pancreatitis patients having severe retching due to some indigestion and other. Ultimately, they had the acute the tear in the gastroesophageal junction. And even there can be full-length tear, Boyer-Hewitt syndrome, but very uncommon. But this one, when you are doing it for after 2 days or 7 days, by that time it has stopped almost. So if you don't get anything, be suspicious that there can be a Malady-Weiss tear. And I've seen that very nicely. You can give the submucosal saline adrenaline injection. You can put the APC there. You can put now so many other things are there. Now clips are there. Now gold probes are there. And many of the electrosurgical thing also you can see. If you see there is active bleeding going on, most of the cases endoscopically you can treat, but only be very cautious that it's there. Candidiasis, one of the common. The few of the patients, they always used to say that if you have immunocompromised, then only you have candidiasis. It can be any other fungal, moniliasis also can be there, but as 95 to 96% of these, all fungals are due to Candida albicans, that's why it is popularly known as candidiasis. So and that's why, but again, now candidiasis also are having a different staging endoscopy. What Ishar always used to say, that Shataprabhu teach the surgeons all the staging so that their reportings are very good. So anybody who looks into the report, he can make out this fellow doesn't only know how to go up to the ampulla, he knows what to interpret. That's the important point in your life. So it's a common opportunistic infection, immunocompromised patient, many times no immunocompromised I have seen. Elderly patients especially, HIV, AIDS, cancer can occur with prolonged antibiotic or steroid use, commonly presenting with dysphagia or odynophagia. Mainly odynophagia people came. And esophageal candidiasis is primarily classified using the Coetzee classification, which grades the severity of endoscopic finding from 1 to 4 based on the plaque size. The white plaques which are there, which cannot be washed away. It is only sometimes you can confuse it with the residual small food particles. So wash it and then see it, white plaques are there, and their confluence size and mucus friability. So Coetzee classification grade A is a few raised white flakes, mostly common, less than 2 millimeter without surrounding edema or ulceration. Coetzee 2 says multiple raised white flakes, but more than 2 millimeter without surrounding edema or ulceration. 3 is confluent, linear and nodular elevated plaques, often with ulceration. That's also very important. And 4 is, I have seen many 4 we are now seeing. People are getting chemotherapy, getting steroid, getting so many things. Linear, nodular and confluent plaques with increased friability of the mucosa, like contact oozing, like the IBD, there may be a contact oozing, and occasional narrowing of the lumen also they can produce. So that's what is Coetzee classification. Foreign body, I'm not going into details because Orko Provo is supposed to come. His train is getting late 4 hours. So once he comes, he will go through. This is a very separate thing. One of the commonest everybody will see this one. So foreign bodies of esophagus. Now varices, very important. Huge number of CLD patients are there and they are coming to you with different gradation of esophageal varices. There can be only esophageal varices, there can be esophagogastric varices. So I'm again going into the classification types, which are very important. And separate, this is the fundal varices. That is the gastric varices, the 99% are fundal varices. 1 or less than 1% can be antral varices also gastric. So, but this is how it looks like, because at least twice I have seen some of my juniors here they thought it was a polyp and tried to snare it, resulting in ferocious bleeding. So be careful. And you see that this is not a solid one. If you close your biopsy for 7, just push it, you can feel the reducibility. You can understand that this is a vascular problem. And now this is the gastroesophageal varices classification. And this is very important. Dr. Sharin has made this thing, few of the endoscopic things which Indians have invented and whole world follows. So they have said gastroesophageal varices, one is when the gastric varices are along the lesser curve. It is 2 when the same gastric and esophageal varices, but the gastric varices are along the greater curve. And isolated gastric varices 1, as I said, 99% in the fundal varices, but 1 or 0.5% can be even in the antral varices. So these are the different entities you should know. Now the classification of esophageal varices, which is the most common. The first one, grade 1, superficial varices that do not disappear with insufflation. That is very important. Prominent veins are those, when you insufflate, they disappear. But when you insufflate, still it is there. And maybe 2 millimeter or little more, then you call it only grade 1 varices. Grade 2 is medium, enlarged, tortuous varices occupying less than 1/3 of the esophageal lumen. Grade 3 is the large coil varices occupying more than 1/3 of the lumen. And grade 4 is the tortuous bluish varices more than 4 millimeter in diameter, filling the lumen, almost touching, kissing each other, the varices. Almost meet often the high bleeding risk, sometimes referred to as grade 5 also, when they are having associated with the stigmata of hemorrhage. If there is red spot on the varices, you can make out it is. Why this is very important? Because it is said that if it is grade 1 or grade 2, you should not go for the prophylactic banding. Because you know the normal portal pressure is 5 to 6. When it is there portal hypertension, if it goes up to 11 to 12, with any of the carvedilol or propranolol, you cannot make it 5 to 6. You always keep it. Our aim is to keep it around 11-12 millimeter. Because they say that if you have a 17 to 18 millimeter, when the 3 and 4 means portal hypertension, your chance of bleeding are between 85 to 90%. And when you can reduce the pressure up to 11 to 12, normally 6, 11 to 12, the chance of bleeding goes down to 3%. So with pharmacological, now different thing, and so 3 and 4 if it is there, if it has not bled also, forget about that, go and do the banding, so you are not facing with a serious, I do not know, in future you will see when it bleeds, actually, it becomes, the vision becomes absolutely real bad. Now with 190 and other, we have fantastic washing things with continuous wash with the leg pressure, then we can go and do this thing. So 3 and 4 go for prophylactic banding. 1 and 2, you can wait for any bleeding, use the pharmacological treatment. Portal congestive gastropathy. Many of the time patient comes without any, so the CLD patient with portal hypertension, without any varices, but they are having the anemia. So only portal congestive gastropathy can cause minimal blood loss continuously, resulting in severe anemia. So this is also very important. The snake skin like totally edematous, submucosal hemorrhages, and with NBI you can make out even the mucosal bleeding and the submucosal also change of color. So that's a fantastic one. Again, congestive, this one gastropathy is also again being classified. What is McCormick classification? That is mild and severe, no moderate. Like your Bedard's dysphagia, it's either mild or severe. So mild is defines a fine white network of snake skin mosaic pattern, not that edematous. Severe defines a mosaic pattern, you can see that one, plus red spots, which are the flat red spots or the cherry red spots, and active bleeding or contact bleeding. When you are passing through that, if you touch it a little rough, the immediate starts. So that is called again severe congestive gastropathy. Then again your pharmacological treatment should be very, very important, and again you should periodically go and do a surveillance. And this another new Italian endoscopy club has come very recently with the latest classification based on 4 patterns: mosaic-like pattern, MLP, red point lesion, RPL, cherry red spots, CRSS, and the black-brown spots. I am mentioning all these things so that if you can remember few of them, if you see any good report from very good center, otherwise you will be at a loss what they are saying. So this is nothing difficult, but they have made it more categorical, more methodical for us so that we can describe it nicely and correlate with the clinical thing. CA esophagus, you know, it can be different type, ulcerated, undermined, proliferative. This is one of the proliferative thing. Only one thing, if you have a CA esophagus, if you are a very learner, if the lumen is compromised, don't try to go beyond that. If it depends on your skill, definitely you can go after some time. You take multiple biopsies from that area and come out. Don't do any harm, anything. Sometimes, rarely, you can have a perforation for that. Submucosal lesions are very, very important. Previously, we sometimes used to take the biopsies from the mucosa and then go deeper in the same place. But now with endo ultrasound coming in our different centers, Kolkata also few are doing fantastic US. Even Ishwar and I had a plan, Satish knows, they know, that few surgeons are doing fantastic. I think Vijay is also doing endo ultrasound. So they are coming with excellent things. So we should, with US, we can make out which layer it is. Muscularis, submucous, below the serous, everything we can make out. So leave it for that. Otherwise, a CT, also good CT scan also can say which layer it is. Different of NET, neuroendocrinal tumor can be there, GIST can be there. This is one GIST, gastrointestinal stromal tumor. My experience, most of them presented with severe bleeding due to ischemia mainly of the mucosal area, and this type of umbilicated surface thing where it can bleed profusely, really acute bleeding, so be careful about the lesion. Then the gastric polyp, now you know the different types of polyps has come. It's not like previously we know only 2 types, pedunculated and sessile polyp, what we were taught and what we used to taught also. Now there are adenomatous polyps, there are hyperplastic polyps, there are juvenile polyps, pseudopolyp and polyposis syndrome. Importance is which has the potentiality to go into malignancy. Adenomatous having the highest potentiality adenoma carcinoma sequence. Now we will say that 2-3% of hyperplastic polyp also can go for malignancy, but juvenile polyp doesn't go. Inflammatory pseudopolyps or ulcerative colitis are very low. Can, but very low chances. Polyposis syndrome where there are hundreds of polyps, and that's a different thing. It's very difficult even for surveillance, which way, which of them are going changing. So many of time the prophylactic surgery is needed, whether polyposis syndrome for colon or for the upper GI. And this is the Paris classification, which is now all over the world. We have seen Europe and states, they are following this one. There can be protruded lesion, flat lesion, and excavated lesion. So polyp even can be excavated lesion, remember that. And then polypoidal can be sessile, flat elevated type, or excavated and ulcerated polypoid type. So contrary to our previous ideas that it is always protrusion from the thing, there can be polyp which are after ischemic changes, after different other changes, there can be even the excavated or ulcerated type. And that is the another very important thing. I have learned a lot from Borgaokar's presentation on polyp. Really, I read out and I got a few of them. This laterally spreading granular type. This is very, very important because this spreads only laterally, doesn't proliferate into the lumen much. But they have a very high potentiality to go for malignancy. So now they are separately mentioned, laterally spreading granular tumor. It can be again flat type, it can be again elevated type. H. pylori, you know, I am not going into details. You know the person who have invented this thing have given the bacteria in their own body. You can imagine the amount of dedication they have, and produced the ulcer in their own body, and they got Nobel Prize after, because previous to that it was Schwarzian theory, no acid, no ulcer. But we are also taught, we also learned from there. Then he has changed everything with the H. pylori, and RUT, rapid urease test, what we do is a very common test we do. We take a tissue surrounding the antrum within 2 centimeter, make a circle, take a tissue from that, few points are there. Don't take the tissue from any area which is erythematous, which is already infected or already ulcerated. Take it from the healthy area surrounding the thing, because what they say, the ulcers are caused by H. pylori, but once the ulcer or infection happened, then the environment is not very conducive for the H. pylori to stay there, so they migrate to the surrounding normal tissue. Even I remember in 24 years back in States, I presented a paper when I used to take the after H. pylori, antrum and fundal for H. pylori, and then after the 14 days course, again antral and the fundal. Fundal was very non-specific, it was a very old one, but so that proximal migration of H. pylori happens. And they stay there, and later they again reinfect. So these are the important points. RUT, I am not going into details, but you should know exactly what happens from yellow to red color thing. These are the points we ask many times in the interview. I think these are very basic things which one should know. I've seen people doing thousands of cases RUT, but they cannot explain what happens. I request you all, you are academic person, you are not technicians, so please learn these things. Dula Foy's lesion, again you know what Ishar says, on your lucky day you can get a Dula Foy's because it bleeds and then it stops. By the time we go, we don't get anything. But again, should be suspicion. And Dula Foy's lesion of the stomach is a rare, life-threatening cause of upper intestinal bleeding. 1 to 2% of all cases where an abnormally large, tortuous arteriole protrudes through the tiny defected in the mucosa. It primarily occurs in the upper stomach, lesser curve. There's a 6 centimeter in the upper lesser curve, and often in older patients with comorbidities, high blood pressure, or even chronic kidney diseases. So all these points are important. I'm not mentioning anything very in details which is not needed. These are extremely needed so that we can get the things. And pathophysiology is an aberrant submucosal artery fails to taper. Usually from serous, when it goes in, it always tapers to smaller, smaller and smaller. But it fails to taper, causing it to erode the overlying mucosa, leading to massive intermittent hemorrhage. Rare causes others are angiodysplasia, Dula Foy's lesion. GAVE is a very important thing. Gastric antral vascular ectasia, you know, it is other names are the tiger stripe, watermelon, when you have to go and through the APC. Then leiomyoma, the submucosal lesion. About the early cancer, Boardman classification is another very important thing. You have the polypoid lesion, you have the raised fungating ulcerated lesion with sharp raised margin. Next is ulcerated but poorly defined infiltrative margin. And last one is the infiltrative predominantly intraluminal lesion, which is linitis plastica, and that definitely the prognosis is very bad. And when we insufflate this stomach, they don't insufflate properly, and even Rugis and others don't changes. So that's one of the cause. Now coming to the last part is the duodenum one. Duodenitis, gastritis, all are related with very much with the Helicobacter pylori, you know. Acute duodenal ulcer, as Ishar was saying very properly, most of them are in the anterior surface, but the thing which we miss is when there is only posterior wall duodenal ulcer. I've seen people others have done, could not get anything. So when you are in the first part, while coming out spatially, be careful, you look at least some glimpse of the posterior wall. Chronic duodenal ulcer with the slough is there and fibrosis there. Bad part is if the heals also, many of the time they cause stricture and causing gastric outlet obstruction. Duodenal scarring, that is one that also can cause problem. And duodenal ulcer, different, is a very, very common one. And that is the last forest classificator. Again, they feel that with every ulcer you mention, you should write the forest classification. The only interesting feature of forest classification, other always when we go up, it is bad. When we go down is good. But here, 1 is the worst. 1A is the arterial or spotting hemorrhage. 1B is the not spotting but oozing. 2A is the only no spotting or oozing actively, but there is visible lesion. 2B is the adherent clot on the floor of the ulcer. 2C is the dark base or hematine covered lesion. That means it has changed from the bleeding. And 3 is the lesion without active bleeding. That means almost any ulcer without anything. So that you remember in the reverse order, I feel this is one of the classification they have made. Again, I am saying all these things because not only you look, you should know this classification in your brain and use that one in your reports, and that really makes your report more precious to others. Different bariatric surgery after that. I have worked in an area where we have regular laparoscopic bariatric surgeon. I don't do that, but I have done a lot of endoscopy on them, and these are different things to assess those ones. So at the conclusion, it's a very easy one, but I think thorough wash or defoaming agent optimize the visibility. Visibility should be good. Don't be in a rush. Image enhancing techniques should be applied depending on the familiarity and availability, because whether malignancy or not, you can have a very good idea. There are kudos classification. I'm not going into that. Narrowband imaging with magnification is the best solution for the characterization of the lesions.
Thank you, sir, for a wonderful talk. And we are fortunate here that we have got the topmost variety of endoscope with narrowband imaging in our department. And our endoscopists are able to do. It is the best use of all such endoscopes. And probably all those who are attending the course will be immensely benefited from having all the description which you have narrated so vividly in diagnosing in their future endeavor. And you have rightly pointed out how the art of endoscopy can be done so perfectly with the scientific background of the knowledge. Thank you so much, sir.
Thanks a lot, because Dr. Gopal has shown me that 190 scope you are using, that's the best scope. So please make use of that. Don't go only white light, and please make use and make an excellent report. Thanks a lot.
And there is an announcement. Since we are running behind the schedule, there will be no coffee break. So we'll go to the next session. I'll ask the organizers to please take over. And all those who require a cup of coffee can go outside and have it. Thank you.
Thank you so much, sir. We take this opportunity to thank our respected chairpersons, Dr. Shiva Prasad Patnaik sir and Dr. P.K. Kar sir. I would request you all to resume to your seats. With this, we begin the second session. It is my great privilege to introduce our chairpersons for the next session. Dr. Madhuri Patnaik ma'am is an advanced laparoscopic, bariatric and oncosurgeon at Spurs Hospitals and Critical Care Bhubaneswar. With extensive experience in modern surgical practice, she is an executive member of ASI Odisha for the term to
Fellowship candidates, please. You can move to this endoscopy room for live demonstration of this upper GI endoscopy. And also we'll have one lower GI colonoscopy also. You can go and see live cases. All fellowship candidates can go do this thing. Are you interested? देखियो. They will demonstrate. चलो.
So many documents, spreadsheets, videos to go through, and the deadline is tomorrow. All the trainees are stressed. Everyone except Sandra. Because with Google AI Plus, she can just use Notebook LM to create a simple podcast summary. Catch up fast.
Break free with the new Opera.
turn your social posts into YouTube ads easily. Just upload your best content to Google Ads and let Google AI scale it to multiple formats. Unlock new audiences on YouTube and get started with Google Ads today.
Filmora gives you the freedom to immerse fully in your
Now we begin the second session. It is my privilege to introduce our chairpersons for the next session. Dr. Madhuri Patnaik ma'am is an advanced laparoscopic bariatric and oncosurgeon at Spurs Hospitals and Critical Care Bhubaneswar with extensive experience in modern surgical practice. She is an executive committee member of ASI Odisha for the term 2023 to 2026 and also serves as the EC member for the East Zone of IAGES from 2024 to 2026. Further, she has been entrusted with the important responsibility of chairman of the FIAGS board of IAGES for 2025 to 2026. With her dynamic contributions to both clinical practice and surgical education, we are honored to have her with us today. May I now invite her to kindly take the stage as the chairperson for the next session.
Next, I would like to introduce Dr. Charan Panda, sir, to the stage. Sir is an accomplished advanced laparoscopic and general surgeon known for his extensive clinical experience and dedication to the surgical practice. He completed his MBBS and MS in general surgery from MKCG Medical College and went on to join the same institution in 1996 as an assistant professor, contributing significantly to surgical education and training. He also serves as the chairman of the Silk City Surgeons Club, Behrampur, reflecting his active role in the local surgical community. We are honored to have you with us today, sir.
With this, it is a great honor to introduce our next distinguished speaker, Dr. Vijay Borgaonkar sir. He is the Chief Surgeon, Endoscopist and Director at Krupamai Hospitals, Aurangabad, with a remarkable legacy of innovation and excellence. A true pioneer in his field, he was first to establish a cobalt radiotherapy unit in the private sector in 1992. He also introduced GI endoscopy, including advanced procedures like ERCP and EUS in the region, significantly advancing gastrointestinal care. Further showcasing his visionary approach, he was instrumental in initiating renal transplantation services in the region. He also serves as an executive committee member of the Asia Pacific Hernia Society and IAGES. With such groundbreaking contributions and leadership, we are truly privileged to have him with us today. May I now invite him to kindly take the stage and share his valuable insights on the topic, role of endoscopy in upper GI.
Respected colleagues, dear young surgeons and distinguished faculty, we are very happy that MKCG Medical College is conducting this EFIGES 2026. And these instruments which were procured by during my tenure as the HOD of surgery as well as medical superintendent, I am very happy that these are being utilized and proper training is being given to young surgeons. And I am very much thankful to the trainers and faculty here. I offer my respect. You are shaping the next generation of surgeons, not only in skill, but also in values. So thank you, sir. Please continue.
Thank you very much. Respected chairpersons, faculty members and delegates. At the outset, I am really happy to be here and I am thankful to the leadership of IAGS, particularly Dr. Ishwar Murthy, Dr. Sarkar, Dr. Mida, for allowing me to participate in this wonderful event. I am also extremely thankful to Dr. Madhuri Patnaik because she has been coordinating with me since beginning and she has also given a wonderful hospitality yesterday. I really appreciate and recognize the efforts taken by the hospital's management, particularly Dr. Patnaik and also Dr. Gopal, because when I came here yesterday nearly at about 10 o'clock in the night, they were still busy in arranging the things along with their team. With this, I turn to my subject, that is the role of endoscopy in the upper GI bleed. When Dr. Madhuri told me that your subject will be GI bleed in endoscopy, I was really relieved, because this is the only one subject in GISA that where endoscopist can deliver his 100% best to the patient. As we know that upper GI endoscope, apart from the diagnostic abilities, it has got a very potential and very high therapeutic capabilities as far as the GI bleed goes. And next slide. Sorry.
Can we have the slides of...
Slide is not moving.
Audiovisual team, can we have the slides of...
Bring greetings from my hospital, Krupamay Hospital at Aurangabad, now Sambhaji Nagar, and my areas of interest are there. See, by definition, the upper GI bleed means any pathology which bleeds proximal to the ligament of treads is referred to as the upper GI bleed. And the occurrence or the incidence is that way pretty high, about 50 to 90 cases per lakh population. So, and the patients, they manifest to us in two ways. Either they are having a bleeding which is occult, as we had seen a case just now in the, while I was demonstrating, and or it could be an overt bleeding. The overt bleeding could be hematemesis, melena, which is very common. What I want to really emphasize here is about the hematochezia. Hematochezia is a passage of a dark red maroon color blood per rectum, where the pathology is essentially not colonic, but it could be small bowel or even the stomach and the duodenum. So as a dictum, actually always, whenever you have a case of GI bleed, maybe melena, maybe hematochezia, maybe anything, the first investigation that should come to your mind is to do a upper GI scopy, because you will be surprised often that the patients of portal hypertension, particularly the gastric varices, or the some lesions in the duodenum, patients never have hematemesis. They may straight come with melena or even the hematochezia. I am going to show one example of this case in my presentation. Still not moving. Sorry. No, we have to go back. I have to go back. Okay. When we have patient of upper GI bleed, it is better to stratify this patient. The risk stratification is very important, because the low or the moderate grade bleeds, they can be managed on the outpatient basis, whereas the severe bleed, they need the high IPD management. Now, how to identify that? It is a simple examination of the vitals, the anemia, the hemoglobin of the patient, and other comorbidities will decide whether this patient needs an IPD or the OPD management. There is a score, that is a Glasgow score, that also can be done to find out whether we are dealing with a low grade or the high grade bleeding. The management essentially is first the optimization of the patient. And this optimization is done by the medical management, where we use certain medicines like terlipressin, octreotide, PPI, and injection erythromycin. Now, the terlipressin and the octreotides, they have definitely proved very good drugs, particularly when we are managing cases of the portal hypertension, and the bleeding really becomes less after the use of these drugs. And then thereafter, after optimization, we can go ahead with the upper GI scopy. The PPIs, of course, they have got a role also in the portal hypertension as well as all the duodenal ulcer bleeds. Injection erythromycin, though not available very freely, but in the guidelines it has been mentioned, it can be given 30 to 60 minutes before upper GI scopy, not for its antibiotic purposes, but it is used as a prokinetic for the upper GI scopy, so that the blood in the stomach is evacuated further and it is simpler for the endoscopist to go in to visualize the things. And then we can go ahead with the upper GI scopy. Now this timing of the upper GI scopy also has been discussed, and there are certain guidelines that it is not necessary to do the upper GI endoscopy as soon as the patient comes to you. Rather, we can always time it up, and depending upon the severity, if we do it on urgent basis, it is less than 12 hours after the admission, or then we can schedule this patient easily next day as a first case on the endoscopy schedule. But there are some situations where we have to really rush this patient to the endoscopy room. So that is why the endoscopy should be ready 24/7 in the hospital. Not only him, but along with his team, with the technicians, the anesthetist and everything. All the accessories should be available even in the middle of night, so that we can salvage the patient who is bleeding very actively and seriously. The etiology of the upper GI bleed, the 50% of the cases, they come from the portal hypertension and from the peptic ulcers. Nowadays, the incidence of peptic ulcer bleeds, they are going down. However, because of drug abuse, there are so many ulcers in the stomach and the duodenum, which are responsible for the bleeding. And portal hypertension incidence, of course, is going up because of the liver parenchymal diseases. The rest of the 50%, they come from the conditions like esophagitis, duodenitis, the vascular ectasias, as was told earlier, that there is a case of watermelon disease, gave Delafoy syndrome, hemophilia, and the hemocystis pancreatitis. Now, all these things, they are possible. If the upper GI scopy is negative for the varices and the ulcers, then we have to necessarily look for the conditions like the Mallarvis, or could be a Delafoy's lesion, and so on. There are certain accessories which are available in our armamentarium for the control of bleeding. And the first thing is the chemical. Here, as per the list, it comes injection ethanol as a sclerosant, injection ethanolamine oleate, injection epinephrine, and cyanoacrylate glue. Now, out of these four, actually the ethanol was used way back, about 40 years back. It's an absolute alcohol, which I have used somewhere in 1984 or so. 5-6 years we used alcohol very aggressively for the management of the varices. Sooner we got cyanoacrylate glue, and even the bands, they came somewhere in 1990, and then the use of ethanol and the ethanolamine oleate has regressed. So nowadays this sclerotherapy is not used, but the injection epinephrine, it is still in use, where we infiltrate the epinephrine where the site of bleeding is. It acts by two ways, by vasoconstriction, number one, and also it also gives a tamponade effect around that area so that the bleeding becomes less. It is not that injection of epinephrine will totally control the bleeding, but it will make at least the endoscopist test simpler because of the less bleeding happening, and endoscopist can see that site clearly, and then he can go ahead with further application of the clips or even you can use the APC and so on. And the esophageal variceal banding is now the gold standard for the management of the esophageal varices. There are certain energy sources which are available and they are also commonly used, like the electrocoagulation. There are bipolar probes also available, and the heater probe, it is also available. It's called as a gold probe, and the APC, out of which APC is a non-contact probe, but the heater probe and the coagulation, where the probes, they have to touch the tissues and then they coagulate. All these things are necessary, and it is not that we are happy with one accessory. In our armamentarium, if you want to give the complete relief to the patient, it is not one, I will say the entire gamut of accessories, they need to be available to the endoscopist. And not only that, the endoscopist should be familiar and should be well versed to use these accessories effectively so that the proper control of bleeding is possible. And then the mechanical clips, like the hemo clips, they are also available, and they can be a clip like that as you see here, or nowadays the over the scope clips, they are also available, which can be used for the larger ulcers, which I am going to talk to you in detail after some time. And this is the endotherapy for the duodenal ulcer. We had the atlas of duodenal ulcers where the forest classification was discussed. And in the forest classification, it is just not the classify the ulcers. Even the therapeutic applications depend upon which stage the forest ulcer is. For example, if it is forest 1A and 1B, then the first line of action could be injection epinephrine by the side of the ulcer. And once the bleeding is little under control, then we can go ahead with the clips, or we can go ahead with the electrocoagulation. So all these secondary accessories, they can be used after the initial injection of epinephrine. This injection epinephrine is 1 in 10,000, and we can use it liberally around the ulcer base. If the ulcer has got 2A or 2B in classification, 2A is just a visible vessel which is not bleeding, and 2B is a clot over the ulcer. If you see a visible vessel, it has to be treated endoscopically then and then, otherwise there is a potential risk of bleeding immediately. And these visible vessels are better clipped so that they can be tackled. And if there is a clot, then if you are capable of managing it further, then you wash the clot and take out the clot, otherwise leave the clot like that. And forest stage 3A and 3B, usually these only require surveillance and there is no endotherapy required. Now, this is one case of a Mallory-Weiss syndrome. The Mallory-Weiss syndrome is a tear in the esophageal mucosa. It is a longitudinal tear. It extends right up to the muscle layer, and sometimes these patients can bleed very aggressively. Why I am showing this case? Because it was very unique. This was a 29 years young male with no comorbidities, no hypertension, no diabetes, nothing. He had his full breakfast, and then he boarded a bus to go to his job, and then he felt nauseated. Socially, it was not possible to vomit him in the bus, so he tried to control the vomit, which he should not do. And that is the correct recipe for developing the Mallory-Weiss syndrome. He had a severe chest pain, and he developed the Mallory-Weiss syndrome. Now, because of his chest pain and he had some sweating and all, he was taken to the ICU. There, the intensivist thought that he is suffering from coronary, and they aggressively thrombolized him. Now, a patient of Mallory-Weiss was thrombolized, and he was bleeding very profusely when he was brought to us. And here, the first thing is to give a very good wash and to find out from where the bleeding is coming. And then we injected epinephrine all around that area, suspicious area from where the patient was bleeding, and then the bleeding was controlled. Otherwise, the clipping could have been an alternative for this patient. But now you can see that the clot has formed there. Yes. And the bleeding has stopped. So this is a case of a Mallory syndrome which was managed endoscopically very aggressively, and then the patient could be survived. This is the case of esophageal varix, and for all grade 2, grade 3 and grade 4 esophageal varices, now banding is the gold standard, and nowadays the multiple band ligators are available. So at every band we can have at least 6 to 7 bands we can fire, and there is no limit how many bands we can apply for a particular patient. Generally they require 4 to 5 bands for the total ligation. We start at the G junction and then we spirally come up, and so that even if the band sloughs out that area, there is no stricture development post-operatively, and 4 to 5 bands can be fired either electively, or even this band ligation system is quite useful even in active bleeding for that matter. Now here you have a video of the band ligation. The band is loaded at the tip of the scope, and the esophageal varix which we want to ligate is sucked in this cup, and after we see a full red glow, that means the total varices has been sucked in the cup, we fire the band, and here 4 bands have been fired. After that we repeat endoscopy after 6 weeks, and any residual varices, if they are there, they can be eradicated. But this band ligation is restricted only to the esophageal varix and not to the fundal varix. Now, this is a patient of a fundal varix which was bleeding quite actively, as you see here. And often they don't have hematemesis. They come with giddiness, they come with melena, hypotension, and like that. And for them, the line of action is we have to inject them with a glue that is called as a cyanoacrylate glue. There is a definite technique by which it has to be injected. The glue has to be injected at the distalmost part of the varix, and it has to be necessarily injected inside the varix so that the cyanoacrylate glue, it doesn't come in contact with the mucosa. Otherwise there will be surfing of that gastric wall. So we take about 21 gauge needle, because that solution is little viscous, about 0.25 ml or 5 ml depending upon the size of the varix. First we have to calculate how much amount of saline that injector can take. Usually it is about 2 ml. So we keep a syringe ready with 0.5 ml of glue, another syringe ready with 2.5 ml of saline or water for injection, and another 10 ml syringe ready with the saline. The sequence is first we inject the varix with the glue. Immediately thereafter we have to inject another 2.5 ml so that the entire 0.5 ml of the glue is injected inside the fundal varix. And then thereafter we can use that 10 ml filled syringe for the flushing of the needle so that it doesn't get blocked. So this sequence has to be very rapidly followed, and you can see it here. The assistant has to be trained properly. The entire team in the OT, they should wear the goggles or the specs, because there could be some splashing of the glue occasionally and we can damage the sclera. After the glue is injected, that 0.5 ml or 0.25 ml of the glue, it polymerizes and it becomes large in size, and it also gets hardened up. And after say 3 to 4 weeks of time, this glue is extruded from the varix, leaving the varix totally fibrosed. So this glue therapy is best for the fundal varix, and that is the gold standard of treating the fundal varices. Almost 100% of the cases, we are able to give a good therapeutic benefit to all these cases. Now, this was a patient of GIST, the gastrointestinal stromal tumor. And this was again a young patient, about 30 years of male. He was sitting in his office around 4 o'clock. He had feeling of little faintness, and he collapsed in his office. Immediately he had melena. He was taken to the local doctors there, and then he required about 4 to 5 units of blood because he was very rapidly losing the blood. The colonoscopy also was done in the meantime, which was negative, and then in the middle of night this patient was brought to our hospital. And as I said that the endoscopist particularly ready to treat such cases, his team should be ready 24/7. My response time for last 30 years is just 1 hour. If I get a case of severe bleeding in the hospital, within 1 hour, including me, my entire team is ready, and we are there to support this patient. Now, this patient, the dictum, as I told you, that if the patient has got a hematochezia, don't do the colonoscopy, because often we don't see anything in the colonoscopy, and often the bleeding, the source of bleeding could be upper GI. Upper GI bleeding is very good for us because we have got all the therapeutic capabilities to control it, number one, and we can diagnose also it very correctly, accurately. And this dictum, actually, it saved me for the first time. I got only one case in my life like this, and all the cases I do the upper GI scopy when they come with melena, but this patient, the cause of bleeding was in the duodenum. It was the upper GI scopy actually. The patient came with hematochezia, and he was actually bleeding in the middle of night. Now, the problem was, it was a pear-shaped, little hard type of a swelling. It was not amenable for the clipping at all, and the patient was bleeding. So I injected glue as per our principle. At the distal most part, the glue could not go properly because the swelling was hard. Then what I thought, that the opening from which the blood is coming, I directly injected some glue in that opening. The entire aim was to stop the bleeding, and that worked, and the bleeding stopped. The next day patient was asking for the discharge because he was perfectly all right. He received 2 units of blood in the night. Then we investigated this case further. It was a GIST from the third part of the duodenum. We did a partial duodenectomy later on, and then he was all right. So actually, these all these cases of the upper GI bleed, they are amenable for the treatment very well. These are the cases which endoscopists can take as a challenge and can perform best, particularly the upper GI bleed. When it comes to the lower GI, the bleeding, the source of bleeding is in the small bowel, large bowel. They are difficult to diagnose, they are difficult to manage, they are difficult to treat as well. There are some solutions for that also, but particularly the upper GI bleed is always our baby, and I think we should do best for all these cases to treat them. In conclusion, when the patient comes to you, you categorize this patient, whether this is a low risk or the high risk stratification. Depending upon that, you perform the admit the cases. The schedule the scopy as per your thing, whether it is urgent or it could be a scheduled case, depending upon this patient's condition. The case which I did in the middle of night was, we never go always, but sometimes, because this patient already received 5-6 units of blood. He still was having hematochezia, not melena, and he was in shock. So I think that such cases, they need to be attended on priority without any problem. And preoperative optimization definitely helps in patients, particularly the cirrhotics. The patient of esophageal varicose bleed, if they come in the middle of night, they get a bottle of blood transfusion, and they also get optimized, and then the next day they are always scheduled for the banding or whatever treatment is required. And use therapeutic all the modalities very efficiently and with rationally. Thank you very much.
Thank you. Thank you very much, sir, for an excellent, detailed and in-depth knowledge, awareness on the upper GI bleed. Definitely a very interesting topic. And the last case was really interesting. I just wanted to know, did the patient need any blood transfusion after the huge loss of the
Yeah,
gist?
the patient was already transfused couple of units of blood before he was brought to me. We also transfused him because he was bleeding very aggressively.
It's a great job, sir. You have done in the middle of the night. And similar case, even I had, it was a D3 gist at D3 level, which was a large tumor. It was having a lower GI bleed, and the cause was unknown, which was diagnosed in a CT scan. And then the patient, because of the tumor, they were suspecting retroperitoneal sarcoma, even in CT. Then MRI clarified our doubt and had to be done Whipples for that patient. And that patient, interestingly, had a septum in the common bile duct as well, just for the knowledge of the postgraduates. So in my life, I've seen the first case which has a CBD with the septum in the middle. So the lumen had double lumen of the CBD. And that was hepaticojejunostomy was done. Patient went on well. So excellent. Any queries, any questions from the delegates? Please, you're welcome. Please feel free to ask any question. This is the greatest opportunity we have here.
One just line on the culture of the endoscopist on the upper GI bleed. The endoscopist, if he is a surgeon, then of course he should do all the things as the endoscopist should do, the therapeutic endoscopy or the diagnostic ones. But then he should know that what is the limitation for the upper GI endoscopy and the therapeutic endoscopy. For an instance, if the patient has got a duodenal ulcer, type 1A, he is bleeding actively, you are given epinephrine, you are done clipping, that bleeding has not stopped. The next step, of course, I have got now 3 options. Either I have to do a over the scope clipping, number 1. The second option is refer this patient to the interventional radiologist. And the third thing is I act as a surgeon and take this patient for surgery. Out of this, if you really ask me, the over the scope clipping for the chronic duodenal ulcer, if the patient is bleeding, it doesn't work because the areas are fibrotic and the clips, they won't take up properly, and we may lose further time. It will further traumatize that area and the bleeding will increase. The best option at this stage is to refer this patient to the interventional radiologist. They can treat them well. If they are also not available or for some purpose, then you have to take him for surgery. Then you pray God, because I had a couple of occasions where I had to do the surgery for the bleeding duodenal ulcers. It is a challenge, it's a catastrophe. It is not a very simple job to do.
And one more small question. In case of ERCP bleed during the papillotomy, so what would be your takeaway message for the gastroenterologist? Many times it happens as an accident or this thing. So
now,
because it was a
nowadays,
topic of upper GI bleed.
yes, for the ERCP and for the papillotomy, nowadays we are doing mostly CRE balloon dilation. So there the area of papillotomy is only 1/3. We are not doing the complete papillotomy, and the rest is the CRE balloon dilation. The patients who are otherwise biliary compromised, they are already having some bleeding problems, cirrhotic patients and all, they tend to bleed in spite of the sphincteroplasty, I will say. And these cases are then to be treated by, again, epinephrine injections. And sometimes the last thing sometimes you can do is the putting a SEMS, a self-expandable metal stent, covered stent. If we put, then that bleeding can stop.
Thank you, sir. You have
the pathophysiology of the esophageal varix and fundal varix is a little different. And thanks to the work of our own person, actually, Professor Sarin, who has given the classification for the fundal varix, the GOE 1, 2, and IGV. This classification is now accepted worldwide, given by Professor Sarin from India. And the collaterals that they develop, where they are close to the lesser curvature and some are to the greater curvature, and sometimes they are independent. And there, if we start doing the bending, perhaps, we may catch the wall of the stomach. The wall of the stomach and wall of the esophagus is little different. So there we can create a perforations and the damage could be more. So the fundal varices, they are typically managed by endoscopists by cyanoacrylate glue. And nowadays, the US endoscopists, they are coming up with the coiling. The another advantage, the only singular advantage of US guided coiling and glue therapy, US guided, is that even in the worst scenario, that the entire field is full with blood, endoscopists cannot see anything. Their US person can see everything. So he can still go ahead with the therapeutic procedure. So for the fundal varices, only two, the either endoscopic guided glue therapy or US guided the glue therapy, or it could be coiling, yes.
Thank you, sir, for your topic of extensively you have described about endoscopic management of the upper GI bleeding. And you have taken so much of pain to travel from the Sambhajinagar via Hyderabad to Bhubaneswar, again to Berhampur. Thank you, sir.
Thank you, sir. It is a great privilege to introduce our next distinguished speaker, Dr. Satish Meeda. He holds multiple prestigious qualifications, including FIAGS, FICS, EFIAGS, FAGIE, FIAS, and many more, reflecting his extensive training and dedication to excellence. He is a highly accomplished laparoscopic and gastrointestinal surgeon, as well as a therapeutic GI endoscopist practicing in Vivekanand Hospital, Ranchi. His leadership in the surgical community is remarkable, having served as the former president of IAGS, former national president of NMO, and former chairman of ASI Jharkhand. With such vast experience in both clinical practice and academic leadership, we truly are honored to have him with us today. May I now invite him to take the stage for the topic, Therapeutic Upper GI Endoscopy and the Role of Endoscopy in Upper GI Malignancy. Welcome, sir.
Good afternoon, namaskar to everybody. Praying to Lord Jagannath, I bring greetings from nearby states, Jharkhand. And at the outset, I would like to thank the faculty, the whole department under the leadership of Dr. Patnaik, Dr. I. Gopal, who have organized such a wonderful course, Dr. Madhuri and other people, and of course our FIAGS board and the faculty who have traveled all the way from different parts of the country. Learning endoscopy, I think those who are become the fellowships, you are really lucky persons, because we were trained like eklavyas. We traveled from here to here, nobody was there. We just learned tits and bits from here. It was not a protocol learning, but we had the passion of learning. And at that time, things were not available also. When I was doing my post-graduation, I saw few endoscopy workshops in one of the ASICON workshops. Dr. Nageshwar Reddy, way back in 91, they had conducted a workshop in Hyderabad. That gave me an inspiration to learn these procedures. So after doing my post-graduation, I went to Hyderabad and met few of surgeons there, people there. Went to Nizam, went to Dr. Nageshwar Reddy, then went to Dr. B. Krishna Rao, and Dr. Amit Mahadev, and many other, Dr. Mahesh Goenka, Dr. S. Patnaik in Kolkata, and picked up things from here and there. And slowly I started endoscopy, then colonoscopy, and I was the first to start ERCP in whole of my region. At that time it was not available, no DM was there. So, but now we know that surgeons need to learn endoscopy because things have changed, and in coming years the role of endoscopy is going to increase more and more. And it's not just one skill, but it's an armamentarium by which we will be able to offer more to our patients. So moving on to the role of endoscopy in therapeutics, I think there is overlap of many of these topics because some of the things have been covered. So I'll just rush those things. So you see that how the endoscopy has progressed, and various things have started from endoscopy to ERCP and now EUS and third space endoscopy, and all these things are progressing and these things will continue. So these are some of the few things where endoscopy comes into play. GI bleed, already we had a lecture on it. Foreign bodies, we are going to have a lecture on it. Then polypectomies, EMR, dilatations, stenting, pyloric dilatation, and many more. So this list is very long. And we had discussion on bleed, so I will not dwell much upon it. But it is something which has to be done now in peripheries. It is not to be kept something for tertiary or other hospitals, because many times it's very difficult for patients to be transferred. But fortunately, bleeding stops in majority of the cases spontaneously. But these 10 to 15% of the patients will need endoscopic help. And we know that these are the various causes of non-variceal bleed, where we can rescue the patients in many of these cases. And there are various armamentarium which we have to acquire, like a heater probe, hemoclip, and all these must be available as we want to manage more difficult cases like lasers, APC, all these. We need to acquire these armamentarium as we progress in our program. Forest classification already dealt. So these are the different types of bleeding which we can get. And these are the treatment options which we are available. And again, these patients have chances of rebleed, which we have to keep on. These are the different agents which can be injected as sclerosants. And we have to inject around the submucosa. And for thermal, either electric current or laser can be used to stop these bleedings. And these are the advantages of laser, but laser is costly and is not available in all institutions, so mostly electrical current is used. Clipping is a device which we must have in our armamentarium for various things. Now these disposable clips are available and they are not very costly, so we should have with them. Many a times it can be life-saving to these patients. These clips usually fall within 7 to 10 days when the healing occurs. Variceal bleeding, we already had discussion on it, and it is one of the procedures which can be learned very easily. Nowadays, most of the esophageal varices, we do the banding, and if there are some left at the last, we'll do the sclerotherapy, but most of the time banding itself heals those lesions, and glue injections can be given in the gastric varices. If there are lesions like gave watermelon stomach, gastropathy. Then we have to apply the APC, which gives a very good results. Foreign body extraction, different types of foreign bodies are found. So this is again one of the things which even the beginners can start doing it. You need just few accessories to start with, a rat tooth, a basket, Roth's basket, so that most of the time you can catch hold of this. So many children will come with who have ingested coins or batteries or some toys, and they will even dentures. Nowadays dentures are uncommon because they are getting the fixed one. But we get interesting cases and give a good relief to the patient. So these are the foreign bodies which we can have. Even meat impaction, food impaction can be there. And sometimes these drugs, people, they can have it. Recently, just 10 days ago, colonoscopy, I had one full bottle inside the colon, so which I could remove it without. Another therapeutic thing which comes in upper GI is the esophageal stricture dilatations. So many of these patients presents with stricture for various causes, maybe pepticus strictures or maybe after ingestion of some caustic agents, and we have to rule out whether these are benign or malignant. If these are benign, then we have to dilate. There are two options. You can dilate it with Savary-Gillard's dilators, or you can use balloons also. So there are different types of guide wire type, balloon type, or optical dilators are also there. And we can dilate the strictures usually under C-arm guided. But if there is just a small ring-like thing, then we can use the balloon. But we have to tell these patients sometimes they recur also, so they need repeated sessions also. But we should not be overzealous in dilatations. When we are dilating, just dilate 3 marks above the whatever was this narrowest part, so that you can keep it reserved for this next session, because perforation is quite common, and sometimes in caustic agent we may have to locally inject steroids also. These are the balloon types of dilators which we use. Then there are optical dilators also. So you can see the pre and post dilatation images after the dilatations. Then many of the patients will come with dysphagia who cannot be taken up for surgery in malignancies, or sometimes even the benign strictures. We are using the different types of stents nowadays. So these are the SEMS, these are self-expanding metal types of stents. Now there are stents which can be removed also, but mostly we are using for malignant cases for the palliations. So the other thing which we can do is the PEG, percutaneous endoscopic gastrostomy, for feeding patients, especially neurological patients or those who cannot swallow. This is one of the procedures which we can learn, even the beginners can start doing. So PEG, even jejunostomy can also be done. It's an extension of PEG. Bypassing a jejunal tube also, it can be done in gastroparesis and even in severe gastroesophageal reflux patients. So these are the steps of placing a PEG tube. The upper GI endoscopy has definite role in the management of achalasia cardia. It could be balloon dilatation. Again, in selected cases we do it, especially those who are unfit for surgery. And then endoscopic botulinum injection. That is again a temporary procedure and has taken. But nowadays the most common procedure which is performed is the poem. So this is again a different chapter in itself. So this is a thing which has revolutionized the upper GI endoscopy and has taken us to the third space where more and more procedures are being done after this poem. So for doing the poem, you need, besides expertise, you need a good setup, a good endoscope, a good diathermy unit, some accessories like hybrid knife and etc. You have to use CO2, you just can't use air irrigation pumps, and it has to be done in OT under GA and gives a remarkably good results. Even third space endoscopy has come in where we can resect many of these tumors who are submucosal tumors in toto by going into that space where we are performing the poem. Then many procedures have come up for GERD. Many of these procedures are not very popular because they don't give comparable results to the surgery, but they are available like endoclinch, plicators, strata. So these are the procedures which can be done in selected cases, and some centers are offering these patients in few cases and they are having good results of their own, but many of these patients are mostly tackled by some sort of surgery. Now, only diagnostic is not important. Now we are able to do many resections, especially the early lesions can be resected by EMR or ESD techniques where we can remove the tumor. Now it's even possible to remove the whole, means all the layers. You can make a hole in the stomach and just close it, or it's possible to clip those holes also. So more and more cases are being taken by therapeutic endoscopists. So this is the one of the steps of removal of early gastric cancer by EMR techniques. ESD, in which we remove the en-bloc large tumors, and it's more established in the stomach than in the colon. Polypectomy, like colon, even these polyps can be removed. Early neuroendocrine tumors, both in stomach as well as duodenum, they can be removed. And similar steps like colonic polypectomy have to be performed. There are some recent advances also, notes, which was earlier not that in fashion, but still picking up in some centers. It's not very popular. Our Indian surgeon, Dr. G.V. Rao from IIG Hyderabad, was first to perform the notes appendicectomy. But again, some interest has developed, and these are the procedures which have been done through notes, but again, still not very popular. These are the procedures which have been described in humans, like appendicectomy, cholecystectomy, gastroenterostomy, and cancer staging by notes. So these are the steps of notes. So advantages: no wound infection and no incisions and no post-op adhesions. So notes can be future of surgery. Those who have passion for it, they are, especially after robotic surgery, they are rethinking of going into notes again. Now coming to role of endoscopy in upper GI malignancy. So we all know that endoscopy has a role both in early diagnosis, staging, treatment, as well as follow-up. So in all stages, we need the help of endoscopy. And for we have already seen the use of NBI, various forms is there. So we have to know these, and we can detect the lesions in the early stage, and then we can stage the disease, and we should know the classification of NBI. Earlier chromoendoscopy was used, and with this there is increased polyp detection rates, and other lesions can now be detected, and some of the lesions can be resected, as I have already taken, by ESD or EMR techniques, and then we can follow up these cases as per need. And it has been seen that many of these lesions can be early detected. So these are the other, like FASI by other company, and we can see the magnifications also by this technique. So narrow band imaging provides different types of classifications also in various diseases. So this is just a broad thing in the therapeutics which can be done, and there are many more also which are being added as the advancements are taking place. We have to take the help of other, like for staging we need the help of endo ultrasound also, that what is the extent of the tumor, accordingly we can go further. So I think we start with the upper GI endoscopy diagnostic, and slowly we progress on to various therapeutics as per our need and armamentarium which we have. Thank you.
Thank you, Dr. Mirda, for extensive description of therapeutic endoscopy. Any questions?
Thank
you. You are as the past president of EFIGES, IAGS. Thank you. You have come all along from Ranchi to this place for giving beautiful and excellent lecture on therapeutic endoscopy. We are fortunate to have this because of efforts of Dr. Aigopal and Dr. Shiva Patnaik. Because of them, they have conducted this so that in our place, you, the young surgeons, could get this benefit. Thank you.
Thank you so much, sir, for your kind words. And I sincerely thank our chairpersons for moderating the session. I would request now all the fellowship candidates to proceed to the emergency OT for live colonoscopy. And with this, we also now proceed for the demonstration of simulation exercises by the faculty and lunch, which would be continuing till 4:30 p.m. Thank you.
Thank you all.
All delegates, everyone, kits are available at the registration counter. You can collect those. We'll get you.
Hello everyone, in this video we're going to download
Hello, 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 check, hello. Aku deh.
Good afternoon. Good afternoon, delegates. A warm welcome back after the lunch. Hope you enjoyed the lunch and had a chance to recharge. We are now moving into the next segment of our program for the panel discussion. So please be seated and let's take the discussion into next phase. Now I'm going to introduce the chairpersons of the next panel discussion. Welcome back to our esteemed speaker, a renowned laparoscopic and GI surgeon and former president of IAGES, Dr. Satish Midha, for the panel discussion. So, kindly grace the podium. So, for panel discussion. Panel discussion topic. Now let me first introduce the moderator. We are delighted to once again have with us esteemed speaker, a dedicated educator and leader in the field of endoscopy, Dr. Satyapriya De Sarkar, with over 13 years of experience as an examiner and teacher for FIGS, FAGIE and EFIAGS, and his role as chairperson of EFIGS Board of IAGEs. He continues to sharpen surgical training at both national and regional level. We are privileged to have him back on the stage. May I request him to kindly continue with the session as the moderator for the panel discussion.
We are delighted to welcome back our esteemed speaker, the director of Krupamai Hospital, Aurangabad, and a pioneering We are delighted to welcome back our esteemed speaker, the director of Krupamai Hospital, Aurangabad, and a pioneering figure in endoscopy and surgical innovation, Dr. Vijay Borgankar. It is my pleasure to introduce our next chairperson, Dr. S.S. Mahanti sir. He completed his MBBS from SCV Medical College and went on to pursue his MS in General Surgery from MKCG Medical College, Barampur. He joined MKCG in 1992 as a lecturer and has been serving actively involved in surgical education and training. He is currently serving as an associate professor in the Department of General Surgery at MKCG. With extensive expertise in general and laparoscopy surgery, including the endoscopy and colonoscopy, he brings with him rich clinical and academic experience. We are honored to have you with us, sir. The topic for panel discussion is prevention and management of complications of upper GI endoscopy.
Hello. 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 So we are going to have a panel discussion with very esteemed panels. We'll go through the slides and we'll discuss one by one. Overall thing, we have actually have quite a few classes on upper GI, but now the end of that one, how we'll move about. What are the points we should do? That's again from Kolkata, warm wishes, and these we got the pictures of your place, looking nice. Tonight we are planning to go this way. So coming to actually you can hear there, is it working? Okay. So first we have made these points that why do the complications occur? Complications during the diagnostic endoscopy apart, not much. Complications during the endotherapy, that's much more actually. Trouble prevention and management, we'll hear about their points. And guideline for safe endoscopy practice at the end. So importance of informed consent. As you know now, everything, whatever you do, the medico-legal things have really diversely. They go to the consumer court, they go to the council, they go to the courts, and government is allowing all of them with the same thing which may be useless. Still you are having a lot of harassment. It's not that most of them are not convicted, but they are harassed definitely. So we also have to be very careful about, and this is actually a surgical procedure. So Dr. Vijay Borgankar, please, the points of informed consent, what are the points you want that to be highlighted?
Before we undertake any endoscopic procedure, an informed consent is necessary. And this consent has three components. One is a consent for the procedure. You have to inform patient which procedure you are doing, what are the likely complications of the procedure, and is there any alternative procedure available to arrive at a diagnosis. The second part is consent for the anesthesia, because these patients might require sedation, sometimes a deep sedation, propofol. So a consent for the anesthesia is important. And the third part of the consent is in the eventuality of any adverse event occurs during the procedure, the patient might require some further treatment in the form of a ICU admission or could be any even procedure for that matter. So all these three components, they should be involved while we take the consent, and they should be conveyed to the patient in the regional language as well.
That's very important, that language which they can understand, you should make this thing. And they say the few points are there. Number one, what else you could have done? Why endoscopy you are asking, not but CECT whether can be done, whether MRCP or another thing, can you do it? That also you should say that you have already told them that these are the other. And again, they are limitations. So why you are choosing out of that endoscopy, that's another one important point. And again, what else could have been done if you don't do, if they refuse to do this thing? And adverse reaction, how maybe rare this thing, write it down. It happens rarely, but that time the first thing they go to the court and say that they were not informed. So you have informed them verbally, everything, but they simply say that I am not informed. So it should be written, and then below patient and witness and your signature should be there. So court you say, okay, I also do not know, it is written, that means it is taken. Otherwise you go for 1 hour discussion and then they say no, not a word is told to them. That's a very, very common thing. So next one, and your any, please.
Local language.
Yes.
Local language better.
Yes, yes.
That is understandable. It's always better to.
Kolkata we have Bengali, we have Hindi, we have English, all the three.
That is.
Yes, yes. That's also some places they make a small room where they go and discuss and they record the whole thing, voice recording and the audio visual recording. But some of the time those who are very busy, it sometimes may not be that, it is time consuming because the main person has to come. Here at least any of your assistant or nursing staff can show it to them. We have a separate bench where they go to them, they read it out and then they sign and then we only start. Satish, any point extra, anything we have left for medico-legal consent?
I think this must be done. Many times we see that it's being followed and in the problematic case it is missing.
Yes, yes, yes.
So this is the usual practice.
Yes, yes.
They are doing it every time, you don't see it, but the case in which the problem has occurred, some formalities were missing. So this is the usual case. Because you believe that your subordinate has done it, but I think this must be followed.
Thank you. Dr. Orko Prabodai, another faculty, his training is late, so he has come. So a big hand for him. I request if you can arrange one more chair or so he can join the panel. Now join in the panel. We'll discuss. So why it is indicated, how it will be done, outcome, is expected benefits and any potential risks. These are the points. Now we have shown, this is one from Ishar Murthy's place. So I thought that that they have given in the Tamil language, so that way to highlight the regional language. Now patient on antiplatelet drug, single or dual, referred to the elective endoscopy for dyspepsia. Orko, what do you suggest? How you will do it? Diagnostic case, antiplatelet, single or twice? You sit.
Sir, I didn't get a question, sir, again.
Patient on antiplatelet drugs.
Okay.
Maybe single or dual antiplatelet. Because now so many patients are, elderly patients are having stents and this thing, cardiac stents especially, and other vascular things. So when those patients come for endoscopy, what precaution you take?
Firstly, we would firstly do the coagulation profile and the general CBC of the patient. Generally at our center, we do not do endoscopy if the hemoglobin is below 8. at least 8 milligram per DL hemoglobin is mandatory for doing an endoscopy. Secondly, if depends upon the indication of the patient for doing the endoscopy, if it's a acute bleeding or a life-saving procedure, then we go ahead with high-risk consent. If not, then we correct the coagulation profile and then.
How long we'll wait for that? Dual antiplatelet, how long we should defer if it is not acute emergency? How long we should defer?
Generally, I have seen it being deferred for like 5 to 7 days at least.
Yes. I think all of you agree with 5 days or anything else.
Another thing is that most of the times the case is referred from the cardiologist.
Yes.
To exclude the dyspepsia. That this is not the cause of that pain, retrosternal pain and other things. And that we must, I think patient on antiplatelet drugs, I think we usually don't
they say
no
that
to the procedure.
only diagnostic if you do and the mucosal like RUT if you take.
Yes, yes.
But don't go for polypectomy, don't go for APC, don't go for any of those things.
For diagnostic purpose, I think
you
we can
can
proceed with
take
that.
it,
Therapeutic
but-
procedure, we can wait for
Vijay and Satish.
Yes, there are definite guidelines about the antiplatelets and all that. The routine diagnostic procedures, they can simply go ahead without holding any of the antiplatelet, no alteration in the drugs. A cardiac fitness is there, you can go ahead. There is no- If you are planning to take even a biopsy, then of course, if the patient is on dual platelet, the clopidogrel has to be only stopped 5 days before. Aspirin can continue even with the biopsies, and with even other procedures like polypectomy, if it is not advisable to hold aspirin, you can continue with aspirin and do that procedure. If the
Satish,
patient
what you
is on
do?
valve, mechanical valve particularly, and the patients who are on warfarin, then of course this warfarin has to be stopped at least 7 days before.
Yes.
Patient has to be taken on the low molecular weight heparin, and again after the procedure we can resume to the warfarin. Now, since we are discussing about the drugs and the endoscopic procedures, there are 3 more issues. The patients who are on antipsychotic drugs, the patients who are on anti-epileptic drugs, and they should continue as they are under antithyroid for that matter. All these drugs should be taken on the day of procedure with a sip of water. The patients who are diabetic, if the patient is on insulin, of course we have to do, all the patients diabetic, we have to do the sugar level before the procedure. And
those who are on OHA tablet?
And the evening dose of the oral anti-diabetic has to be stopped day before. On the day of procedure, there is no oral anti-diabetic, and after the procedure, the drugs can continue. So this is overall the
Drugs which
medical
they usually
treatment and the endoscopies that we have.
Satish, anything to add or same? I think they are repairing something. So next slide here. This connection has not come. Oh. Because of So causes of what we say unplanned events, that complication, and we want to say this nothing complication, unplanned events requiring other procedure also. High risk patients, ISD, poorly controlled diabetes on clopidogrel, aspirin, warfarin, we have already talked about that. Poorly controlled diabetes mellitus, anything you can, any of you can say, the patients who are on like 350, 400, 450 blood sugar, CBG.
Sir, in those cases, sir, as for diagnostic endoscopy, it's not contraindicated. We can go for the, but for therapeutic, larger dissection or polypectomies,
ESD polypectomy or POEM.
I think we should normalize the glucose and then proceed.
Any opinion?
Yes.
Before the big procedure.
Agree.
And high risk endoscopy team, that lack of experience and training, that's very important. I always should tell all of you that you should know your limits up to what you can do and who are also assisting you. That's also very, very important. New place, new assistant. I have seen all over India and all many of the countries I went and I did the live cases there. A new place, new machine and new assistant, 50% your efficacy goes down. What you are doing every day so easily, you really struggle going there. Own team.
Own team.
And I've seen later the few of the international faculties, they with their own experience, they bring their assistants from their country. They really to show you the complex procedures that they do. So endoscopy under LA or sedation and dangers of sedation. So I am one who does a lot more endoscopies under sedation. So many others are doing the under LA. But if you have this sedation, then what precaution you should do, Satish? Doing under sedation, usually the tramadol or Jofor or this thing, then Buscopan and the midazolam. These are the usual things. Propofol we use not without presence of any
If you are using sedative drug, then you should have an antidote available for that drug. And you should have the emergencies set up available so that if there is any respiratory problem, arrest or any cardiac event, then you should be able to manage these. Emergency cart should be ready. Ideally, in this medico-legal era, if you are going to give sedation, you should have anesthetist available. But if you don't have anesthetist, you should have a trained, qualified staff, because endoscopist will be busy during the endoscopy. The proper monitoring, patient should have an IBP and then pulse oximetry and ECG leads connected if you are doing all these procedures.
Very important, we always do under the mentor, cardiac monitoring, saturation and all these things, and they say that one of your assistants should be specially given that responsibility to look into that. Many of the time we are glued to the endoscopy picture. So they should immediately say, and I want one of the ICU trained sister to be in there. So though we have always online on-duty anesthetists in our hospital, still it may take some time and maybe crucial time. So ICU trained by good persons, they exactly know what to do, because these are usually always very temporary things. So even that moment, and midazolam, the flumazenil is the antidote, what he is saying. Flumazenil can be given in 0.2 milligram. That come in 1 and 0.2 milligram you should give. And again they also said that about the only flumazenil problem, if the patient is a epileptic patient on anti-epileptic drug, having some respiratory problem for midazolam, if you give flumazenil, that not only blocks the midazolam, that again counteracts with the anti-epileptic drug also. So then the patient can have epileptic fit after flumazenil. So please know all these points.
These usually never go for mortality, but we should know all these things so we take proper measures. So list of complications, the cardiopulmonary is the commonest they say, but arrhythmia, MI, hypoxia, aspiration are very uncommon and usually very mild amount. And if you immediately just detect it and you do little aspiration and withdraw the scope, stop, wait for a little time, give oxygen, nasal oxygen, like I always give nasal oxygen to every of my things. Many people used to say they don't give, but later I found out in American guideline they are saying yes, nasal oxygen helps in all the endoscopic procedure. So that I did. Drug-related event we have already discussed. Dr. Vijay has nicely said that anti-epileptic, also diabetic, and those cases what you do. Now infection is an important point from endoscopy to the patient or from the contaminated endoscopy. You already had a CDS class there, leak test and the CDS class. They said number one, no HIV or Hep B C usually are reported to be transmitted through the contaminated endoscope till date. But the bacterial infection are there. Out of them, Pseudomonas is the most dangerous infection goes. So in between cases, especially when we have a big crowd, a huge output of patient in, so that cases I feel that we should be very careful, don't be negligent. Many of you during your primary learning curve or when you are junior, you go to different places, the back, I shouldn't say the marginalized places. And those places, they don't have anything. So they force you that you have 30 patients and you have to do it in this hour. And they don't allow you to do any this CSD, though we don't need any, we don't need sterilization. We need high-level disinfection. But that high-level disinfection at least should be done. Ideally, everywhere we should have more than one scope or 3 scope in all good places, where one, then it goes for that high-level disinfection when you do with the other one. But most of the places, even now, you get only one. Here, I think in this medical college, how many endoscopes are there?
You have actually 2 scopes.
Oh.
2 scopes. But again, regarding infection, transmission of this HIV, HBsAg, HCV, that's also important, sir.
Yeah, very important, but they say in search the literature, they said that HIV transmitted from contaminated endoscope is not yet reported.
Pardon, sir? But again, I think a few years back in United States, an Indian gastroenterologist was barred on this aspect, community transmission of
HIV through the endoscope?
Yes, sir.
I don't know, but publication has searched it.
Come in the, but what is your take about this?
Think that what may be between each of the procedure, you must do high-level disinfection minimum.
What do you mean by that, sir? Practically
that is Sidex or the Paracets are there, Paracet at least 10 minutes.
Dr. Midha, sir, what is your takes on this, sir? Does enzyme?
Yes,
that is.
Mechanical cleaning has to be done before you put it in the...
Absolutely. Otherwise, they say if there are proper mechanical cleaning,
10 to 15 minutes, Sidex half an hour.
Yes. So, but
you see,
after the mechanical cleaning, otherwise it doesn't
possible.
enter into the area and it doesn't help. And also you should suck it, not the outside also. And also the gauge piece, suppose you come from above and below and don't take it again from below up. Above and below and throw it away 2 or 3 times. Otherwise you are contaminating the rest of the places also. That you should not do. And definitely a proper mechanical cleaning. And like in our place, we have Olympus, have other instruments are there where they can, each channel can be washed out. That also you should ask actually, wherever you are going to start, now the days are changing, I feel. We have made so many compromises because of lack of knowledge, because of so many other things. Nobody give us the options. But now you should say that these things should be there. And all these instruments, at the end of the day also, they should. Yes, yes, that's why I said
We can use
you need.
we
Please.
can use endo washers, which are now they are not very costly.
Yes, yes.
also.
We have endo washer.
Yes, and
that really for each channel you connect that one and then you push and they really otherwise inside it is going on silently.
And what is important is at the end of cleaning through the side X, again the irrigation by water, and then
Again,
air blowing. It
the
has to be
side
air
X
drying.
again that can cause a chemo problem. So again, not only that the thing we are doing, after that you should properly clean
Rinse
the
back,
inside
yes.
things also rinse
So,
with the water, proper water. RO water or properly clean water.
And the scope has to be completely dry before second use. This is only possible if we use the endo washing.
Absolutely. Endo washer is a very one because I am using it for decade. And really, it's, and your technician also should be given proper importance to that you have to do it.
And
they are
all,
happy that some person comes and he says, no, nothing is needed. They just wash outside and give it to them. But you should say, no, you cannot do that.
Injection needles to be discarded after use, never to be reused again by recycling. And all the accessories need to be ETO sterilized.
Another very important, see, most of these accessories are made for single use. But in our setting, nobody is made it a single use. But ETO now, because of laparoscopy, actually, and also the cardiac thing, the plasma and ETOs are now available very wide. Previously it was not there. So we should also, with their instrument, you send all these things so that the cost also becomes much more viable because the cardiac instruments, they are doing that. With that they put few of your instruments, so ETO or even the plasma, they can come out.
Nowadays, a few of the patients, they ask whether everything is okay or not.
Yes, no, definitely, and they have every right to ask.
Yes.
So next
Especially
is...
if you are doing it in the private sector, it's good. The demand rather.
No, and that's a logical demand. Bleeding. Now, diagnostic upper GI bleeding chances, if there is no double platelet or other, very less, but following the therapeutic procedure, especially after polypectomy. During polypectomy, there can be bleeding, but even late after polypectomy, as late as after 2 weeks also, the patient can come with a bleeding. And that's not an easy job sometimes. So that you should keep it in your mind that when you are doing all these things, that these may happen. And as morning you are saying, Dr. Ishramurthy, that you should give your mobile number to them so that if anything like that happens, and you should also tell them. And they say the information card also you should say that these are told to him that if he is having any problem, any pain, any bleeding, any reeling of head, all these things happen, they should come and inform us. That's important. Procedure specific will go there. A failure to diagnosing to treat is missing the lesion. Failure to recall the patient. That is one most important thing, is that when you do the CBD stenting, I have seen few patients coming after years. And at least 3 patients I remember where we could not take it out by endoscopic procedure. We have to go for open surgery to take it out. And definitely they have been told, but in all 3 cases I have seen in the endoscopy report, it was never written that remove this thing after 8 weeks or 12 weeks. So again, what you are saying now, it was done, but in the real cases they have not written it. So they will say that no, nobody told me. So in the report also you write it down, the stent has to be taken out within 12 weeks. For repeat endoscopy in suspected gastric CA, that is another. Suppose you have a very big gastric ulcer. You take multiple biopsies, all came as non-malignant. But again, they should say that after 2 months or 3 months, we should again repeat endoscopy and repeat biopsy. Because I have a suspicion we may have missed, because there can be some places which are malignant, some places which are benign. There can be some problem with the pathological assessment also. So these things we should be very careful that we have to mention this one. This perforation will come a little later, I think. perforation upper GI is very, very uncommon. That's why colonoscopy we have one, there we should go. But usually perforation happens in the anatomical problem or after big polypectomy or SMR. Like Jenker's diverticulum or wave, if you cannot understand the way we are all going, we are looking into that, then we are pushing, then it's fine. But sometimes definitely if you go on the back of the throat and follow the heart palate and back side, you go definitely. But then out of 1001 case, maybe there Jenker's diverticulum, where you cannot understand which is the diverticulum and which is the main luminal place. You press it and just force your way and you can have a perforation. Yes, that's why I'm saying colonoscopy is much commoner, but upper GI, unless it is a therapeutics, mainly the upper esophageal few things are there, the waves and Jenker's diverticulum. And another thing, be very careful about the corrosive strictures. They are not like others. Few of the corrosive strictures may have, he has been followed up and they made 8-9 times the dilatation. And you think, oh, if 8-9 times he done, nothing happened. But it can happen during your time. And be very, very careful. Most important, another one, Isha says that don't hold it like sword, hold it like pain. So don't give pressure. If it doesn't go, okay, it doesn't go. That's fine. For removal of biliary stent, we have already discussed. Timing of unplanned events before the endoscopy, drug related, drug can be allergic and respiratory depression. Again, we have discussed that we should know the antidote, we should know what to do, how to do. During endoscopy, faulty techniques, definitely. Again, if you are quite gentle, if you cannot, then discard. Suppose you cannot go into the esophagus, especially older patients. I remember out of 3 cases of very old patient, I cannot go past the cricopharynx. So don't take it as ego. Tell them there is some anatomical problem or old age, some spasm. I cannot. Don't force it away. That's the only thing I feel you all should take home message. Then after the endoscopy, procedure related, post polypectomy bleeding, what we have said, and post ERCP pancreatitis. Again, that can be sometimes very serious, though there are many drugs are coming out, and even they say that pancreas, if you more than twice gone without, you know all about the selective cannulation. So Satish, what you do in your case, you are doing ERCP regularly, but in your case, if you have accidentally gone 2-3 times into the pancreatic duct or given some dyes, so what can you do? Prophylactic, anything you advise?
Initially, for prevention, we hydrate the patient with ringer lactate and use NSAIDs, rectal indomethacin.
Indomethacin, they say that all the literature has mentioned.
But if you have gone 2 to 3 times into pancreatic duct and you are not able to go it, then you should go for other methods, either do a pre-cut or put in a stent into the pancreatic duct and then go for it.
Kolkata, 2-3 places, things I have seen, 3 millimeter that pigtail stent they have given into the pancreas, and I have removed that after 4 weeks. So that's again a standard treatment now going on. Next one. Cardiorespiratory asset, what will be your response? We told that there should be sister of ICU training and their ICU person should be nearby, and you should always, if you have a little older patient, cardiac comorbidities are there, you should talk with them so that if anything happens, they'll immediately come and do it. Pulse oximeter, ECG tracing, I always do. Abandon the procedure if something happens, always take the scope immediately out. Call for help those who are specialized in this resuscitation. This very quickly you have to do. And most of the patients resuscitated. But you have to do, they know exactly what are the protocols. We know sketchily, at least I, but they do it very expert hand. Look for and treat the aspiration, suction the airway, drug related antidote. These all we have discussed already. Bleeding during gastroscopy. Orco, the diagnostic endoscopy, very, very rare, but But therapeutic, what are the cases you feel there can be bleeding?
Or if there is a varix, we need to take if there is a gastropathy or severe gastritis in the lumen of the stomach. In the G junction, sometimes there is a mallory device that can bleed profusely, or if we have a mixed fundal varix, that can also bleed profusely. These are most commonly troublesome bleedings. Otherwise,
I think diagnostic. So what I feel that if there is the fundal varix bleed, especially in esophageal varix, they say even in emergency you go and band it again, wash properly, band over that. I have seen also 2-3 times very bad bleeding, but properly put a band, it stopped. Fundal varix, I think you have to go for the pharmaceutical, as they are saying. So I want to study now. Terlipressin is the drug of choice. That's the important thing. Give a bolus and then keep it for 24 hours. So that's the only way to reduce the portal hypertension. I told you that what are the percentage of portal hypertension, chances of bleeding. So reduce that one. And if needed, give resuscitation or blood transfusion. Because that case is immediately you cannot do the glue injection for a very bleeding varices. What you feel, Satish? Can you do when there is a fundal active bleeding accidental?
Means initially you should try it with the medical, but if bleeding continues, we can give glue injection also. I mean that is an option. We have done in few cases. And if expertise is available, then coiling by EUS.
Yes. Now endo ultrasound coiling are the fantastic thing. They stop almost everything. But suppose when you are doing the glue injection, if then it is bleeding, then you can continue with another dose of 0.5 injection by side of that. Maybe it has not filled the total lumen. You know the solidification of the cyanoacrylate glue, it works. So you give one more injection. Most of the time it stops. Again, I say that you should have a very good assistant. So what we do that we make it properly and ergonomically. Any fundal area is very difficult. Fundal polyps, even taking a biopsy, you sometimes struggle a lot. You are just not getting into that. So that's a very big problem. So, and your assistant exactly should know, we prick it, you cannot keep it for long. Immediately we give a little saline to see that it is going inside that one. Then you break also, you don't break and you cannot put it in a syringe. That will also. So immediately you break it and then there and then immediately you push it there. And after that also we give a little saline so that the whole thing doesn't stay in the thing and then go into the varices. And then very important, because around 15 years back, I forgot, I really made a mistake that I pulled it. And then the whole channel was blocked. It took more than 1 lakh rupees for repair. So what you do that you keep the whole thing outside. You cut from the outside accessory place. Take out the whole thing, then pull it from your mouth, from where it is coming out. So those are very important thing when you are going for fundal varices glue injection. Can we get it?
So normally we can control with adrenaline and
But fundal varices you cannot inject there. But fundal varix is the most, I feel, the toughest thing if it starts bleeding, and it really bleeds and then the visibility goes, worst thing. Already you are in a very difficult ergonomic situation and the visibility is lost. Diagnostic endoscopy, what you said that you were retching at the time, malarious can happen even during, very rarely, but when you are there, and that time if it retches too much, there can be a bleeding. But again, if you immediately give the saline lift, saline adrenaline, and adrenaline come in 1 in 1000, you should know all of them, 1 cc. Previously I used to dissolve in 10 cc, now it dissolve in 100 cc, because then you get a lot of amount of this thing, and you can inject up to even 30-40 cc if needed. So 1 in 1 lakh actually we inject submucosally, that really helps. Bleeding from ulcer or varix, we have already decided you can again go and bend on the point it is coming. If it is bleeding from the ulcer, Satish, what you do is active bleeding from a gastric ulcer and a duodenal ulcer. Do you approach anything different if it is a gastric ulcer, or the approach different if it is a duodenal ulcer?
In duodenal ulcer means the management of ulcers, which we have already discussed, that you have to wash the area, remove the clot, try to localize the vessels, even after local injections. If it doesn't, then heater probes, then metal clips, then these are the things which we
Many
have.
of the time clips are very good. If you can put
If
it
you can
properly,
localize the vessel, the clips are good.
or gastric ulcer, Vijay, if it is actively bleeding gastric ulcer.
This actually actively bleeding gastric also can be also initially controlled by epinephrine local injection.
Absolutely.
The quantity of bleeding will come down, and then either you can clip it, or then the gastric ulcers are even amenable for the over the scope clips. So that also is a good idea to control the active bleeding from there.
Can you do APC?
APC we can do, yes.
Because APC doesn't go deeper. The best part of APC is APC always acts superficially. So at least not causing perforation. Because trying to electrocoagulate it also can cause perforation, especially in duodenum. Coagulopathy, if there is there, but Orko has said that you should do the coagulation profile before and correct it and then go for therapeutic endoscopy. We know different things. Polypectomy is a different one. Sphincterotomy, what you are saying, that now they are cutting a little and then dilating it more, so that your chances of that severe bleeding are much less. Sclerotherapy, we have talked, coming. Bending, we have already. Glue injection also we have discussed. Again, perforation during gastroscopy, how clinically, sir, how you will detect it clinically?
Clinically, if you have got a Janker's diverticulum, you have perforated, so everything will be emphysema, neck, and other things. It's a problematic thing.
Surgical emphysema you will feel actually in the neck and all these areas.
Yes, sir.
And patient having
That's a
pain,
problem.
saturation goes on, pain on the shoulders and these things. But luckily one good thing is that rarely you need to go for operative things.
Yes.
Usually if it is not too much contaminated,
Self-limiting, you stop the
conservative treatment.
Self-limiting.
Life, I have two things, but all with conservative treatment they have perfectly controlled.
But during diagnostic endoscopy, rest of the parts, perforation, I think it's almost nil.
Therapeutic, we know
yes.
each by each
Yes.
things. Janker's diverticulum, post-cricoid web, and corrosive injury, and some of the even malignancy.
Yes.
If there is a huge malignancy and a little learner stage, if you want to push it, like today, there is a circumferential growth. I think Satish is doing is absolutely fine. He knows exactly where is he. He have an idea also how much you are pushing, and he was pushing, so they know that how much we are pushing, and they're looking that space is there. But for other beginners, I should say, take from the distal margin in colon or upper margin, proximal margin in upper, take 4-quadrant biopsy, come out.
So what is your take about this esophageal web?
Esophageal wave, I think we can pass a guide wire or even a biopsy for 7 closed, and over that we can pass the scope. The scope can act as a dilator.
Yes. Yes.
I feel that's a good thing. Another thing we have not discussed will come, dilatation of stricture of esophagus. That can also cause perforation. Balloon dilatation of achalasia also have seen patients having perforation, even not the first time. And polypectomy, ESD poem, we all know, as we are going deeper and deeper layer, so it's becoming thinner, you have to be more and more careful. Esophagus, no serous thing, so while you are going below only the thin muscle layer is there. Complications in therapeutic endoscopy, foreign body removal, Orko will talk about that, I'm not going into, but one thing I should say, the most difficult and risky thing I have found is the dental plaque. False teeth, if they have swallowed, then catching other thing are fine, but taking it out through the esophagus mainly, second time you may do iatrogenic more damage than what it was. So that is a very important thing. Now we have many hoods and others. I'm not going because we will do.
Another thing is, while you take out, during retrieval of the foreign body, it just slips into the
Yes, that's a very bad thing. I use the Rothnet maximum because at least it doesn't slip. When you are coming out near vocal cord opening and there you slip it. So can be real problematic. The benign stricture, malignant stricture, we have told for malignant stricture, if you are not expert, if you don't have the, if you know how to put the, that you are saying the self-expandable metallic metal stents fully covered, then you know that slowly. Now these self-expandable are very good because you can put it in deflated way. Then over days they go to the normal position. So their chances of perforation are far less. And now we have different types of guide wires also. So that guide wire is very malleable, you can pass it and you can see in the fluoroscope that is there, and over that if you do that self-expandable metal stent, those are real good. Ulcer bleed we have talked, bleeding varices we have talked, polypectomy we have talked.
What about ESD and complications?
ESD again, perforation is a very common one. You have to remember ESD is a very lengthy procedure. Sometimes it may take more than an hour if it is a big one. And you cannot saline lift at a time. So you do saline lift, cut a little, again do saline lift, repeatedly you go, because that saline lift is acting as the traction. Whatever surgery you do, laparoscopy also you know, traction in the right direction. Many times your assistant make your life really bitter because they are not properly, number one, pulling it and not giving in the right direction also. So here there is no one except the therapeutic, what you said, we do 2 of the gastroplasties. They have a separate thing, separate channel where you can pass it, can catch hold of that and pull it in a other way. That is also difficult because you are going through one channel like single lumen laparoscopic cholecystectomy, single port, because the ergonomy is not good. But still you can do, otherwise you have to give little injection, and that way then when it is lifted, cut. Now we have beautiful that knives are there. I have also used the triangular knives, T-knives, where you can cut properly and go very slowly. And again, problem is if small bleeding also happens, that bleeding may not be dangerous, but that bleeding is really obscure your vision. Vision should be very perfect.
Complications following EMR is
very low. Failure to retrieve the foreign body, very important one thing is dry run. That is, you see what is there and outside with your accessories, you try to, like a coin and other, if it is possible, you catch hold of that and see that your accessories at that particular day, it may be acting good previously, but on that particular day it may be not working. So outside the body, before you actually do one test that is called dry run. Especially for the child, the children are the most susceptible one. You give anesthesia and many of them you put a tube there. Because what sir was saying that while taking the foreign body out, there can be slippage. So that can go to different beds. If a patient is intubated, the child, at least that emergencies won't happen. So those are very important. Child they bring, everybody is anxious, you try to do some heroism. No, wait for that, wait for the anesthetist to come. Few months child come with the foreign body. So be careful, and if you ask the anesthetist, if he or she says that okay, please do it, I will need an intubation, do the intubation, then only go for that. Overtube is a newer thing. I am not saying again, Orko's presentation will show that's a very safe procedure. Hood is another one where the sharp objects, it has somehow gone. We do not know how it has passed, but while you're taking out, you can injure a lot. So keep the sharp objects below the hood. Hood mechanism will show that it is on the endoscope while you are going in, and while you are going out, it goes beyond your endoscope and you catch hold of that, and the hood will protect the sharpness of the foreign body. Risk of perforation and those things we have said. See, and this, suppose this type of safety pin, don't catch it in one place, catch it in the middle and then put the hood so that your chances, these are the small picture but important. Hold it at the junction. Dilatation of stricture, again, you should pass the guide wire, do strictly under the fluoroscopic guidance. Send this thing if you are going to put the stents, plastic stents, now not much, now metal stents are much more common. Now the fully covered stent has come, now slow. We are there, nothing was there. Now slowly the self-expanding stents have come, which you put in the deflated position, then it of itself, slowly it goes on expanding. And later you can go again, pass through your scope, through the thing. But again, Savary Gillard dilator, one of the all the instruments, these should be with all the endoscopy people. But again, there is a very important rule of 3. Suppose you feel you are starting with 7 or 9 or 5, according to how tight it is. But if you start with 5, go 5, 7, 9. If you start with 7, 7, 9, 11, never go beyond 3. I have one perforation, and that way I was over enthusiastic. Seriously, within 3 it was nothing, and the 4th one I put it, and then there was a perforation, small one. So what they have said, with their experience they have said, so go, number 1, put lots of jelly, be careful, over the wire you go, don't push it hard, but even then you do or follow the rule of 3, that are the different sizes of Savary Gillards are there. A management of perforation and after dilatation, what you are saying, again what I have asked, chest pain, dyspnea, surgical emphysema, you do a chest x-ray. Water soluble, now many types of contrast are there, urographin, gastrographin, which are water soluble, they won't do more harm. But if still there were any doubt, definitely do a chest, a CT chest or CT abdomen. Colonoscopy also, if it happens in the retroperitoneal space, only CT scan can tell you. Otherwise you may not get even the free gas under diaphragm. So that's very important. Only one what you should do a CT of that area. And admit, active observation, decide, conservative, as we have told you, nil orally, hyperalimentation, IV PPI and IV antibiotic. Wait for the few days, ask everybody, call for the CTVS surgeon and take their opinion. Again, they say if there is not big, very high, with that not too much contamination, if the comorbidities are not very bad, if there is not like 90 years old, all these things are not there, then you can wait usually. Surgery, very unstable patient, heavily contaminated mediastinum, that CTVS surgeon should take the decision. Now, after the FC, the fully covered ACMS self-expanding metal stent has come. Now many of these perforation you can put it there, and they are very well. Even after esophagectomy, there are papers that if there is not multiple smaller up to 2 centimeter, if there are anastomotic leakage, you can put a fully covered slowly expanding metal stent, and they are really 90% cases they heal. Now complication after endoscopic banding. Orko, what can be the after endoscopic banding?
There is a
and why transient dysphagia, why it can happen?
Yes.
Usually what therapeutic mistake you do, there can be transient. We start from G junction, then what therapeutic mistake if you have done where the bleeding has stopped but their patient are having dysphagia post?
We were too many bands in the same level.
Yes, always start from the G junction, go spirally up. And the same places on, sometimes there are very big varices. So at the same place you can give an anterior surface, you can give one posterior surface. But later there can be obstruction little because of the same stage you are putting bands, so that you don't do ulceration. All these banding are having some small ulceration during their process. We do it after 6 to 8 weeks and see. Before that, they have first superficial ulcer ischemia, then there is the vessels getting sclerosed, and then actually it happens. But rarely the ulcer can be deeper and there can be bleeding. Rebleeding during the procedure, as I said, you put another band. Wash it, see the exact position, put another band. If it rebleeds after, again go and see the place where it is rebleeding. You can put a band, but again remember, putting the band for the first time is very easy. Putting the band on grade 4 is very easy, but after they have already sclerosed, sucking that mucosa into your lumen and putting the band is a very difficult job. It doesn't come. And pharmacotherapy, we have already discussed that we can give that terlipressin. Endoscopic sclerotherapy. Now, we used to do, we have all started with endoscopic sclerotherapy, we know. There was no band. And so that time we had lots of bleeding during injection also. So there can be bleeding, can be deep ulceration, there can be mediastinitis, pleural effusion, perforation, aspiration. So what are the tips, Vijay, you take when you do? And now I do only in residual varices. After the bending, if there are few places there are residual varices but they are bleeding, I do that places the endoscopic sclerotherapy. So what tips you want to give it?
Use a small gauge needle, preferably 23 gauge. Also the needle should not penetrate at right angles, it should go tangentially so that esophageal wall is not perforated.
Very important, you can cross the whole esophageal wall and put it in the mediastinum, causing mediastinitis.
And use small quantity injections,
yes,
volume wise.
Very important, 23 gauge, but again remember when you are doing the fundal glue injection, you should use a thicker one, the 21 gauge we use, because otherwise through 23 it doesn't go, because it's much thicker. So that also you should know, important point. Not working. Glue injection, we have already talked about that. One point we have not mentioned, there can be embolization if you too much do. That's why the endoscopic ultrasound coil never have this thing. I have seen patients who died of this thing, pulmonary embolism on next day. So don't give it too much, give it in the right place. Otherwise, like venous embolus, it can go to the lung, kidney, brain. Channel block, lens damage, we have already talked. That's why be very careful and have a good team. Those who have seen, those who know exactly what to do. Because when you are doing, you cannot break it, you cannot do these things. So your whole team should know exactly what you are doing. Agile staff, spear, ample, and needle. All these things should be there. You have one needle and one ample, then it gets all in your needle only. Endoscopic hemostasis of bleeding ulcer, we have talked about this thing, that we can give the 1 in 1 lakh saline, adrenaline there, and can make it. We can saline lift, not only the saline adrenaline, even the tissue pressure also causes a hemostasis. Then we can, if we can point, we can put a APC, we can give like this parting, we can give a good clip over that one, if you can point. Risk of rebleed, need for additional method, hemoclips, thermal method. Thermal method, when you give it, don't be too enthusiastic, then you can stop the bleeding but can't cause perforation. And this is that, as I said, the self-expanding metal stent. This is much safer. When you put it, it is like that, and then slowly over days it goes up, makes the lumen, so it's much, much better. We are discussing the whole thing because what we do, and you may or may not do tomorrow, but I think this at least will be in the back of your mind. Yes. Stent failure, what are the things can be? So Satish, that ACM stent, after that, what are the things can happen? Under fluoroscopy, a past guide where put it the outside also we put some metallic thing so that we know exactly from where to where the growth is there, then measured that one. And it should not come also very near to the vocal cord and cricopharynx. So there are many limitations are there. I'm not going into details, but what can happen? Stent migration, how much you have seen?
Stent migration does happen. It's around 5 to 10% cases.
So any method to keep it there? Now they are saying some clip also they give it.
Now you can just put in a clip there. Or sometimes earlier when these clips were not available, we used to hold them. People used to put them near the nose or something like that. But now clips are there. So
put that one, yes.
And
food bolus, always that is what problem can be there with a food bolus if they take too much solid food.
We have to instruct the patients that not to take the hard food, or even if they are taking the liquid food, they must take water after it.
Yes,
but if it does happen, then if the stent is fully, then we have to go in and break those food bolus. Like
I've done good number of percutaneous endoscopic gastrostomy, and I've seen the same problem with the patient party. More enthusiastically, they are giving all the foods, and we told them that after each feeding, you must wash it. That food gets encrusted and they block the whole thing. So here also that thing can happen, and then GE reflux definitely can happen, and that can cause aspiration, especially little upper part when there is. So nothing is there, it can come up and do this, especially night time. And tumor, both this thing, ingrowth and overgrowth. What is meant by ingrowth and what is overgrowth? Ingrowth is especially when there is not covered. Through the net, it can go and grow inside the lumen and block it. And overgrowth means it's going in the proximally or more distally. Beyond the stent, beyond the limit they are going.
Then these, either you can go through lasers or re-stent.
Yes. Professor B. Krishna Rao, our actually teacher, and we all say that we are bearing his flags. He's the man surgeon, still attending our many of the fellows classes training. He has started the first endoscopic laser in India. But it's again very difficult. Laser is so powerful that if you are not in the exact position, you are going to perforate definitely. So these are ultimately the guideline for management of complication after endoscopy. One, vigilance, should know all the complication. Then you will be only aware that this thing can happen. All rare. All rare. We are doing so many really rarely. But you should know this can happen. Early recognition and prompt action, especially perforation, the worst thing is you have not recognized it. That can cause life. Proper communication with the patient and relative, be present, be frank and truthful and compassionate. And tell them what happened. Don't try to hide it because you cannot hide it, ultimately. Documentation, you write it in your thing that while doing this thing, perforation happened, bleeding happened. So that again, medico-legally, they don't say that you are careless, you are negligible, you have tried to hide it, criminal thing you have done. No, this thing happened. This thing happens in anybody's hand all over the world. So against that unwanted episode, event has happened, and we have tried our best. Investigate properly, appropriately. As I said, the CT scan is needed to see small perforation in chest or abdomen. Involve senior colleagues, always. Or maybe our junior colleagues, those who are good, because when you had something, your brain is not working. Let them come, they are cool, they will do the right thing. And audit outcome measure, that also should be in your 1,000 cases. Here also, as I have heard, you are doing thousands of cases. I do not know, Dr. Gopal is doing the audit of these cases. And they can come up with a lot of publication also, very small things. I think one of the PGs should have been given, one or two, that you please do this thing. Seriously, that can come up excellent things. How many of our, all over the world, many of the international seminar I have given, they cannot do like this thing. Suppose any speaker is there, he has to say this week done so much. What is your, how many perforation you have done? How many bleeding you have? How many after polypectomy bleeding you have? They quote their own statistics always. Seriously, we are lacking. Our generation lacked that one. I request all the juniors don't lack in that. Keep it absolutely updated and give your data. Then only in international good places your words will be given any value. So ultimately, video that we have to trust our whole team. Without team, you cannot do. So team is a very important. You see the man standing there, then you can make out the whole picture, and you can make out that your dependent trust. You have to trust all your thing, everything you cannot do yourself. And you see, he's standing on both banks of the two aeroplanes which are running side by side. So any smallest mistake by anyone, everybody will be out, no parachute, nothing. And then if you can do that, we'll dazzle in the sky like that. So thanks a lot. We have tried our real best to give you all the wholesome idea about the UGI and what we do. Thank you.
Thank you, faculties, for this insightful discussion. It is my pleasure to introduce our chairpersons for the next session, Dr. Manoj Kumar Sethi sir. Sir completed his MBBS and MS in General Surgery from MKCG Medical College, Berhampur, and currently serves as a professor in the Department of General Surgery in the same institution. With extensive expertise in general and laparoscopic surgery, including endoscopy and colonoscopy, he brings a wealth of clinical experience and academic insight. We are honored to have him with us today. May I now invite him to kindly take the stage, sir.
Our next chairperson, Dr. I. Gopal sir, holds multiple esteemed qualifications including MS, FIAS, FAMS, FCGP, EFIAGES, DPAMS, FIGI, and FALS, reflecting his extensive training and commitment to surgical excellence. He is a skilled endoscopic and laparoscopic surgeon with expertise that also includes colonoscopy and advanced procedures like ERCP. He is currently serving as Associate Professor in the Department of General Surgery at MKCG Medical College, Berhampur. We warmly welcome you to the stage, sir.
It is my pleasure to introduce our next chairperson, Dr. Rajendra Kumar Sahu. He completed his MBBS from MKCG Medical College, Berhampur. We are honored to have with us Dr. Gurabhi Ramdas sir. He is currently serving as a professor of surgery in Assam Medical College and Hospital, where he is also actively involved in key national digital health and telecommunication initiatives, including NKN, NMCN, ABAS, NMC, and ABDM. We are honored to have him with us, sir. May I now invite him to kindly take the stage and share his valuable insight on the topic colonoscopy hardware, indications, and bowel preparation.
Munabi, Dr. Desharkar here. He is a co-chairman, co-convener of our National Endoscopy Board this year. Me, Munabi, and Orunima. We are missing you. Good food and everything is very good.
I am missing you too, sir.
Also. So please go on with
Welcome,
your
sir.
Yeah, thank you so much, sir. Sir, am I audible there?
So you're not
Am I audible, sir?
Yes, sir. Yes, sir, you're audible.
I'm audible, sir. So
yes,
can I share my screen?
Yeah, yes, sir.
Okay. Can you see my screen, sir?
Yes, sir.
Thank you so much, sir. So thank you so much, and a very welcome to all the faculty there. A very good afternoon, faculty, my seniors, my teachers, my friends, and all the delegates there. I'm very sorry I couldn't be physically present there because of some preoccupied programs, but I definitely have missed you, sir, Satyapriya Desakar, sir. And I'm sure all of the people who are sitting there down, even when I'm into these courses, I learn a lot. I'm sure all of you will be learning so much so that you can start up your new endeavors into this whole world of endoscopic procedures. So I bring greetings from Assam Medical College, my alma mater. Can you see my screen, sir? Is it changing, sir?
Yes, sir. Yes, we're saying, sir.
Yes, okay.
Eyes posted, sir.
Okay. So I definitely believe that before you start handling the scope, it is essential for all of us to learn the intricate design of the scope and to understand how it functions. Because it doesn't matter how many resources you have, if you don't know how to use them, it will never be enough. So just like my previous speakers way back in the morning, Dr. Srijoy Patnaik sir and Ishwaramurthy sir, they have already talked a lot about the hardware part, and that is the same as in the endoscopy, upper GI endoscope and the colonoscope. So I will be just moving around with these slides. So this is a basic endoscopy tower with the main part, the body is the processor. Then we have different types of endoscopes which can be attached to these processors, and we require an LCD monitor. Of course, suction is a must, and the ancillary equipments like a carbon dioxide insufflator and a water pump, I think they are very essential while doing a colonoscopy. So just like the upper GI, the video colonoscope also has a processor unit, a light source, a colonoscope, and then the monitor system. And different companies have come up with different models. If you are a newcomer and then you're going to buy a new set, I would always suggest go for the full HD set. The Olympus has the 170 and the 190 series, which are full HD. And if you have more money, you can go for the 4K sets, that is the X1 series, which is very new. And this has an advantage of you can use the magnification scopes with these processors. Similarly, the Fujinon also has the Eloxio 8000, which is also, you can use the zoom scopes for better detection and early detection of carcinomas. Now, what does this processor do? So as already explained, when the light from the light source falls on into the cavity and the images are taken up by the objective lenses and are displayed on the charge coupled device. So the charge coupled device, it changes them into pixels, and those are carried by the cables to the processor. Now this processor converts them into video signals, and these are ultimately displayed on the LCD monitor. So these new systems support various types of image processing, including the color enhancement, and you can decrease, I mean, you can put some filters there, and you can use the wavelength of the light that you can filter, like the narrowband imaging, where we use the red filters. We remove the red light so that we can see the subepithelial mucosas and the vessels. And the latest units now, like the X1 series, they're integrated with the light source and come equipped with the LED with a long lifespan of almost 10,000 hours. And they even have a pump that transmits the water in the air. So the colonoscope, just like the upper GI endoscope in the morning, it also has a connector section, which has the air and the water supply connectors and the suction connector. And then we have the umbilical cord from the connector section to the control head. The control head is the brain. It has got both the wheels, and then we have got the valves, and then we have got some switches which are programmable. And then after that, we have the insertion tube. And it is a little bit softer on the tip. So this is the connector section. You can see when you put on into the processor, you can hear a click and you can know that yes, it has been connected. And then this is the umbilical cord. It has got the light guide, the electrical connections, as well as the conduits for air, water, and suction. So the control head, it has got two wheels, two buttons, and then two latches. Now remember, we have already been explained how to hold the control head. and how to steer the wheels. We also have wheel brakes. So whenever you, just like we want to brake the car, we use the hand brake and we pull it towards us. Similarly, these levers can be used and they need to be pulled towards us so that we can maintain the position of the big wheel or the small wheel into a desired position when you're doing a scoping. Yes, the functions of this button is the superior button. Remember, S for superior, S for suction, I for inferior button, and I for insufflation of air as well as installation of water. But this installation of water, this is only for clearing the lens over the scope. It cannot be used for clearing the mucosa of the viscera that you are seeing. The insertion tube in these colonoscopes is different because it is longer. It is the standard colonoscopes that we use are around 133 centimeters long. We of course have more longer colonoscopes of 160 to 180 centimeters. And then just as the upper J endoscope was 9.2 millimeters, this is 11 to 13 millimeters thick. So this is a little bit more thicker on the outer diameter. And channel for the accessories also. Previous, you had 2.8 millimeter channels in the upper GI scope. Now you have 3.2 to 3.8 millimeter channels in the colonoscope. And the end is more flexible than the gastroscope. Now we even have wide angle colonoscopes because sometimes the lesions may be located behind the folds of the colon. So conventional colonoscope, it has the degree of viewing is around 140 degree, but with these wide angle colonoscopes, you can see up to 170 degrees of vision. So the insertion tube is, the coils are similar to the upper GI scope. You had the inner spiral metal band and the outer spiral metal band. But the only difference here is that we have this adjustable wire for stiffness. So this is not there in the upper GI scope. Now this is there present in the lower GI scope so that you can adjust the stiffness of the scope. So what is that? So the distal 40 centimeters of the insertion tube, it is more flexible as compared to the upper GI scope because it is covered by a soft outer polymer. And you can have variable stiffness of the colonoscope by turning a knob. So this knob is present just below the biopsy channel area, and you can increase the tension of the wire that runs entirely through the length of the scope, and then you can increase the stiffness of the colonoscope. This aids while you are navigating difficult areas. If you want the scope not to manipulate too much, then this aids in your colonoscopy. So this is a bending section similar to the upper GI scope. So remember, just imagine the cycle that we used to cycle in our younger days. We had the pulley, isn't it, the pedal? So similarly, when you bend the pedal towards you, the bigger wheel towards you or in an anti-clockwise direction, the scope sees upwards. When we bend away from you or in a clockwise direction, the scope sees downwards. The smaller wheel, when you pull it towards you, then the scope sees left, and when it is away from you, the scope sees right. The end view is similar to the upper GI scope. Of course, the biopsy channel is bigger. The rest of it is almost similar. The function of the suction channel is also the similar. Just remember, for adequate suctioning, you need to close the biopsy channel with the gap. The air-water channels are also similar to the upper GI scope. That has already been explained in the morning. The fundamentals are also similar. The processor always keeps on pushing the air into the scope, but because the knob is open, so the air passes off through the knob. Now, as you just lightly put your finger there, you are closing, not allowing the air to pass, and then it pushes through the valve and goes into the end of the scope. Similarly, the water, it has got a valve, and normally the processor keeps on pushing the water, but now as you press upon the same knob, as you press upon, the valve goes down, and then the water can pass and go to the tip of the insertion. So this already we have talked about. So the objective lens should provide a large field of view and a higher image resolution. But since it is very difficult to achieve both of this with a simple lens, so this endoscope uses multiple lenses to form the images. So we have a diverging lens with a negative focal length, which is needed to maximize the field of view. And then we have a pupil located behind the objective lens to block the extraneous internal reflections. And ultimately, there is an intermediate lens which helps to focus the image on the detector. And an achromat corrects for the chromatic aberrations so that all the colors in the visible spectrum will focus onto the same place on the same plane at the detector. So these are the ancillary equipment that are must, I must say, when you are doing a colonoscopy, because a flushing pump that is aids to your a powerful and controlled flow rate. Sometimes this flow of water is required for when you are doing a underwater viewing or underwater procedure like EUS. And because the colonoscopy is for a longer duration, you need to insufflate a lot of air. So it is always better to have a carbon dioxide regulator unit, because carbon dioxide is rapidly absorbed. It is almost 150 times more faster than conventional air, and that can greatly reduce the patient's pain and discomfort. And you can also obtain a wider view by insufflating enough carbon dioxide. Of course, an energy source is a must. Nowadays, the good energy sources, they already have programmed endocut settings. So that is very well utilized when you are doing some procedures. So this is something, the endocup vision that has been come from Olympus. So these can be attached onto the scope, and they have some tentacles. And while there are different sizes, there is the orange is for the XL, the green is for the large, the medium is for blue, purple for the small. And when you go in, when you do a colonoscopy, you are going in these tentacles, they are closed. But as you try to revert back the scope, then they open up, and then you have a wider field of vision. So this aids because you can manipulate large folds, and when you are doing a loop reduction, the scope can be anchored to the mucosa. And if you are doing a procedure like a polypectomy, this stabilizes the scope and aids in your procedure. So the latest scopes have the responsive insertion technology. So the first thing that have the passive bending or the adaptive bending. What happens is whenever the scope meets any resistance, the pressure is redistributed. So the insertion tube automatically bends to adjust to the contours of the colon, potentially decreasing the patient's discomfort. And we have also something called as high force transmission. So now when you are pushing force or you are putting a rotational torque, this is transmitted in a 1:1 manner, so that the physician handling, and it is easier to maneuver with the colon, and it is more sensitive to the physician. Lastly, we have already talked about the variable stiffness. So all these three lead to a responsive insertion technology. Now we have something called the scope guide, which is by Olympus, or the Colo Assist by the Fuji people. So when you are doing a colonoscopy now, there are some dedicated scopes where you have some electromagnetic coils, and you can see where you are in the colon, and this aids to see whether you have formed a loop, in which part you are, and whether which part your assistant can put a pressure. So this is the transfer receiver, which can be attached to the bed of the patient. And then we have a hand marker also. And then while you are doing, the electromagnetic coils built in along the length of the dedicated colonoscopes, they generate some low pulse intensities. And ultimately, you can see if there is a formation of a loop, and then it can be aided. So these magnetic pulses are used to calculate the precise position and orientation of the insertion tube. So these are the newer innovative technologies. That is this is a altogether different topic. Actually, it will be taken up by Govindra sir. So I will not go into detail about these things. So the newer thing that has come up is the EndoBrain. So here, this is a medical device software where the AI analyzes the endoscopic images taken by the colonoscopy and issues warnings whenever the polyps are detected. So even if you have missed any lesion, the system will tell you. The unit immediately makes an alert with a sound, and then there is a color in the monitor and shows the lesion with a rectangle on the display. So what this has definitely led to increased ADR detection rates. You can see this could have been missed by our naked eye, but it is taken up by the Endo AI. So coming to the room setup, it is just as similar to setting up endoscopy unit. You have the reception area, then we have the consultation room. Very important is the counseling room, because there you will need to counsel about the whatever complications can happen while doing a colonoscopy. And then there is a preparation room. For it is desirable to have a dedicated anesthesiologist in your unit, because you will require sedation while doing colonoscopies. And then we have the recovery room and the decontamination areas. So this room, colonoscopy room, should be a little bit bigger, because a lot of things need to be there. You have the monitoring equipments also, you have the suction, the piped oxygen, and it should be ergonomic. And the position of the endoscopist, the patient, and the monitor, it should be very ergonomic, just like we do laparoscopic procedures. This should also be in a straight line. The facing the surgeon should be, I mean, the endoscopist should be facing the monitor, and then the height of the monitor needs to be adjusted. It can be the height of the patient, or table also needs to be adjusted according to the height of the endoscopist. Only thing is that should be a gaze down view, so that you do not have strain on your neck. Sometimes you may require some additional monitors also if you have, so that it is better for your assistants to view whatever procedure you are doing. So how to store them? Definitely moisture invites infection. So wherever you stay, this should be well ventilated cupboards. You can have the tungsten lights, two of them in your inside the cabinet. So when you put them on, they will keep the cabinet dry. Always hang your scopes vertically. Never store them in closed suitcases, which are provided by the company. Even if you're not using, always hang them. So what are the indications for colonoscopy? The diagnostic indications, like evaluation of lower gastrointestinal symptoms, like patients with rectal bleeding or chronic diarrhea and constipation, patients with unexplained abdominal pain and weight loss, and unexplained iron deficiency anemias, or whenever you have to diagnose inflammatory bowel disease or do an assessment of the disease, detection and even removal of polyps, diagnosis of carcinomas with biopsy of suspicion lesions. And sometimes you have to do some preoperative evaluation if you are going to close some stoma, or if you're going to do some hemorrhoidectomy, or if you're going to do some other procedures like rectopexies and all, you might require to do a colonoscopy. Of course, for colorectal screening, not like the West, we do not have any design programs here, but patients who have a history of colorectal cancer in their family, or patients with FAP, as early as 20 years, you have to do the screening colonoscopies and surveillance colonoscopies. Patients who already you have operated, or you have done previous polypectomies, those patients you will do some surveillance colonoscopies. So therapeutic indications are when you're doing a colon polypectomy, or patients when you need to treat them from bleeding ulcers, or diverticulas or angiodysplasias, or while doing a stricture management for balloon dilatation of the strictures, or even for placement of stents, and sometimes even for foreign body removal. When not to do a colonoscopy, absolute unique contraindications are when you know or suspect bowel perforation, or patients who are having severe diverticulitis. You wait for 1.5 to 2 months, let the diverticulitis subside, and do the colonoscopy then. Also in fulminant colitis and toxic megacolon, you should not do a colonoscopy. Patients with, yes, recent myocardial infarction and severe cardiopulmonary instability, these patients beware. And patients, if you are having poor bowel preparation, better you send them again, ask them to come next day with better preparation. And coagulopathies and bleeding disorders, these patients, remember, it is better do not do any interventional procedures. Coming to bowel preparation, if you are doing only a sigmoidoscopy, enema might be sufficient. But if you have to do a full colonoscopy, you need to do full bowel preparation with isoosmotic agents, or hypoosmotic or hyperosmotic agents. Preferably the isoosmotic agents. We have the high volume polyethylene glycol preparations. If you are using a low volume 3350 PEG preparations, you have to use them with some hyperosmotic agents also. We also have the sulfate-free PEG solutions nowadays. But if you're, this is the most frequently used solution, the peg leg. This is the composition for the peg leg. And if you're using hyperosmotic agents, never use it is better not to use the sodium phosphate agents. So what you do, ask the patient to have a low residue diet for 2 days prior to the procedure and a liquid diet the previous day. You can ask the patient to prepare 2 liters, the whole packet of the solution of the PEG into 2 liters of water, and then have it over 2 hours. And then after that, again, you can ask the patient to have normal fluid, normal water, and then report only after 5 to 10 times of clear watery stools. Sometimes in patients, some split dosing may also be beneficial. And if the patient has chronic constipations or IBDs or left-sided obstructive lesions, you might have to adjust the dose according to the diagnosis also. So remember, a good bowel preparation is the halfway to almost a successful colonoscopy. So this is the Boston bowel preparation skill that we frequently use. We document for the left colon, the transverse colon, the right colon separately. The maximum score is 9, so a higher score indicates a better preparation. Always try to get a score more than 8 or 9. So remember, a safe endoscopy is not an accident, it is always a system. Thank you so much. Thank you, the Behrampur team, for giving me this opportunity. I'm sure this has been a wonderful event. I'm missing all of you. Thank you so much.
Thank you, sir, for excellent talk on colonic preparation, colonic setup, and indications of colonoscopy. Thank you, sir.
Gunabi, we really enjoyed your presentation. Really nice, colorful, and you've taken us to even to the very important advancements happening in colonoscopy. As we know, colonoscopy takes a little longer for people to get the skill set, but I think
Right,
you
sir.
made it. You set the platform such a way so that I can remove some of my slides and go straight to how to do a colonoscopy. Thank you.
Thank you, sir. Thank you, sir. Can I leave now, sir? Yeah, I'm stopping the share.
Thank you so much. Now, on to the next speaker, Dr. Iswara Murthy. We are honored to once again have with us our distinguished speaker, a highly accomplished surgical gastroenterologist with exceptional academic credentials, including multiple FRCS qualification, currently serving as a consultant surgeon and surgical gastroenterologist at Lotus Hospital, Erode. He continues to contribute immensely to the field. We welcome you, sir, for the topic colonoscopic step by step and to outline the list of complications.
Thank you. Thank you for the nice introduction, my dear chairpersons. I think it has been a long day. I've been watching you all, and we started with the lectures, then you moved them all to the live, then again back to the panel and the live. And I don't know whether they had any time for the simulation or any time for the lunch or tea break, but it's been a long innings. Thank you, Gopal. You have done a wonderful job.
Did some live surgeries, and we are eagerly waiting for your coming back, sir.
It's always it was nice because you can see from a distance how well it is going, like a well-oiled engine. It has been going. I think day one itself, they learned so much. I think we have crystallized the whole thing, what they used to learn over many weeks. I think in the next 1.5 days are remaining, the 2.5 days, and they'll be wondering. But it is like what I usually say, any skill set or any particular topic, it is not a destination, it is a journey. Even today, I learned a certain points. So every day we learn. So the delegates and postgraduates should have the mindset, have the passion to perfect whatever they do. Doesn't matter, it's a colonoscopy or playing a cricket, whatever they do. So if they have that passion, like what Satpriyo has, the passion to travel across the country, colonoscopy, I don't know how many number of times he has demonstrated, done, but still the same energy, enthusiasm, either him or Satish Midaji or even Vijay Borkar, I can see still they are sitting. Why they can give the lecture and go away? See, that is the passion. So that is what everything is all about. And my compliments. Just I wanted to, before I share the screen, just a quick, I wanted to say hello to the delegates directly from here to ask them 3 specific questions to put the thing. So if you could turn the camera to the delegate side just for a minute, just if it is possible, just to have an eye contact. just to make it, because I know at the end of the day, it is always very challenging to have the attention span. Hi, how are you, Madhuri? Doing well. And the last batsman is still waiting after me before you go for the well-deserved faculty dinner part 2. Isn't it? Yesterday you had a dinner, today also. So I want to know, ask the how many of the delegates, especially the EFIAGES fellowship category, how many of them are already done more than 25 cases? Either they have done assisted upper GI endoscopy. Please raise your hand. I just want to see how many of you have already done. So I presume, how many of you are sitting there are appearing for fellowship category on Sunday examination? Raise your hand. First, let me see how many of you are fellowship category. And presumably some of the rest are postgraduate, some are faculties, I presume. So out of those, raise the hand. How many of them have handled the endoscopy, upper GI endoscopy before? Please raise your hand, even if it is 5-6 times. Anybody assisted or done a colonoscopy? I can see 1 or 2 half hands are appearing. So it is fine, fine. So, okay, let us go back. So before I just go in, a little intro from Satpriyo, just a couple of words, then I'll share the screen in the meantime. So you can put the set, because I always feel he is the right person to introduce the topic.
Colonoscopy is not like the upper GI that you go like arithmetic, as you are showing morning, all the things. There's each part of the colon has been within the normal variation. There are so many variations, so many pain thresholds, so many type of preparation, so many other things. So very carefully listen to him. After so many years of experience, he was one of the most lucid describer of this very complicated colonoscopy. Try to make it easy. I'm so happy always to work with you and really grateful to you. Our team should do wonder as we are doing. Thanks a lot.
I hope you are able to see my slides. Sorry for the little hiccup I had. I think we should be okay to go now, hopefully. Are the slides visible? Am I audible?
Yes, sir, you're audible.
Okay, thank you very much. Thank you
Slides,
very
sir?
much. Yeah.
How did you get this slide, sir? This is the central part of Berhampur.
Okay, okay.
This one.
Can you just a minute? Can you see my slides now?
Yes, sir. Yes, sir.
Okay, fine. My dear chairpersons, all my faculty friends, delegates, postgraduates, ladies and gentlemen. This is the second innings for me today regarding the steps of colonoscopy, which I'll try to make it a little shorter and sweeter compared to long innings in the morning. Because the colonoscopy, like a colonoscope, is having a long learning curve. You should know you can do about 100 cases of endoscopy, then you'll be itching to do an upper GI endoscopy. Whereas when you do a colonoscopy, even after hundreds, if not thousands, you still feel there is some difficulty. So it is a long learning curve that we need to accept. Next important thing is always you try to reach the cecum however long. Don't look at the watch, how long it takes. Be patient. Try to reach the cecum most of the time. Even though the book describes 95% of the time, you should reach the cecum. For a beginner, even a 75%, I would say, is normal because we should not do any harm while trying to be perfectionist. Most important thing is not reaching the cecum. Listen to me. It is from the cecum, you have to slowly withdraw. Unlike an upper GI, here the mindset is you have to come back from the cecum to anus in the first gear. That is very, very slowly looking at the nook and corner. The reason being very simple. You don't want to miss a so small polyps or a sessile polyps, which is the very reason you are doing a colonoscopy. So the polyp detection rate has to be very high in your practice. And while you're performing, you are so delicate, you should have a zero tolerance to perforation. So if you're able to achieve these 3 or 4 quality in doing a colonoscopy, then everybody in the whole town will say, here is a one good colonoscopist. So you should have and reach the cecum surely, safely, and also don't miss any lesion. That is as simple as that. To have this, it is not only your technique that matters. What matters is to you have the machine also matters. So try to buy a high definition colonoscopy. I'm going to share with you 10 key steps or tips. First step is go and buy a very good high definition colonoscopy. That is the order, whichever company doesn't matter, because it has that narrowband imaging or image enhancement technology. The second thing, as Gunabi rightly said, make sure patient comes to the colonoscopy room only after having given a good bowel preparation. Isoosmotic bowel preparation like polyethylene glycol. You take the powder, mix it with the 2 liters of water, ask them to slowly, surely drink over the period of next 2 hours. Usually they come around 8 o'clock in the morning, nil oral, after having had only liquid diet previous day. 8 to 10 they drink. 10 to 12 they go to the toilet for 8 to 10 times. Then afternoon we slot them in for colonoscopy. That is the right time. So usually it takes about 4 to 6 hours for the whole process to go. It is not in and out as we do in upper GI endoscopy. The dosage varies according to the patient's condition, of course. In a chronic constipation, who goes to the toilet once in a week, 1 sachet of Pegleg may not be sufficient. That is probably by experience, we know where to titrate the dose. The third important thing is you give equal importance to you along with your staffs also, because both standing opposite to me, there is patient, as you can see, it is a very snapshot of my colonoscopy room where I am standing. Actually, in addition to the monitor here, there is a monitor just opposite to me, so that straight line principle. And I'll be facing here, unlike an upper endoscopy, only the back of a patient. This patient will be, my staff nurse will be talking to the patient also, even though he is sedated mildly. And she'll be giving, when I ask her, required suprapubic compression if required. And of course, there is one more staff nurse will help with all the biopsy and other things. So minimum 2 staffs. And if you have a third person, she can sit quietly in a corner, take all the recording and everything. And you need to have all the gadgets ready, available, like a high definition colonoscopy and a CO2 insufflator ideally, because you may never know when you're going to use a diathermy, irrigation device, diathermy machine, and the documentation device, all various sorts of equipments on the backside in the drawer. So it is a very typical, it's not like an OT, but it is more or less like a mini theater you should have. So that is a setup I like to have. And like what I said in the morning, never take the scope straight away. Do the drill, cockpit drill of checking your instruments, then go into the patient, understand the patient. There are two important differences compared to the morning. One, of course, if the patient had, for example, previous anterior resection coming for what I call a check colonoscopy, then you may think, okay, it's going to be easy. You never know whether a patient is having a end-to-end anastomosis or end-to-loop anastomosis, something like that. So you have to read the previous bowel surgery operative notes, then carefully negotiate. Especially in patients with the colostomy, sometimes it's very, very difficult to do colonoscopy. Next, of course, is a bowel preparation. Though it is a job of your staff nurse, you need to ensure that the patient had a very clear bowel movement before you start giving sedation, because unsatisfactory bowel, that means you need to abandon the procedure. You don't want to do it. So that is a two important additional points I want to emphasize. Now coming to the important aspects, I am going to tell you only what I call the technical aspects of doing colonoscopy today. But colonoscopy has a lot of cognitive skill, knowledge it needs. For example, if you see a polyp, how to evaluate the polyp? By just looking at the polyp, can you say, as for the Paris classification, do you know Kudos classification? Can you classify the polyps into various category and what to do with the what polyp? All those knowledge, the theoretical knowledge, one has to have before you go in. And here only it comes the AI. Tomorrow I'm thinking you're going to have another lecture on the AI, because nowadays, the moment you enter the colon, and the artificial intelligence or the endo brain will tell you, this is a case of colitis, or here is a polyp, and this is a polyp is likely to be. So that hard work is taken care of your AI, but that is not an excuse for not knowing that technology. You need to understand all this by reading the books. Of course, technical skills are important. Also, these three important value added addition I told you already. When you have an unclear bowel, probably a little bit of irrigation might help you, or you want to do a water irrigation colonoscopy, it will be immensely helpful. Then a CO2 insufflator, no longer it's optional, slowly becoming essential, because CO2, unlike air insufflation, absorbs very easily. The risk of explosion is zero. And you need to have a custom-made diathermy machine for your examination. Once you have a perfect patient, like good bowel preparation, the theater is set up, consent is there, then it is a way to go. So my fifth tip is 5 golden rules. What are the 5 golden rules? Rule number 1, if you are a beginner, try not to learn this way, even though this has been practiced. I would ask you to learn what I call a 1% technique, like what I said in the morning as an endoscopy. You take hold of the control head with your left hand, and the right hand hold the insertion section like this. Your assistant, most of the time, he only look at the patient and also gives a suprapubic compression when required. Very rarely, he'll bring his left hand here to hold the scope when your right hand is busy controlling the small wheel, something like that. So it is a mutual understanding between these two, but the 95% of the work has to be done by you. So you take the sole responsibility. Any procedure, whether it's a laparoscopy or a colonoscopy, each step has a lot of micro steps. So ideally, you start from the rectum, go all the way to cecum, then come back all the way back to rectum. So this is our navigational drill. To do that, the first important thing is I normally wear a double glove, do a rectal examination to look at the lower rectum, proctoscopy to exclude any piles or fistula, then plenty of lubrication on the scope, then you go into the upper rectum and start going. The signature of the rectum, how do you know it is a rectum? Obviously, you're just inserted. It'll have a classically the valves of Houston. The right, left, right, like that. See, for example, here is the lower, mid, and upper valves of Houston. Once you have that, like 3 o'clock, then 9 o'clock, again 3 o'clock, they'll have. Once you have that, then you go into the sigmoid. So rectum is fairly easy to navigate, but the challenge for the beginner is a sigmoid colon. So see, for example, when you enter the sigmoid is like a winding road. Okay, it is very, very challenging to go through the sigmoid and to order to identify where exactly is the lumen, because your view is around 170 degrees only, and you wish you have not only eyes in the front, eyes on the side or even the back, like a 360-degree colonoscopy, so you know which way to turn. Here it may be little tricky for a conventional colonoscopy, so you go by some important clues. Clue number one is wherever there is a darkness like this, here there is a likely place of your lumen, like here at 10 o'clock, here at 7 o'clock, and even otherwise, wherever there is a longitudinal tinea coli is directing you, that is probably the direction, 12 o'clock. So you know which way to drive. The small wheel, big wheel driving, you learn it in the upper GI endoscopy. After hundreds of upper GI endoscopy, when you come to colonoscopy, it becomes easy. Don't venture into directly, like what open surgeon, they go into robotic surgery. You can't go that analogy here. Ideally, upper GI, then colonoscopy is probably preferable. And what you need to realize here is how to steer. For that, two important things you need to understand. The colon is longer than your scope. In other words, the colon is around 2 meters, for example. Your scope is only 140 centimeter. So there should be some trick to deflate the colon and go into the colon. How we do that? First, we'll see the sigmoid. See, whenever you go into the sigmoid, when you start insufflating, the sigmoid, what is started to be a pelvic sigmoid, slowly ascend like a Mount Himalayas like this, it'll go into becoming like a valvulus, like a small intra-abdominal sigmoid like that. That is a temptation. So how to avoid that? Minimum insufflation. Don't over-insufflate. Rule number 2, try to go one step forward and one step backward. See, like that arrow mark. You always pull, pull, pull. It is not going forward all the time. The third important thing is you do what I call a right hand short steering. That is, you have to clockwise you turn. You have to remember how you drive a screw in the wall. A screwdriver movement is always clockwise, slow and steady. Same movement, when you do that, you move forward slowly like a drilling. So it's like a drilling the sigmoid. Slowly when you go, this is the turning. So steering, you steer like this slowly. So you are able to ascend. Instead of going like this, coming down and go, the whole sigmoid and rectum will be in straight line. When you follow this continuous clockwise torque steering. Because normally the colon has a alpha loop formation. So you need to turn. If you see this, the only way is you have to turn right. Like here, for example, this video is keep on. You can see it is not moving forward. It is rotating, rotating. So that's a way you turn the scope tip opposite direction, this direction to this direction. So that way you avoid this little mountain and go, the whole thing is straight. So whatever is a tortuous, now it has become straightened. So this is the very important learning curve one has to climb. Sigmoid navigation is a tricky one, and you have to see at least 50 to 100 cases to understand how you are able to navigate by torquing. And there are some loops formation also will be there, and how to recognize. So because once you go beyond sigmoid without a loop formation, I think you already won the game. That is a near success. But as I said, there are only two parts in the colon has a mesocolon. One is a sigmoid, another is a transverse colon. So both tend to form loops, they distance. Like for example, because of the mesocolon here, the sigmoid becomes something like intra-abdominal sigmoid, and this retroperitoneal descending colon. So sigmoid descending is fixed here. So in this position, you can imagine if I push here, only the loop will get bigger. I will not make any progress here. So that is called, if I push 1 centimeter, I will not go here 1 centimeter. This is a very typical N loop. Same way, sometimes you have a configuration of like an alpha. So you'll go all the way into the sigmoid, even into the descending colon, but you will get stuck at the splenic flexure region. In this position, even if you push, you will make this little alpha curve even bigger alpha rather than you are making any movement. So if the absence of the tip moving in the monitor, there is no progression. Patient is shouting, the decibel is getting louder and louder, or you feel some stiffness, all this means you are having a loop formation. I think nicely Gunabi has shown you briefly the scope guide, which is nothing but a MRI coil around the scope, which will tell you all this morphology of the scope. But that is a luxury. Not everybody is going to drive tomorrow a Mercedes Benz. So we are all going to have only Maruti. So poor man's Maruti. Can you guess this? Yes. At 40 centimeter from the anal verge, if you 40 centimeter here, you are having a N loop. This happens around 80 to 90 centimeter level. So that is alpha loop. So whatever it is, loop has to be reduced. So loop has to be recognized. Like for example, N loop here, I'm reducing it. Here is alpha loop is reduced. How we do it? Simple pull back. You just keep on pulling back. And here in addition, for the alpha loop, what you do is you watch this picture, you need to do a right hand torquing. So when you do a right hand torquing, and you can imagine this loop becomes straightened and you can pull. So finally it will be like this. See, watch this inferior picture. That is a scope guide. Now it is in the alpha loop position. Tip is in the splenic flexion. Now it is straightened slowly by a right hand torque steering. So this takes a little bit of time for you to understand. Once you conquer this loop, then you can proceed. Sometimes you can change the position also. Left lateral is where we start. Sometimes rectosigmoid junction may be difficult, especially in a woman who had a hysterectomy, for example. So there we may ask the patient to come to supine one more time. Very rarely we change them to other positions like a right lateral or even prone. So these are the positional change, but this by far is the commonest position you start and finish. Suprapubic pressure, I have been telling you from the beginning. This is a very, very simple, effective measure you need to adapt early in your practice. What I mean is, if you allow the sigmoid to ascend abdominally, it is going to make a loop. Why don't you reduce the loop, then put a firm pressure? Not when I say you put, not you, your staff nurse will put her left hand firmly here so that she prevents the sigmoid loop reforming. So this is the analogy here. So why? So this is the picture I'm showing you. Rarely we do a epigastric pressure for a transverse colon, a right loin pressure for a ascending colon, but this is by far the constant one we normally adapt. The sixth is the most important message for the youngsters. There is no definite signpost in colon. For example, I already told you, how do we know that you are in the rectum? Valves of Houston will be there. How do you know sigmoid? Sigmoid is very tortuous. How do we know we are entering the descending colon? It will have a fluid level. And how do we know that we are in the splenic flexure? That bluish discoloration of spleen may be seen. Do we know that we reached the transverse colon? Yes, this typical triangular configuration of transverse colon might help me. How do we know? We know we are very close to the hepatic flexure. The bluish discoloration of liver may be shown there. And how do we know the cecum? We know by seeing some signs. So out of all these things, only the cecum is more definitive. Rest of the things what I said is not absolutely true. So what I'm trying to tell is, unlike an upper GI endoscopy, colonoscopy don't decide where you are unless you are absolutely sure. Because why I'm telling you is, some people have seen only the tumor in the sigmoid, but they thought they have gone all the way to transverse colon. They give a report, tumor at 110 centimeter, 100 centimeter, probably in transverse colon. Then you end up making a wrong diagnosis and a wrong resection you are doing it. So that's why always correlate colonoscopic finding of tumor along with the CT imaging of the tumor. Very, very important for you. Or you do a colonoscopy tattooing. Otherwise, there is no signpost but for the cecum. See, for example, I already told you descending colon means fluid level. Patient in the left lateral position, there will be typical fluid level will be seen. So from a difficult tortuous sigmoid, you are going to a straight like an esophagus, you fly over the fluid level until you reach the what I call the splenic flexure. You will be able to see the splenic flexure with a little bit of bluish discoloration, not always present, but if it is present, well and good. And sometimes there will be so much of fluid in the splenic flexure and acute splenic flexure, you may have to do some extra trick. There are two tricks I can tell you. Trick number one is very simple. That is, ask the patient to take a deep breath in. So the left diaphragm will come for your rescue. The diaphragm comes down, splenic flexure comes down. So that is a one simple trick. The next is shift the patient from left lateral to the right lateral. See, this is the left lateral position. When you go in, you can see because of the weight of all the fluid from the transverse colon, the splenic flexure is hyperacute like this. Very difficult to cross this. Whereas the moment you turn the patient to right lateral, the whole thing changes. See, now the descending colon, splenic flexure here. Now this acute, hyperacute splenic flexure changed to hyperacute hepatic flexure now. So this is the way a positional change also will be a rescue. So if you don't get the desired result, you need to make some changes. The two changes I told you is change the patient to right lateral or ask the patient to breath hold, deep breathe, hold there. Like this, deep breathing. So diaphragm comes down, it pushes the splenic flexure down. So once you have done that, now transverse colon. Transverse colon, even though book says, in my opinion, you can go from one end of the transverse colon, other end in no time. Because the moment you suck the transverse colon, all the air from the transverse colon is sucked. So deflated transverse colon becomes a shorter transverse colon. You go from here to here very quickly just by riding on the suction button. Very often, you will not even push. But if you're having an unlucky day, then you develop one more loop. That is what I call an gamma loop, like this, because it is having a mesocolon, like a sigmoid. So this is a very rare gamma loop. And coming to the hepatic flexure, then into the you descend into the ascending colon. This is what we descend into the ascending colon, and there you see the one of the haustral fold is very thickened. That is the last haustral fold. That is the ileocecal valve. So that you will be able to see from afar, but you need to go very near to do a ileal intubation. So even the hepatic flexure ascending colon is not that difficult, but you need to recognize repeated suction and maneuvering your scope in such a way you reach the final destination for surgeon is cecum, but I would say probably terminal ileum. There are three signatures of cecum. One is a thick ileocecal fold, usually around 7 o'clock position, and the convergence of the rugal, all the tinea coli, that is called the Crowfoot sign or a Mercedes-Benz sign. The third is a biconvex, this what we call appendicular opening. So at least two of the three should be present to be sure that you have reached the cecum. Just merely pressing on the right iliac fossa is not sufficient for you. And normally, this is a very typical ileocecal fold. And normally you'll see like an infant bottom. You'll be able to see a minor depression there. That is the site of the ileal, lumen. But sometimes you may be able to see like a typical inferior lip, superior lip valve like this. But most of the time will be hidden like this. So what do? You go by what I call a bow arrow sign. So this is the one important constant sign we recommend. If you are able to identify the ileocecal valve and also appendicular opening, you just to throw an arrow from the middle of the convexity of the appendicular opening towards the small dimple in the ileocecal fold. There is a direction. Underneath this fold is a hiding ileocecal, valve or the lumen. So you'll be able to see, but ileal intubation is preferable unless you try every case. You end up not having a good ileal, because only then there is surest way that you are reached, because sometimes in a ileocecal valve, and ileum is very important in Crohn's disease and ileocecal tuberculosis. Of course, I told you the importance of withdrawal. 6 minutes minimum you have to take for you to travel all the way back from Sikkim to Anus. Then only then you will be able to identify a small polyp which was missed on the way in. Now we are able to see thanks to the slow and steady withdrawal. The last thing we do in upper GI endoscopy, the last portion we examined was fundus. Here, the last portion is the lower rectum by doing a procedure called retroflexion. See, like a hockey stick. So, if you completely bring the big wheel towards you, push the scope, you will be able to look down on the lower rectum, hypertrophic anal papillae, solitary rectal ulcer, lower rectal tumor, or grade 1 piles. All these things can be easily seen provided you make it as a routine to do a retroflexion in the rectum. Whatever you do, the tip number 9 is the take home message for all of us. Never use force. The force has to be coming from your fingers, not by the grip like a tennis racket. By inexperience or using an excessive force, especially in a pathologically diseased colon like ulcerative colitis or a patient with a previous surgery, you may use some force and end up causing a perforation. Take it from me, a perforation following a diagnostic colonoscopy is as big as a colonoscopy that is 12 millimeter in diameter. So it's quite a huge hole you're going to make. So that has to be rectified either by endotherapy or immediate surgery. Don't wait, it'll seal. Unlike an upper GI perforation, sometimes in the cervical region, we manage conservatively. These perforations are very seldom forgiving. First, try not to get into this trouble. But if there is a perforation, never hesitate. There will usually will be a lot of gas under the dome of diaphragm because you are insufflating so much. But if a patient has a persisting pain, distension of the abdomen after the colonoscopy, it is perforation unless proved otherwise. Keep the patient for 4 to 6 hours. Repeat the examination. Do the CT if required. Never discharge a patient with a suspected perforation. So zero tolerance is the watchword. Finally, how to get this training? Sir, you told me it is a long learning curve. How can I make it short? There is no shortcut for success. It is a practice, practice, and practice. But thankfully, now we have endo trainers like Mikato colonoscopy trainer. I hope it may be available in Berhampur today. If it is available, that is as good as a colon in an adult patient. So you have to spend at least 6 to 10 hours in a Mikato colonoscopy simulator, then in a plastic simulator, then you see 10, 15 cases with experienced audience, faculties there. Then you venture into simple sigmoidoscopy, then left-sided colonoscopy, then full colonoscopy, especially in every hemorrhoids. From tomorrow, if you start doing colonoscopy, slowly you will gain more and more confidence. So this is a glimpse of the Mikado endoscopy simulator. IAG is very proud we acquired it because of its importance in teaching this very important, difficult skill set. And of course, and if you have a time, you go and visit places like IMAST in Mumbai or GSL Medical College in Rajamundry, where they have this symbionics from Israel, where you'll be able to understand what is various types of loops, all these things like pendex and colonoscopy along with the simulation. See, I can see a 3D map of reducing the sigmoid loop, entering the transverse colon, all those things I can teach anybody very easily thanks to this technology. So thanks to the simulators nowadays available, our job as a trainer has come down and our tension and anxiety level also come down. So ladies and gentlemen, I think there is no shortcut. I told you success. You need to buy a good scope, read this book or similar books. Structured colonoscopy training is the order of the day, and you need to have the mindset of passion to perfect and a mentor next to you to handhold and teach you this important skill. So that way you will be able to learn even this more difficult skill. I would usually put endoscopy, ERCP, colonoscopy. I think ERCP sometimes it may be easier than colonoscopy. Don't take colonoscopy lightly, but my best wishes for all of you to learn this also a skill set for your future benefits. Thank you very much.
Hello. Thank you,
Really,
sir.
every time you make it more easier, more lucid, and you are showing that right, beautifully, like drilling it, the screw on
Yes.
the thing. That's a beautiful new point. Rest all are fantastic way is showing, and we have Mikoto here, two Mikoto.
Good, good.
So I've shown there, and all of them are doing. So excellent way they are all having five separate rooms are there, cubicles where they are going and doing, and we'll try to make, as you say, that as many time as possible on the simulators. Thanks a lot.
I watched you all.
When he
Yeah, yeah.
says it looks very easy actually, but it needs a lot of practice.
Yeah.
At least for
Thank you, thank
colonoscopy
you.
needs a lot of practice.
Yeah,
You are
but the
both
way
in the
you
big
arrange the
event.
live.
I'll ask only four of you can get the book because I brought that from Kolkata. So you
Yeah.
decide among yourself who will take this one. So tomorrow we'll distribute those.
I think you arrange the live in a slightly different way, and there are few people standing next, and there are other people behind that chair, and
Yes.
it's nice. They have a good room, so everybody had a view without disturbing the performer and also the patient. I think it is really well arranged. I think each time we are learning a different way of executing the skill, because as
Absolutely.
a surgeon, nothing like going and watching. It is a proof of the pudding is what you preach now, you practice the same day. That's what you've done. I think my appreciation, words of appreciation to the whole team Berhampur under your leadership, Gopal and all your team. I think thank you very much. I missed the whole show, but I really satisfied, able to contribute whatever little we could do from our end. Thank you.
You are
Thank you, sir.
always there, physically, virtually, and mentally.
Thank you. Thank you very much. Thank you.
Thank you, sir.
Thank you, sir. We are delighted to welcome back our esteemed speaker, Dr. Satish Midha, a highly accomplished laparoscopic and GI surgeon and therapeutic endoscopist from Vivekanand Hospital, Ranchi. A respected leader in the surgical community, he has previously served as the president of IEGS and held key leadership role in national and state level. May I invite him to take the stage and share his valuable insight on the topic colonoscopic image atlas.
So good evening. It has been a long day. So I'll rush through because I think at a time our brains get saturated with learning. But anyway, we had a beautiful day. We started with endoscopy. We had discussion on the techniques, and then atlas of endoscopy. We had few cases also. We had one case of colonoscopic demonstration, and that was a good thing. And it became easy because Dr. Gopal was there, so it went quite fast, and it appeared simple that we could reach the lesion within few minutes. But things are not that easy always. So, but anyway, our brain has to know what are the lesions which we are looking for. So I'll just rush through some of the common things which we come across and which we all should know, and by practice, and what diseases are common according to the history of the patients, we look for these lesions. So can we have the slides, please? So colonoscopy, the common diseases which we, again the patients comes with is the bleeding, PR, pain in the abdomen, or we are suspecting some mass. The incidence of colonic diseases is increasing in our country also. Earlier, carcinoma and all this were not common, but now we see a lot of cases coming up. So these are the things which we have already discussed. So we must spend some time on it, and proper training and experience is necessary, so that then only we can embark on this. So these are the common indications: constipation or change in the bowel habits, bleeding per rectum, post polypectomy surveillance, or prevention or aftercare of the colorectal carcinomas, or if there are thickening, many a times is observed during imaging procedures, or sometimes primary tumor search when it present with secondaries. But there are some contraindications also if there is a suspect of perforated intestines or diverticulitis, deep ulcerations, or in severe ischemic necrosis, in fulminant colitis, or in cardiopulmonary decompensations. These are the complications and risks which can occur, which we must be aware of while doing the colonoscopy. Preparations we have already discussed, and this is very important, and we have to discuss. And we must know how our scope is going and what are the common lesions which we expect in what are the areas where we have to look for these, and some may be present throughout, but some may be present in particular area. This normal anatomy, we must have this in mind so that we can recognize. Endoscopy, you know that it's 40 centimeters, so you have gone 40 centimeters, but colon it may be confusing, so maybe paradox. So you might, but anyway, if you have not, maybe you have gone 100 centimeters, but actually you have gone 30-40 centimeters only. So you have, maybe you have formed the loop. So this, while you are going in from rectum to the cecum, the things which we have already been discussed by Dr. Ishwar Murthy. So all this should be in your mind so that you can at least feel. But many times you appear that you have reached cecum, but it's not there. Ileocecal valve, already a landmark, which we all should try to be there in 100% cases. If not, I think 95% of the cases is expected, 94 to 95%. And this is the Mercedes-Benz sign. And NBI should be used if available so that we can recognize these lesions and blood vessels. And these flexures, these are identified by the splenic flexure and hepatic flexure by the discoloration there because of the spleen and liver overlying it. Retroflexion, we showed it today, and we should try to perform it in all cases. These are some of the lesions, diverticula, not very uncommon in our country nowadays because of our changing lifestyles. We do some cases, but in our country, many of them are asymptomatic. But whenever we see them, we must mention them. But we do, nowadays, we do get some cases. These are rectal varices. Can we go back? One more back. Diverticulosis colitis can also be seen in many a times, and there may be signs of inflammation, food particles impacted into it. Polyps, these are the lesions which can be missed. It can be behind the folds also. Many a times you see the polyps because the examination is done while we are withdrawing. So nowadays we have various other types of endoscopes where they have the cameras on the sides also so that they can view the 360 degree, and we can miss some of the flat lesions also. And again, NBI must be used to see these lesions. Polyposis, again, different types can be seen and must be seen. Carcinoma, as we saw today, that was a probably, I think most probably a malignant case. So you'll see these different types of lesions. Some may be presenting with obstructions also. So these must be recognized and reported. And synergetic lesions can also be present. The other two common conditions which we come across are these two, Crohn's disease and ulcerative colitis. The incidence of this disease has increased in last 3 to 4 decades in our country also, and we do quite number of cases, and so much so that many patients having ulcerative colitis have gone surgery for hemorrhoids by some of the quacks also, but bleeding persists. So even just a small history will guide you that what these patients are. The stool is mixed with the blood. If you take properly, probably you will not miss it. Many a times we get a call from our colleagues that I am sending a patient of hemorrhoids, please operate him tomorrow if you can, if you have time. So we ask the patient and tell them then we can't operate, we have to do some test. They become disturbed. Why are they asking for another test? And it comes out to be ulcerative colitis. So mild colitis may be there, severe colitis, pancolitis, and we have to follow these patients, and some they may have pseudo polyps and take the biopsy. Some they may be in pre-malignant conditions also. Crohn's, again, they have characteristics: aphthous ulcer, serpiginous ulcer, cobblestone mucosa, ileal Crohn's. These are the terms. I think slowly you will be knowing more when you see or start practicing with these cases. Some of the rare conditions may be presenting with bleeding, may have angiodysplasia, or especially in our country, radiation colitis or proctitis is very common because many of these ladies are irradiated because of the carcinoma cervix can present with these cases. Then they may have pseudomembranous and ischemic colitis also. These are the ischemic colitis, radiation proctitis, sometimes very difficult to treat also. Juvenile polyps, again, they can be found. Pseudopolyps in ulcerative colitis. Submucosal lipoma, again, we have to resort to other tests like MRI or sometimes endoscopic ultrasound to do these tests. Angiodysplasias. Melanosis coli, again, can be seen. Many of the patients who are using some of these cathartics, especially some Ayurvedic or other preparations, they present with all these things, and it's sometimes difficult to diagnose also. Many of these patients, chronic liver disease patients, they present with the rectal varices, confused with the hemorrhoids. And the treatment is different. Here, if you try to treat them as hemorrhoids, you will land up in trouble, and post-operative these patients bleed profusely. Sometimes misdiagnosed, especially in the peripheral areas, many of the patients present with these problems. And by retroflexion, some of the internal hemorrhoids which are not normally seen can also be detected. NBI, we must be aware so that we can recognize those lesions, especially what we have discussed in the upper GI endoscopy. So we have the increased polyp detection rates. There may be strictures also for various causes. Usually these are malignant strictures, but in our country, tuberculosis is again not very uncommon. We do have many of the strictures due to tuberculosis. We have to take biopsy. Sometimes dilatation is required. Many a times strictures can also occur post-surgery also due to anastomosis strictures that can also be seen. And we can use these. Foreign bodies we do get across. Sometimes if they have gone higher up, we have to do endoscopy and we may have to remove those structures. Many times we do colonoscopy for post-op complications also. This is an anastomotic leak which we can recognize and then treat it by over-the-scope clips also. And we now have some suturing devices also by which these can be repaired. So to diagnose the lesions in the colon, withdrawal time is very important. And various studies have been done, and Dr. Ishwarmurthy said that 6 minutes must be given. So 6 minutes is a very long time. So looking at the clock and withdrawing in 6 minutes is really a tedious task. But studies have shown that even 9 minutes increases further detection of the polyps. And we all are aware that why this detection of polyps is important. especially where screening programs are conducted in Western countries, because these are the small polyps which later develop into the carcinoma. And colonoscopy is more difficult than endoscopy, that has been always stressed, but we should not be disheartened. It takes time, and we have to do practice and get the guidance from our mentors, so that there may be several factors for difficult colonoscopies. Sometimes it may be our skills, patient factors, or a combination of both, which makes the procedure difficult. Some of the patient factors, it may be sometimes more difficult in females, or long tortuous or angulated colon, or previous diverticulate disease, or previous surgery, or adhesions, and then not ideal BMI. It's more difficult in fat, or also more difficult in very thin patients also. The average patients are. So various techniques have been evolved so that we can have the better examination. Also, fluorescence colonoscopy is one of the things. And various studies have shown that we have to have good polyp detection rates. To summarize that, we have to have a good withdrawal time, and then only we can have the better detection rates. And it has been shown that compared to physicians, a study has been done on surgeons, and surgeons prove to be better colonoscopists if they start doing it. So colonoscopy has a lot to offer, because these are our patients, and if we can diagnose them, treat them, and follow them, it will be nothing like that. Thank you very much.
Hello. Thank you, sir. Sir, one thing, sir, like colonoscopy, how about do you have to get like without anesthesia, with local just Jalakan, as we do endoscopy, we can do? Is it advised or not advised? Like many a times we do colonoscopy because, as I've told you today morning, like we are having a difficulty with anesthesia getting.
You see, theoretically, people say that you should do some. In my practice, young patients we can explain them that we are going to start the procedure. If you have intolerance or pain, we will give you some analgesics and sedations. More than 60 to 70% of the patients I get through without drugs also. But in some patients we start with giving IV Tramazac, and then in few of the patients even midazolam is added. But majority of the patients with experience, I can complete the procedures in 15-20 minutes maximum, mostly 5 to 10 minutes. So I think many of these patients will tolerate, and we tell them that you will have some slight pain, slight fullness will be there, because we are injecting some air into it, and slowly you will feel. So majority of the patients will not complain, and they don't also say that it was very uncomfortable to them. So I think if we sedate them, then we have to keep them, admit them, all these things are there. But those who are very apprehensive, then we give them propofol, and we admit them and do it under the presence of anesthetist also. So you should have preparations for all.
Thank you, sir. Anyone, any question? Okay, thank you, everyone. Many of them have already left before we said thank you. But okay, tomorrow morning again, sharp by 8 o'clock, we'll have live surgeries from AIG Hyderabad. So be seated, because they will start in time. And you won't miss from Asian Institute of Gastroenterology. Tell all your colleagues to be at this place so that you can enjoy the best of the information. And on succeeding to that, again, G.V. Rao sir will be there. He'll be giving his lectures, and more importantly, we'll be having our president over here, Govindraj sir will be there. And today we missed one of the lectures. We'll try to accommodate it tomorrow. Find it out. And many of you non-examination category and all will take orals tomorrow itself. We'll finish their orals. And probably if possible, some batches we can take even from the examination category also. Thank you very much.